Good evening, everyone. Hopefully, I'm audible. So please let me know if the audio visuals are clear. For those who don't know me, I'm Dr. Omkar Sangita Dilipra Sonone, and today we'll be continuing with the second part of our surgery revision that we have initiated yesterday. So don't worry about Hindi and English. I'll be covering most of the things in both the languages. Each and everything that I speak in English, I will repeat it in Hindi. Don't worry about that you will be losing out on something. Okay. Yesterday, we have completed general surgery. Now we'll be starting our revision with endocrinal surgery. And endocrine surgery mainly has two important parts from your exam point of view. First is definitely the breast or the mammary glands. And second is what is your thyroid. Once we are done with the endocrinal surgery, I'll be continuing with vascular surgery. And then further, we will definitely move on with GIT, the most major and the vast portion of your surgery. Okay, great. Chalo. Yeah, I will be using both the languages. Okay, so that's important. No issues with this, anybody? Chalo. Let's begin. Okay, don't worry. I'll be using both terms. ठीक है, दोनों language में बात करेंगे. चलो, let's start without any further delay with your today's topic. The first topic that we are about to discuss is the breast. We hope all of you are quite aware. I hope breast is nothing but it is also known as your mammary glands, right? Breasts are also known as your mammary glands. Important is that. Okay, and now breast, usually it is a gland which rests on the chest, mainly on which fascia? So breast is mainly resting on the pectoral fascia. So what is the pectoral fascia? So usually you know this as the chest. Okay, ये तुम्हारी chest है. It is having two important muscles, and which are those two muscles? One is called as pectoralis major, second is called as pectoralis minor, and a fascia or a covering is known as the pectoral fascia. ठीक है, pectoralis major और minor की जो covering होती है उनको बोला जाता है pectoral fascia. And online and above the pectoral fascia we generally have the breast tissue. Okay, over the pectoral fascia we have this pectoral. So this is the pectoralis muscle, this is the pectoralis fascia, and this is what is your breast tissue. No issues with this, anybody? That's important. Okay, now in breast tissue, all of you are quite aware. Please remember over here, this area is what is the erectile tissue of the breast, and this is what is known as your nipple. Okay, so this is the erectile tissue of the breast known as the nipple, and surrounding the erectile tissue we have a blackish area. Okay, surrounding this nipple tissue we have the blackish area, and that is what is called as areola. Okay, और nipple और areola को together क्या बोला जाता है? Nipple and areola together is what is called as NAC, nipple areola complex. Okay, so nipple and the areola together is what is called as NAC, that is nipple areola complex. No issues with this. Now important is the breast tissue. It contains two important kinds of tissue. Okay, breast में there are two important kinds of tissue. दो तरह के tissue कौन से होते हैं breast में? First of all, it contains a lot of ducts. Okay, it contains a lot of ducts. Okay, and these ducts are connected further to alveoli. Okay, so these ducts are further connected to the alveoli. I hope all of you are quite aware. Alveoli का काम क्या होता है? Alveoli, they are responsible for milk synthesis or milk production. Okay, so these alveoli which are there, they are responsible for milk synthesis or milk production. उनका काम होता है milk बनाना. And then this milk is carried with the help of these lactiferous ducts. What are these ducts known as? In ducts को क्या बोला जाता है? These ducts are called as lactiferous ducts. So all of these ducts will open at the level of the nipple. All of these ducts will open at the level of nipple. Each breast has how many lactiferous ducts? So you need to remember that each breast will have 15 to 20 lactiferous ducts. Okay, each breast will have 15 to 20 lactiferous ducts, the red ones that you can see, and these lactiferous ducts, they will carry the milk which is produced by the alveoli, and they will release it at the level of the nipple. No issues with this. So that's the basic function. So these structures, the alveoli plus the lactiferous ducts together, are called as the glandular tissue. Okay, this is what is known as the glandular tissue, and I hope all of you are quite aware. Glandular tissue will be more in which age group? Females. Definitely glandular tissue will be more in reproductive age group females. Okay, that is younger age group females. जो young patient होगी, reproductive age में होगी, उसमें definitely ये glandular tissue जो होगा वो ज़्यादा होगा मात्रा में, because milk production is usually seen in the reproductive age group. But once the patient is aging, that means usually after menopause, so usually postmenopausal females or perimenopausal females will have less amount of glandular tissue. So what will increase then? It will be the fat tissue or the adipose tissue. Okay, so the fat or the adipose tissue increases as the patient approaches menopause. What do I mean by this? जैसे जैसे patient menopause की तरफ बढ़ेगी, glandular tissue कम होता जाएगा और adipose tissue या fat बढ़ता जाएगा. That is what is meant by this. No issues with this, anybody? So that's the basic idea. You need to remember this. Okay. Apart from this, please remember in the breast we also have some ligaments. Why? Because breast is hanging out now. Okay, breast is hanging out, but you can see that breast is hanging out, but it is not sagging down. Okay, it is not sagging down. Why? Because we have some ligaments which support it. Okay, we have some ligaments which support it, and these ligaments are what are called as suspensory ligaments of Cooper. Okay, the ligaments which will support the breast tissue is known as suspensory ligaments of Cooper usually. Okay, so suspensory ligaments of Cooper are present in upper as well as lower part of the breast. दोनों हिस्सों में होता है, but definitely they are majorly they are present in the lower part of the breast. More amount of suspensory ligaments of Cooper are present in the lower part of the breast. No issues with this, anybody? That's the important thing you need to remember. Okay, so important is, please remember, see, I'm again repeating it. The chest, what is there? Okay, this chest is there. It is containing the pectoralis muscles. Which pectoralis muscle? Pectoralis major and pectoralis minor. These muscles are covered by a covering known as a fascia. And what is that fascia called as? That fascia is known as pectoral fascia. Above the pectoral fascia, we have a gland that is known as a mammary gland or the breast. Okay, so in the breast, you have this erectile tissue over here. The erectile tissue which is there, it is known as the nipple. And this nipple is surrounded by a blackish area. That blackish or hyperpigmented area which is there surrounding the nipple, that is what is called as your areola. And this together is known as your NAC, that is nipple areola complex. Now I have told you that breast tissue has two important things in it. Breast में दो चीजें होती है. What are these two important things in a breast tissue? One are called as the glandular structures. One is called as the glandular structure. What is the function or role of glandular structures? The function or role of glandular structure is to produce milk. Okay, and among the glandular structures we have these sacs, small sacs that I have drawn now. These small sacs are known as alveoli. These alveoli are responsible for production of milk. Okay, these small sacs are responsible for production of milk usually, and once they produce the milk, they will drain it into the lactiferous duct. Each breast tissue has how many lactiferous ducts? Each breast, हर एक breast में कितने lactiferous ducts होते हैं? 15 से 20. Each breast will have 15 to 20 lactiferous ducts. And what is the function of the lactiferous ducts? They will carry the milk produced by the alveoli till the nipple. Okay, and then the milk will be ejected outside. Then milk बाहर चला जाएगा from the nipple. No issues with this. So that is the first part of the breast tissue known as glandular tissue. Next part is what is called as fat or adipose tissue. So breast also contains a lot of fat. Important is, I'm saying, if the patient is younger, if the patient is in the reproductive age group, definitely she needs milk production. Therefore, the amount of glandular tissue will be high, whereas the amount of fat will be low in a reproductive age group female or a younger female. But if I talk about a postmenopausal female usually or an elderly female, definitely in that, now that female does not need any milk secretion, therefore the level or the amount of glandular tissue will be low, whereas the amount of fat or adipose tissue will be more in this female. Okay, so that's the basic idea I wanted to talk about. Next important that I've drawn, the purple one that you can see, this ligaments which are there, they are extending from the pectoral fascia till the skin. These ligaments which are there, they are known as suspensory ligaments of Cooper. And what is the role of suspensory ligaments of Cooper? These are known to support the breast tissue. Okay, suspensory ligaments of Cooper are known to support the breast tissue, and they are present more in the lower half of the breast. ज़्यादातर कहाँ होंगे? Lower half में होंगे breast के. So that is what is you need to remember properly. No issues to anybody? So that's the basic idea I had to give you about the breast. No issues. Now a lot of times now we are discussing about what? We are talking about breast lump or the breast cancer. Why it is so important? Because overall most common cancer worldwide is the breast cancer. Please remember, yes, the most common cancer worldwide is the breast cancer. It is even becoming more common than lung cancer. Please remember, most common cancer worldwide is breast cancer. Most common cancer in females worldwide is again breast cancer. Okay, most common cancer in Indian females is also breast cancer. If they ask you about the rural females, then definitely cervical cancer precedes. Okay, no issues with this, anybody? So that's the important thing you need to remember. Okay, so MT workbook, I feel I have shared the PDF in the Telegram group. Okay, the same Telegram group, so you will find it over there itself. Now, if I talk about question, the question says a lady presents to you with a breast lump. Okay, so there is some lump. Lump is nothing else but a mass. Okay, so lump is nothing else but a mass. So a lady presents to you with a breast lump. What will be the best approach for assessment? What is assessment? Assessment का मतलब होता है examination. So how you are going to examine this patient properly if a female is coming to with a complaint of breast lump. So the important thing you need to remember is nowadays if a female comes to me with breast lump, definitely the best method of assessment is what is called as triple assessment. The best method of examination or assessment is what is called as triple assessment. तो मैं क्या करूँगा? Triple assessment करूँगा इस patient में. And what are the three important factors or three important things that I do in a triple assessment? मैं तीन चीजें करता हूँ इस triple assessment में. And what are those? The first important thing that I like to do in this female. Okay, so important is English I'm saying each and every word in Hindi too, please remember. Okay, now important is please remember the first thing that I do in triple assessment. Okay, जो सबसे पहली चीज करता हूँ मैं triple assessment is what? First is history taking. I will first of all ask the patient when did the breast lump appear. Okay, what were the initial complaints, then how much it grew in size. Okay, तो कितना बढ़ा size में, कब से है. Okay, if you have pain or not, all of these complaints and all of this history of the breast lump I'll ask to the patient. Along with history, the second thing that I do is clinical examination. So history taking and clinical examination is first part of examining a breast lump. So history taking and breast clinical examination is the first part of triple assessment. The second part of triple assessment you need to remember is radiological investigation. The second part is known as radiological investigation. So once I definitely take history of the patient, once I clinically examine the breast lump, okay, I will palpate the breast lump properly, and then I will go for a radiological investigation. In radiological investigation, it is important to remember that if the patient is less than 40 years of age, if the patient is less than 40 years of age, then definitely I will prefer using a ultrasound in this patient. If the patient is less than 40 years of age, that means a young patient, so I will prefer using a ultrasound. The reason is what? As I've told you, if the patient is young, agar patient young hoti hai, that means the patient is in the reproductive age group, the patient will have high amount of glandular tissue. And if there is more glandular tissue in the breast, definitely the mammography which is there or the x-ray which is there, it will not be so much clear. Okay, that's the reason why in a younger female less than 40, definitely I will prefer ultrasound. But if the patient is more than 40 years of age, I will definitely prefer mammography. What is mammography now? Mammography is nothing but x-ray of the breast. Okay, so mammography का मतलब होता है x-ray of the breast. That's what you need to remember. Then once I am done with the radiological investigation, एक बार मैंने radiological investigations कर लिए, the third part of examination is definitely the histopathological examination. The third part is histopathological examination. What do I mean by histopathological examination? I will take some part of this breast lump and I will send it to the pathologist. For examination. That is what is called as histopathological examination. Histopathological examination can be done with the help of two things. Either I'll go for a FNSE. What is FNSE? Fine needle aspiration cytology. Now the word itself says cytology. Cytology matlab it will only contain cells. Okay, so FNSE में हमें क्या मिलता है बस? FNSE will only have cells in it. Okay, whereas if I need a proper tissue, then I need to take a true cut biopsy. Okay, so true cut biopsy mein I will not get only cells, but I will get a proper tissue. And if I get tissue, definitely the examination will be much better. Okay, the examination can be much better. So important is true cut biopsy is considered as the investigation of choice. Okay, true cut biopsy is considered as investigation of choice in cases of breast lump or in cases of breast cancer. No issues with this, anybody? So that's the important thing you need to remember about the triple assessment. Now I've spoken about History taking. So history taking will be the same. Definitely you will ask the patient about the presenting complaint, then you will ask about history of the present illness, then you will ask about any past history in the patient, okay, past medical history, then you will ask about the personal history of the patient, you will ask about the social history of the patient, okay, addiction history, then you will definitely ask about the family history of the patient. That means if any of her first degree relative, what do I mean by first degree relative? Usually her sister, mother, okay, so usually any one of them do not have a breast cancer, okay. So I will ask about the proper family history. So all of that will be done in the history taking. Clinical examination mein there are various methods to clinically examine a breast lump. But if they ask you what is the best method for clinical examination, if they ask you the best method for clinical examination of a breast lump, I will start in the center and then I will go outwards, okay. I will start with the lump and then I will go outwards. मैं सबसे पहले start करूँगा center से and definitely then I will go outwards. The best method is known as dial clock method. The best method is known as dial clock method. So for clinical examination, the best method that I have is dial clock method. That means I'll start from the breast lump and then I'll keep on palpating outwards and outwards and outwards. That is what is called as dial clock method. Please remember. Okay, so कब करना होगा triple assessment? As we have discussed in the question itself, when a patient complains of a breast lump, जब patient तुम्हारे पास एक breast lump से आती है, a breast mass she is complaining of, that time you need to go for a triple assessment. That is an indication of triple assessment. No issues with this, anybody? That's important. Now, once I am done with the clinical examination, I need to talk about the radiological investigations. Okay, I need to talk about the radiological investigations. So if I talk about radiological investigation, definitely a better radiological investigation is a mammography. Okay, it is always a mammography, that is an X-ray of breast. But the problem is, as I've told you, if there is more glandular tissue in the breast in a younger female, then mammography will not be so much clear. And that is the reason why in younger females, we prefer using ultrasound. No issues with this, anybody? That's important. Then, if I talk about FNSC and true cut biopsy, important is, please remember, I'll talk about screening. I'm right now talking about only triple assessment when a patient is coming to me with a breast lump. Okay. In FNSC, definitely, what is the size of the needle used? Now, the name itself mentions fine needle. So, I need to use a very fine needle, okay, with a very narrow diameter. And that is usually, I hope, yesterday we have discussed, as the number of the gauge increases, the diameter decreases. So, we need a larger number of gauge. That means usually we use needles between 22 to 30 gauge. Okay, so for FNSC, that has been a question. We use needle between 22 to 30 gauge. Whereas on other hand, for a true cut biopsy, the better needles which are used are 8 to 18 gauge. For true cut biopsy, definitely we need more amount of tissue, and as we need more amount of tissue, we need a larger needle, and therefore we use a smaller gauge, that is what is 8 to 18 gauge. Please remember, okay, so that's important. And the best one to be used among the 8 to 18 gauge needles, the best one to be used is the 16 gauge needle. The best one to be used is a 16 gauge needle. So breast lump अगर नहीं है, the patient will not come to you. बेसिक ये आइडिया मुझे बता दो, अगर ब्रेस्ट लम्प पेशेंट में है ही नहीं तो पेशेंट तुम्हारे पास क्यों आएगी, ये बताना जरा. तो जो नहीं है उसके लिए ट्रिपल असेसमेंट नहीं करते, उसके लिए हम स्क्रीनिंग टेस्ट करते हैं. आई एम कमिंग टू दैट. प्लीज रिमेंबर, आई एम कमिंग टू दैट. ओके वेट, ट्रिपल असेसमेंट 3 चीजें करनी है, बहुत महंगी होगी, तो अगर किसी पेशेंट में कोई कंप्लेंट नहीं है तो उसमें तीनों चीजें नहीं करवाओगे. Okay, you will go stepwise, right? You will go for a screening test. That's the basic idea. If a patient is having a complaint, then you will go for diagnostic test. But if a patient is not having any complaint, on healthy individuals, we do not go for a diagnostic test. We will go for a screening test. That's the basic difference between a screening test and a diagnostic test. You might have studied it in PSM as well, right? Diagnostic tests are done for patients with complaints. Patients who do not have any complaints, that means healthy individuals. In May, we will go for a screening test, which will help us make the diagnosis early in course. That's the important thing. So if I talk about screening, that means a patient who is not having any kind of breast lump, a patient who is not having any kind of breast lump, but she's having some family history of breast cancer. She's having some family history of breast cancer, or there was some gene mutation like a BRCA gene mutation, which is commonly associated with breast cancer. Okay? So that's the reason why she wants to undergo a screening test. Or even a normal patient can also want to undergo a screening test, because as we know, the incidence of breast cancer is increasing nowadays. Therefore, every female wants to undergo a screening test. As in cervical cancer, we go for a pap smear. In breast cancer, we go for various screening tests. And what are those screening tests? They are definitely the radiological investigations or the imaging techniques that we use for screening in a case of breast cancer. Okay, so if the female is less than 40 years of age, for screening also, we will prefer a ultrasound. So if a female is young, less than 40 years of age, we will prefer a ultrasound in this patient for screening. Then if a patient is more than 40 years of age, then for screening, definitely a better investigation, I've already told you, it is a mammography. It is definitely a mammography. Now there's nothing but an X-ray of the breast. Then if they say screening test of choice for a pregnant female, now we know that mammography is an X-ray, and X-ray exposure or any kind of radiation exposure is avoided during pregnancy due to the teratogenic side effects. That's the reason why during pregnancy we will prefer using an ultrasound for screening. Okay, during pregnancy we prefer using an ultrasound for screening. Next is if a female is there with breast implants. Now if a female is having some kind of breast implants and she wants to undergo a screening test, okay, definitely if a female is having breast implants, usually these are silicone gel wala breast implants. Now it is very difficult to pick up any kind of breast lump or any kind of lesion if a patient is having a breast implant with the help of an ultrasound or a mammography. So in cases of breast implant, we need a better investigation than ultrasound and mammography, and that what you need to answer it as MRI. So if a female is having breast implants, the better screening test of choice will be a MRI. Okay, the better screening test of choice is a MRI. If there is a high risk female, what do I mean by a high risk female? High risk female, that means a patient who is having a family history of breast cancer. Family history matlab, as I've told you, first degree relative of a female is affected with breast cancer. That is either her mother or her daughter, okay, or her sister. They are affected with breast cancer. So that is family history. Or if the patient is herself having BRCA gene mutation, and we know BRCA gene mutation is commonly associated with breast cancers. So definitely if the female is herself having BRCA gene mutation or somebody in her family is having BRCA gene mutation, then that patient is also considered as a high risk female for breast cancer. So if a patient is high risk female, definitely the screening investigation of choice is again a MRI. So if a patient is a high risk female, the screening investigation of choice is a MRI. So these are the screening tests of choice. Less than 40 ultrasound, more than 40 mammography, pregnant female ultrasound, female with breast implants MRI, and a high risk female MRI again. No issues with this, anybody? So that's the basic thing you need to remember, guys. Okay. Next, if I talk about the mammography, I hope all of you are quite aware, as I've told you, mammo is nothing but X-ray of breast usually. Okay, mammo is nothing but X-ray of breast. And as I've told you that mammography is considered as the best screening method. Why? Because it is cheaper. MRI is way too expensive. Okay, so it is only used in females of breast implants or in high risk females. In all other females, we prefer using a mammography. Definitely exceptions being a pregnant female and a younger female. Okay, so otherwise the best screening method is always a mammography. Okay, and when is screening usually started? So screening is generally started in a patient at 40 years of age. Okay, therefore mammography is preferred. Screening in a normal female is usually started at 40 years of age. In cervical cancer, you might have studied, it is started after 3 years after the first sexual intercourse, or it is started at 21 years of age usually. But here the screening of breast cancer is generally started at 40 years of age. And what is the frequency? कितनी बार करोगे साल में? एक बार. Okay. So usually you prefer doing mammography annually. That means once in a year. Okay. So that has to be remembered. Please remember that. Okay. So after 40, it is started, and mammography is the preferred technique, and it is done annually. That is once every year. No issues with this, anybody? That's important. Then if I talk about the mammography, it is done in two views. One is called as the craniocaudal view. Okay, one is called as the craniocaudal view. Second is called as the MLO, that is mediolateral oblique view. Second view of mammography is called as MLO, that is mediolateral oblique view. Mediolateral oblique view definitely covers more amount of breast tissue. Why? Because it also covers the breast tissue which is lying in the axilla. Okay, so please remember, this mediolateral oblique view जो है वो better है. क्यों better है? Because ये ज़्यादा हिस्सा cover करता है breast tissue का. It also covers the breast tissue जो axilla में होता है. So you will say, sir, do we have a breast tissue in the axilla? Yes, we do. Okay, so please remember, there is a part of breast in the axilla, and this part of breast in the axilla, this part is what is called as the axillary tail of Spence. The part of breast tissue which lies in the axilla is what is called as axillary tail of Spence. Okay, it is known as axillary tail of Spence. Okay, no issues with this, and that you can see over here. So this is the axillary part of the breast tissue. It is the axillary part of the breast tissue. Please remember this. No issues with this, anybody? Hopefully you have understood that. Okay, so MLO is considered as a better view, but once we do a mammography, we get both the views done. Okay, we get both the views done. Agar better pucha, to answer should be MLO. Now on mammography, we can see two kinds of finding. First picture that you can see over here, the first picture that I'm highlighting over here, this one. Okay, is it a benign lesion or a malignant lesion? So important is, you can see a breast lump which has been highlighted with the help of the white arrow. This breast lump which is seen in the first image, you can see it is having well defined margins. Okay, so it is having well defined margins, first thing. Second, there is a halo around the lesion. Okay, there is a halo surrounding the lesion. Around the lesion there is a halo. And third important, here we can see it is white. Why it is appearing white? Because the breast lump is undergone calcification. क्या हुआ है उस breast lump में? Calcium deposit हुआ है. इसीलिए therefore the breast lump is appearing white. Okay, it has undergone calcification. Now it is a big calcification or a small calcification. Now we know it is a bigger calcification, and bigger calcifications are called as macro calcifications. Bigger calcifications are called as macro calcifications. And we know if it is having well-defined margins, there is a halo and macro calcifications, definitely the first image is suggestive of a benign lesion. Very good. Okay, the first image is suggestive of a benign lesion. Very good. Whereas if I compare it with the second image over here, if I compare it with the second image that I've highlighted right now, this one, as you can see, the white arrow is highlighting the lump over there, and this lump is having which kind of margins? Definitely there you can see there are irregular and spike like margins. Spike jaise dikh raha hai na? So these are irregular spiculated margins. Okay, so in the second image you can see there are irregular spiculated margins which are seen. Next important, you can see the architecture. Okay, so architecture hai, that is completely destroyed over here. So there is an architectural distortion. There's an architectural distortion which is seen usually in the second image. And third important, there is micro or macro calcification. So you will say हमें बड़ा calcification दिख रहा है. We can see a larger calcification. So it is not actually a larger calcification. There are very small calcifications which have fused together. बहुत सारे छोटे छोटे calcifications है जो एक साथ आके fuse कर गए, इसीलिए तुम्हें लग रहा है कि बड़ा calcification है, but it is not. So these are very small calcifications which are coming together. So definitely it is a case of micro calcifications. And we know if there is irregular spiculated margins, definitely with architectural distortion and micro calcifications, it is a feature of a malignant lesion. So that is what is suggestive of a malignant lesion or a cancer. So that's what you need to remember. Macro calcifications are seen in a benign lesion, whereas micro calcifications are seen in a case of malignant lesion. No issues with this. Popcorn is an example of a macro calcification. Please remember the popcorn calcification that you can see. Okay, the popcorn calcification is an example of a macro calcification, and we know popcorn calcification on mammography is seen in which condition? Popcorn calcification in mammography is seen in the fibroadenoma. And what is fibroadenoma? A benign breast tumor or a malignant breast tumor? All of us are quite aware fibroadenoma is nothing but the most common benign breast tumor. It is the most common benign breast tumor, right? So now you can see that macro calcifications like the popcorn calcification, they are usually seen in cases of fibroadenoma, which is a benign breast tumor. No issues with this, anybody? That you need to remember. Now just answer me. I'm asking you integrated questions. So popcorn calcification on a chest x-ray is a feature of. Answer that in the chat box. Till that time I'll move further. Popcorn calcification on a chest x-ray is a feature of. Okay. So moving further now. Once I've spoken about the mammography, definitely. Okay. And I've talked about all the other imaging techniques that we generally use to screen a breast cancer, or in cases of assessing the breast lump also. Okay, that is in triple assessment. Now moving further, talking about a very important topic, and that is breast cancer. Now talking about breast cancer. Okay, very good Raja, very good Priyanka. Okay, so all of you, important is very good. Popcorn calcification on a chest x-ray is definitely a feature of pulmonary or a lung hematoma. That's very important. Very good all of you. Now important is just answer one of my questions. Okay, just answer one of my questions, guys. Important I will like you to answer is, Please remember, as we are going to talk about breast cancer in a patient, okay, we are going to talk about breast cancer in a patient. What are the most important risk factors in a case of breast cancer? What is the most important risk factor in a case of breast cancer? The most important risk factor. Okay, I will write a statement and then it will become much easier for you to answer. So breast cancer, I will write it as hormone driven cancer. What do I mean by this statement? Breast cancer is a hormone driven cancer or hormone dependent cancer. That means if there is increase in level of a specific hormone, definitely there will be more stimulation of the breast and there will be more cell division in the breast, which will lead to malignancy or cancer. Okay, which will lead to more malignancy or cancer. And what is that hormone which causes stimulation of the breast tissue so that the breast tissue proliferates too fast और there is more and more cell division in the breast? कौन सा हार्मोन है जो breast tissue को stimulate करता है so that the breast tissue rapidly divides and forms a cancer? Okay, so important is I have written hormone driven cancer na, so I am asking you about the hormone. Okay, I am actually asking about the hormone. Smoking, please remember, smoking is not considered as the most important because smoking is usually a risk factor in younger females, but it is found to be protective in elderly females or post-menopausal females. So smoking is plus minus always for breast cancer. Very good, it is estrogen. Very good, it is estrogen. The excess amount of estrogen is known to stimulate the breast tissue so that it keeps on dividing rapidly and that forms a cancer. Okay, so any condition where there is hyperestrogenemia, and that has been asked a lot of times or a number of times in your exam. Hyperestrogenemia. And what are the conditions where there will be excess amount of estrogens in your body? Definitely estrogen is released when? Definitely more amount of estrogen is released during menstrual cycles. Therefore, if a patient is having more number of menstrual cycles in her life, ओके एक पेशेंट को अगर ज्यादा मेंस्ट्रुअल साइकिल्स हुआ है उसकी जिंदगी में तो उसमें एस्ट्रोजन एक्सपोजर ज्यादा हुआ है, therefore the patient is at a higher risk of developing breast cancer. Okay, so if a patient is exposed to estrogen for a number of times, that means the number of menstrual cycles were more, definitely her risk for breast cancer will also be more. So usually they will give you important statements, and that is early menarche. What is menarche? Menarche is starting of menses. So if a patient started a menses at 8 years of age, definitely a number of menstrual cycles were more, and definitely exposure to estrogen was more, and definitely the risk of breast cancer is more. Next is if a patient was having late menopause. What is menopause? When the menses will stop. Okay, so if a patient is having menopause at around 57 years of age, definitely the number of menstrual cycles were more, the exposure to estrogen was more, and definitely the risk of breast cancer was also more. And that has been a very common question in your exam. Very common question. Please remember that. Okay, apart from this, definitely obesity is an important risk factor. Why obesity is an important risk factor? This I will like to explain because we are trying to manage the patient accordingly. Obesity, if there is obesity in a female, there is more amount of which tissue? There is more amount of adipose tissue, or there is more amount of fat, and that fat tissue contains an enzyme. And what is that enzyme known as? That enzyme is known as aromatase. Now what is the important reason of aromatase? Aromatase will convert estrogen to aromatase will convert androgens to estrogen. Okay, androgens are converted to estrogen with the help of this aromatase enzyme. So if a patient is obese, there is high amount of adipose tissue, therefore there is more amount of aromatase, therefore more and more androgens will be converted to estrogen, and there will be excess of estrogen in the patient causing breast cancer. ठीक है, very good. Nulliparity is also one of the risk factors. Why nulliparity? Nulliparity, that means the patient was never pregnant. वो फीमेल कभी प्रेग्नेंट ही नहीं हुई है. तो अगर वो पेशेंट कभी प्रेग्नेंट ही नहीं थी, उसको ब्रेक मिला क्या मेंस्ट्रुअल साइकिल से? नहीं मिला. So once I'll explain it in Hindi and then in English. Please remember, अगर पेशेंट प्रेग्नेंट होती है तो उसको क्या होता है? उन 9 महीनों में मेंस्ट्रुअल साइकिल्स होता है क्या? नहीं होता है. इवन आफ्टर प्रेगनेंसी लैक्टेशन जो होता है, लैक्टेशन में भी उसको एमेनोरिया होता है, मतलब मेंसेस नहीं होते. सो शी गेट्स अ लॉन्गर ब्रेक फ्रॉम मेंसेस, एंड अगर ब्रेक मिलता है मेंसेस से तो ईस्ट्रोजन का एक्सपोजर भी नहीं होता उस टाइम में, एंड दैट्स द रीजन व्हाई द पेशेंट विल हैव डिक्रीज रिस्क ऑफ ब्रेस्ट कैंसर. नाउ आई एम रिपीटिंग इट इन इंग्लिश. Important is if there is a nulliparous female, that means a female who was never pregnant. Now she will be at a higher risk of developing breast cancer. Why? Understand it. Please remember, if a patient was pregnant and after that she was lactating or she was breastfeeding. At this time usually she was not having menses, and if she was not having menses, she was having very low levels of estrogen during that time. And if there is low levels of estrogen, definitely she got a break from estrogen exposure, and that's the reason why she will have a low risk of breast cancer if the patient is pregnant or if the patient has lactated. Whereas if the patient was never pregnant, if the patient is a nulliparous female, definitely the risk of breast cancer will be much higher. That you need to remember. No issues with this, anybody? So these are the important risk factors. Okay, so please remember, nulliparity is a risk factor, but multiparity is a protective factor. Pregnancy, protective factor. Lactation or breastfeeding, protective factor. Okay, so these are the important things I need you to remember. Then definitely we know that, please remember, family history is a very important risk factor again. If she's having her sister, mother who is having breast cancer, the risk of her developing a breast cancer is also very high. कि अगर उसकी माँ या बहन में अगर ब्रेस्ट कैंसर है तो उसमें भी ब्रेस्ट कैंसर होने के चांसेस बहुत ज्यादा बढ़ जाते हैं. दैट्स इंपॉर्टेंट. नाउ another risk factor for breast cancer is definitely genetics. And if I ask you about the gene mutations, okay, if I ask you about the gene mutations, important is, please tell me, breast cancers are more commonly familial or they are sporadic? More commonly breast cancers are familial or sporadic? Okay, I'll talk about that as well. Please remember, Shanmukh Priya, overdose of estrogen pill. Usually, not one-time exposure of estrogen is going to cause breast cancer in the female. A prolonged exposure to excess of estrogen is going to cause breast cancer in a female. Okay, so usually hormone replacement therapy, when excess of estrogen is given to the patient, that will definitely cause breast cancer. But low dose OCPs, as they are in very low doses, only there is 30 micrograms of estrogen in a low dose combined oral contraceptive pill. Therefore, low dose OCPs are not considered a risk factor for breast cancer. That you need to remember, as they are having it in very low amounts. Very good. So important is, sporadic is much more common. Okay, so 90% of the breast cancers are sporadic in nature, whereas only 10% of the breast cancers are familial. What do I mean by familial? A breast cancers which runs in the families. That means agar maa mein tha to beti mein bhi hoga, to definitely poti mein bhi hoga. That means if a mother was having breast cancer, her daughter will also get it, and her granddaughter will also get it. That is what is called as familial. Now, if they ask you which is the most common gene mutation in sporadic breast cancer, the most common gene mutation in sporadic breast cancer is P53. That's the safest answer. The most common gene involved in most of the breast cancers, most common gene involved in most of the cancers in the body, most common gene involved in most of the cancers of the body is your P53 gene. But if they ask you which is the most common gene involved, in familial breast cancer, if they ask you which is the most common gene involved in familial breast cancer, then your answer should definitely be BRCA1 followed by BRCA2 gene mutation. Okay, then your answer should definitely be BRCA1 followed by BRCA2 gene mutation. No issues with this. So sporadic breast cancer, most common is P53, but familial breast cancer, more common is BRCA1 followed by BRCA2. Very good. Moving further, now if they ask you which is the most common site of breast cancer, so the most common site of breast cancer we know. If I divide this breast into 4 quadrants, the most common site of breast cancer is usually this one. And what is this? This is the upper outer quadrant. Okay, it is the upper outer quadrant. And least chances, so upper outer quadrant is the most common site for breast cancer, whereas this one, that is lower inner quadrant, completely opposite to it. Lower inner quadrant will be the least common site for a breast cancer. Okay, lower inner quadrant is the least common site for a breast cancer. Very good. Okay, that has been a common question in your examination. So please remember that upper outer quadrant is the most common site, whereas lower inner quadrant is the least common site. No issues with this, anybody? Now please answer which is the most common type of breast cancer. I'll just tell you. Now, what did I tell you? There is glandular tissue in the breast. Okay, and please remember, breast cancers mainly arise from the glandular tissue. Why? Because estrogen is not going to stimulate the adipose tissue or fat. Estrogen is going to stimulate the glandular tissue itself. And the glandular tissue had 2 parts in it. One were the lactiferous ducts, and second were the lobules. You will say, sir, आपने तो alveoli बोला था. Definitely I said alveoli, but alveoli are nothing else but they are a part of these lobules itself. Okay, alveoli are a part of the lobules itself. Okay, so that's important thing. So now if the breast cancer arises from the lactiferous ducts, it can be called as either ductal carcinoma in situ or it can be called as invasive ductal carcinoma. It is called as DCIS, that is ductal carcinoma in situ or invasive ductal carcinoma. Whereas if it arises from the lobules, then it is called as lobular carcinoma in situ or invasive lobular carcinoma. If it arises from the lobules, it is called as lobular carcinoma in situ or invasive lobular carcinoma. Yes, definitely adenocarcinoma will be more common because breast is a gland and we know glands are responsible for secretions. And what is breast responsible for? Which kind of secretions? Milk. And wherever we need any kind of secretion in the body, the epithelium that we have is known as columnar epithelium, and the cancer which arises from the columnar epithelium is what is the adenocarcinoma. Therefore, definitely any gland in the body, like a breast gland also, will have adenocarcinoma itself. Okay, so it is a adenocarcinoma. If I talk about the subtypes, as I've talked about, these are the 4 subtypes. If it arises from lactiferous ducts, it can be either DCIS or IDC, or if it arises from the lobules, again it can be LCIS or ILC. Important is, you need to remember one thing. Please remember, what's the basic difference between carcinoma in situ and invasive cancer? Now, all of you are quite aware, this is the basement membrane and these are the columnar cells. Okay, so we have the basement membrane and columnar cells. If the cancer which arises is only above the basement membrane, if the cancer is only above the basement membrane, it is called as carcinoma in situ. Okay, if the cancer is only above the basement membrane, it is called as carcinoma in situ. But when the cancer starts invading the basement membrane, when the cancer goes below the basement membrane, when it starts invading the basement membrane, that is what is called as the invasive cancer. That is what is known as invasive carcinoma. That's important. Okay, so you need to remember that. Chalo. If I talk about the most common type of breast cancer now, you need to remember the most common type of breast cancer out of all of these is the invasive ductal carcinoma, IDC. The most common type of breast cancer is usually IDC, that is invasive ductal carcinoma. Okay, it is not DCIS. Please remember, it is IDC, invasive ductal carcinoma. Please remember that. Okay, so it is invasive ductal carcinoma. It is most common. Please remember that. If I talk about LCIS now, according to the recent 8th AJCC update that we have, LCIS, that is lobular carcinoma in situ, it was found that it does not invade only the basement membrane. Okay, so yaad rakh lo, LCIS jo hai, according to the recent 8th AJCC update, it is not considered a cancer or a malignancy anymore. LCIS is not considered a cancer or malignancy anymore. It is nowadays considered as benign lesion. It is considered as a benign tumor nowadays. Okay, so lobular carcinoma in situ, this is the recent update. It is considered as a benign tumor. Please remember that. Okay, therefore here the treatment will only be observation and follow-up of the patient. Okay, so here the treatment will be observation and follow-up. No issues with this. That's the important thing you need to remember about the update. Okay, then if I talk about the special variety of breast cancer, and that special variety is what is this? That is the invasive lobular carcinoma. If I talk about invasive lobular carcinoma, okay, in invasive lobular carcinoma, the gene mutation which is commonly associated is known as E-cadherin gene mutation. The gene mutation commonly seen is E-cadherin gene mutation in invasive lobular carcinoma. And if I talk about the histopathological examination, what do I mean by histopathological examination? Biopsy in short. Okay, so if I talk about the histopath examination, it will characteristically show this type of appearance. Kya dikh raha hai is biopsy pe? You can see a characteristic appearance where the malignant cells are aligned one behind another. Malignant cells कैसे लग रहा है कि एक के पीछे एक खड़े हो लाइन में, ठीक है? So they are seen as if these are the files in a government office in India. ठीक है? So therefore this pattern in a case of invasive lobular carcinoma is called as single file pattern. It is known as the single file pattern or the Indian file pattern. So that was a question which has been asked, that single file or Indian file pattern on histopathological examination is suggestive of which breast cancer? Now you know the answer. It is suggestive of ILC, that is invasive lobular carcinoma. It is suggestive of invasive lobular carcinoma. No issues to anybody. So that's the basic thing that I wanted to discuss with all of you. Important is, if I talk about the breast cancer, please remember, if I talk about breast cancer, if I talk about the staging, yaad rakh lo, now a lot of people have the question ki, sir, do we need to remember staging for each and every cancer? No, please remember, you don't need to remember cancer staging for every cancer. Important is wherever the cancer staging decides the treatment, wherever the cancer staging will decide the treatment, for those particular cancers, definitely you need to remember the staging. For those particular cancers, you definitely need to remember the staging. No issues to anybody? That's important. Chalo, talking about the breast cancer staging once now. Okay, so once you have diagnosed with a true cut biopsy that it is a case of breast carcinoma, you will definitely go for a proper staging. You will definitely go for a proper staging. Okay, so in staging, we have TNM staging, right? And what do I mean by TNM staging? Okay, so T stands for the tumor size. Okay, how much is the size of the tumor? T stands for tumor size. N stands for the nodal metastasis. What do I mean by this? How many lymph nodes have been involved? Okay, N stands for nodal metastasis, and M stands for distant metastasis. What do I mean by this? Which other organs are also involved? That is what is distant metastasis. Okay, so you need to talk about these things over here. If I talk about T staging, okay, main is T staging for breast cancer. If I talk about T staging for breast cancer, T1 is what? T1 is less than equal to 2 centimeter. T1 is less than equal to 2 centimeter. T2 is more than 2 but less than equal to 5 centimeter. T2 is more than 2 but less than equal to 5 centimeter. T3 is more than 5 centimeter. T3 is more than 5 centimeter. T4A, important is T4A. Okay, it is nothing but chest wall involvement. T4A is chest wall involvement. T4B is what? T4B is skin involvement. Okay, T4B is skin involvement. T4C is both. What do I mean by both? T4C is both, that is T4A plus T4B. That means if there is chest wall involvement also and skin involvement also, that is considered as T4C, both. Okay, and last is T4D. T4D is important for you to remember, that has been asked as well, and it is inflammatory breast cancer. Okay, so T4D is inflammatory breast cancer, where there will be inflammation of the skin over the breast cancer. It is known as inflammatory breast cancer. Okay, so please remember T1 का मतलब होता है ट्यूमर की जो साइज है वो 2 सेंटीमीटर या उससे कम है. T2 ट्यूमर की साइज 2 सेंटीमीटर से बड़ी है बट 5 सेंटीमीटर है या 5 सेंटीमीटर से कम है. T3 मतलब ट्यूमर की साइज 5 सेंटीमीटर से भी ज्यादा है. T4A दैट मीन्स देयर इज इन्वॉल्वमेंट ऑफ चेस्ट वॉल की इन्वॉल्वमेंट हुई है. T4B मतलब स्किन की भी इन्वॉल्वमेंट हुई है. T4C मतलब दोनों चेस्ट वॉल की भी और स्किन की दोनों की इन्वॉल्वमेंट हुई है. T4D दैट मीन्स इट इज अ केस ऑफ इन्फ्लेमेटरी ब्रेस्ट कैंसर. ठीक है. Important is, how do we suspect chest wall involvement? So what is considered as chest wall involvement? What lies behind the pectoralis muscles? We know it is the rib cage, right? So involvement of ribs is chest wall involvement. Involvement of the intercostal muscles. What are intercostal muscle? These are the ribs. And the muscles which lie between the ribs are known as intercostal muscles. So involvement of intercostal muscle is also considered as chest wall involvement. Okay, and involvement of serratus anterior muscle. Involvement of serratus anterior muscle, that is okay, also considered as chest wall involvement. Please remember, yes, a lot of people will be feeling, sir, pectoralis muscle involvement is not chest wall. No, pectoralis muscle involvement is not considered as chest wall involvement. Okay, so pectoralis muscle involvement is not considered as chest wall involvement. That you need to remember. Okay, that has been asked as well. Skin involvement is what? So please remember, skin involvement is what we call it as pudgy orange. I'll talk about that. Pudgy orange is considered as skin involvement, and that is a Sarkari question of your exam. Pudgy orange. Okay. Then ulceration on the skin. Ulceration on skin is skin involvement. And satellite nodules. Okay, what is satellite nodules? I hope all of you are quite aware. Okay, so if there is a breast cancer and if there are nodules which are formed around the cancer, these are called as satellite nodules. So again, satellite nodules are also considered as skin involvement. Okay, so important is that we need to discuss about these three important things now. What are these? So important, if I talk about, is the first image over here. What is this image suggest you of? This image is what is suggestive of pudgy orange. Okay, this image is what is suggestive of pudgy orange. Okay, so this pudgy orange or pudgy orange, whatever you call it, it is nothing but orange peel like appearance of skin. Okay, it is nothing but orange peel like appearance. Okay, orange के छिलके जैसा लग रहा है ना breast skin का appearance, that is what is pudgy orange. So, orange peel like appearance of the skin over the breast is known as pudgy orange. And important is, please remember, pudgy orange, they will ask you which stage of breast cancer it is. That has been asked in recent FMGE exams as well. Now you know pudgy orange is nothing but skin involvement in cases of breast cancer, and skin involvement is nothing but T4B. Skin involvement is nothing but T4B. So please remember that pudgy orange is considered as stage T4B. Now there's a question, so why is pectoralis muscle not considered as chest wall involvement? Important is pectoralis muscle is very commonly involved in breast cancers. Therefore, it is not considered as a separate involvement. Okay, so that's the reason why in most of the breast cancers you will see that the pectoralis muscle has been involved. Okay, so therefore it is not given a different staging. Please remember that. Next is this image over here. This is what? This is nothing but you can see bluish nodules over the breast, and these bluish nodule over the breast which are seen, these are called as cancer and Curas. Okay, so these bluish nodules which are seen, these are known as cancer and Curas. Now these cancer and Curas, they are what are suggestive of. Important is cancer and Curas is what is suggestive of a loco-regional recurrence. What do I mean by this? पहले breast cancer निकाल चुके थे तुम लोग, वापस से breast cancer हुआ है. That is what is recurrence. Okay, so once you have removed the breast cancer, again there is a recurrence. Okay, so that is what is called as loco-regional recurrence. So cancer and Curas is suggestive of loco-regional recurrence of breast cancer. Now one question I want to ask all of you is pudi orange. This has been a sarkari question again. Pudi orange is due to blockage of. It is due to blockage of. Options are, it is due to blockage of lactiferous ducts, it is due to blockage of cutaneous lymphatics, or it is due to blockage of subcutaneous or subdermal lymphatics. Please answer it in the chat box. Okay, I'm waiting for that answer. Okay, so that has been a very classical question of your exam. They give you this image and they ask you what is the cause behind this. So cause behind this is blockage of either of these three. So let me know that. Next important is, I'll talk about this first. What is this? This you can see there is a dimple over the skin, right? There is a dimple over the skin. So this is what is called as dimpling. Okay, so if there is dimple over the skin of the breast, that is called as dimpling, or it is also known as puckering. It is also known as puckering. So there is dimpling or there is puckering, as you can see over here. And dimpling and puckering is suggestive of what? Here it is suggestive that there is involvement of, what were these ligaments known as? Suspensory ligaments of Cooper. Very good. So if the breast cancer involves the suspensory ligaments of Cooper, they will pull inside the skin, and that causes dimpling and puckering. So involvement of suspensory ligaments of Cooper, involvement of suspensory ligaments of Cooper, okay, leads to what? Leads to dimpling or puckering. Leads to dimpling or puckering. Okay, so that's important. Please remember this. Okay, next is this one. What is this? This is what you can see, the nipple has been pulled backwards, or अगर nipple अंदर खींची जाती है, if the nipple is pulled backwards, this is what is called as nipple retraction. So this is the case of nipple retraction. Important is, what was opening at the level of the nipple? As we know, what was opening at the level of nipple? Multiple lactiferous ducts were opening at the level of nipple. So if these lactiferous ducts are involved with a cancer, then that will cause nipple retraction. So please remember, nipple retraction is due to involvement of, nipple retraction is due to involvement of the lactiferous ducts. That causes nipple retraction. Important is, please let me know. Okay, so I'll talk about pudi orange in that time. Meanwhile, please let me know that nipple retraction and dimpling of puckering is which stage of breast cancer. Okay, it will be considered into which stage? Will it be chest wall involvement? Will it be skin involvement? What? Please let me know in the chat box. Okay. Next, if I talk about the pudi orange, as I've asked you a question, pudi orange is due to blockage of which ducts? So it is not lactiferous ducts. I've already told you involvement of lactiferous ducts will cause nipple retraction in the patient. So that has been ruled out. We are left with cutaneous lymphatics or subdermal lymphatics. So important is, it is due to blockage of the subdermal lymphatics or subcutaneous lymphatics. So when the lymphatics below the skin, that is subdermal or subcutaneous lymphatics, are blocked, that causes the classical appearance of pudi orange in a case of breast cancer. Please remember that. Okay, that causes a classical appearance of pudi orange. Important is, please let me know. Just a minute. Please let me know. Nipple retraction and dimpling of puckering is. Important is, you need to remember that both these conditions are not considered as skin involvement. Both these conditions are not considered as skin involvement. Yes, if a patient is having nipple retraction or the patient is having dimpling or puckering, they will not be considered as skin involvement, and that is a very important question that you need to remember for your examinations. Both these conditions are not considered as skin involvement. Please remember, they are not considered as skin involvement. No, they will not be T4B, because as I've told you, they are not considered as skin involvement. Okay, that's you need to remember. Chalo. done with these type of 4 regions, and these 4 regions are very important to remember. Okay, these 4 regions are very important for all of you to remember. No issues with this. So we have spoken about T staging of breast cancer. Okay, we have spoken about T staging. N staging, nodal staging, it is not very much important for all of you to remember, but sometimes definitely they can ask you about N staging also. Okay, so in N staging, if I talk about, at least remember the first one. N1 is what? So please remember, N1 is definitely involvement of, N1 is nothing but involvement of axillary lymph node, because we know that 90% of the breast tissue, okay, 90% of the breast tissue drains into which lymph nodes? 90% of the breast tissue drains into the axillary group of lymph nodes, whereas only 10% of breast tissue drains into, only 10% of breast tissue drains into the internal mammary lymph nodes. Only 10% of the breast tissue drains into the internal mammary lymph nodes. Therefore, the first lymph nodes to be involved, or the most common lymph nodes to be involved in a case of breast cancer, will definitely be the axillary group of lymph nodes. So usually N1 is nothing but mobile axillary lymph nodes. That means axillary lymph nodes are involved, and when the lymph nodes are involved in a case of cancer, what happens? There will be enlargement of the lymph node, and enlargement of the lymph nodes can be felt, it can be palpated easily. Please remember, okay? So that is important. So mobile axillary lymph node is N1 that you need to remember. Please remember that. Okay, N2A is what? N2A is nothing but fixed or matted axillary lymph nodes. That means when the axillary lymph nodes are not mobile, when the axillary lymph nodes are not mobile, it is called as fixed or matted axillary lymph nodes. It is known as fixed or matted axillary lymph nodes. N2B is what? N2B, you need to remember, it is internal mammary lymph nodes. N2B is internal mammary lymph nodes. Okay, it is internal mammary lymph nodes. Important is without axillary lymph node. Yes, because if internal mammary and axillary lymph nodes both are involved, then that becomes N3B. Okay, N2B is only involvement of the internal mammary lymph nodes without any involvement of the axillary lymph node. So these are the 3 most important N staging that you need to remember. ये 3 सबसे ज़्यादा commonly एग्जाम में पूछी जाती है. ठीक है, that's important. चलो, once I'm done with this, now talking about the treatment of breast cancer. When you have staged the breast cancer, definitely you need to talk about treatment of breast cancer now. If I talk about treatment of breast cancer, this TNM staging, याद रखना, ये TNM staging जो होती है ना, उसको further subclassify किया जाता है. Okay, the TNM staging is further subclassified as, okay, how it is classified as, I hope all of you are quite aware. The TNM staging is further subclassified as stage 1 of breast cancer, stage 2 of breast cancer. So stage 1 and stage 2 are different from T1 and T2. That's important, okay? Stage 1 and stage 2 are considered as early invasive cancer. Stage 1 and stage 2 are considered as early invasive cancer. Whereas stage 3A, B and C, stage 3A, B and C, these are considered as, stage 3A, B and C, these are considered as locally advanced breast cancer. Stage 3A, B and C is usually considered as locally advanced breast cancer. No issues with this. So that is N3A. Please remember, okay. So N3A is usually intraclavicular and N3C is supraclavicular. Please remember that. No issues with this, anybody? If you are able to remember all of them, remember all of them. Actually, if you are not able to remember all of them, at least remember these 3 ones: N1, N2A and N2B. Chalo. So these are the 3 important things that you need to remember over here. Stage 1 and stage 2 is the early invasive breast cancer. Stage 3A, B and C is locally advanced breast cancer. So we will say, sir, stage 4. Stage 4 का क्या होता है? So please remember, in stage 4 we do not have any surgical management for breast cancer. In stage 4 we do not have any surgical management for breast cancer. Why? Because there is already a distant metastasis which has occurred. Okay, there is already a distant metastasis which has occurred from the breast cancer, and therefore in stage 4, therefore in case of stage 4, we will only go for a palliative care. What is palliative care? Supportive care. We do not treat the condition, we do not treat the disease, we only give symptomatic management to the patient. हम बस palliative care देते हैं, मतलब supportive care देते हैं, so that the survival or the outcome of the patient is somewhat better. Okay, so the survival of the patient is increased, that's it. Okay, that is the only role of palliative care. Okay, whereas for early invasive cancer and for LABC, that is locally advanced breast cancer, for both of them we have some surgical management. Okay, so let's talk about the treatment in a case of breast cancer. Okay, let's talk about treatment in a case of breast cancer. Important is, please remember now, breast cancer is such a cancer in the body, breast cancer is such a cancer in the body which can be treated by surgery, which can be treated by chemotherapy, which can be treated by radiotherapy, and it can also be treated by hormonal therapy. So there are very few cancers in your body which can be treated by hormonal therapy, and that has been a previous year question. Which among the following cancer can be treated by hormonal therapy? And important is, breast cancer was not given in the option. The other option that was given was prostate cancer. Yes, prostate is also a hormone dependent cancer, and that is the reason why in prostate cancer we can also use hormonal therapy in the patient. Okay, so that's important. Now let's talk about the management in the patient. As I've told you, early invasive breast cancer, that is stage 1 and stage 2. In early invasive breast cancer, the size of the tumor is very small and the lymph nodes are also not involved. Many lymph nodes are not involved. Therefore, here we can only remove the part of breast which is having the cancer. And if I remove only this part of breast which is having the cancer, this is what is called as lumpectomy, or it is called as one quadrant is removed. Therefore, it is also called as quadrantectomy. So lumpectomy or quadrantectomy if I do, so what I'm trying to do, I'm trying to at least preserve the breast. I'm trying to save the breast as much as possible. Okay, so here मैं क्या करने की कोशिश कर रहा हूँ, मैं बस उतना लंप निकाल रहा हूँ, that is lumpectomy, या फिर मैं उतना क्वाड्रेंट निकाल रहा हूँ, that is quadrantectomy. क्यों? क्योंकि मुझे ज्यादा से ज्यादा ब्रेस्ट टिश्यू बचाना है, एंड बचाने को क्या बोलते हैं? कंजर्वेशन बोलते हैं. So therefore this surgery will be called as BCS, that is breast conservation surgery. So for early invasive breast cancer, I can go for a breast conservation surgery. Important is, all of you are quite aware, in breast conservation surgery, that is again important thing to be remembered. Okay, what is the diameter of margin that we take? Initially, earlier days we used to take 1 centimeter normal margins, but now we only take 1 millimeter normal margins. We only take 1 millimeter of normal margins in a case of breast conservation surgery. So if we are taking so small margins, there's a very high risk that some of the malignant cells or some of the cancerous cells can be left behind and there can be recurrence again. वापस से कैंसर आ सकता है ना अगर हम इतनी छोटी margins ले रहे हैं तो. Definitely, that is the reason why in breast conservation surgery, always and always we need to follow up the breast conservative surgery with the help of radiotherapy to prevent any recurrence. Okay, because breast conservation surgery has a very high chance of recurrence. Cancer वापस आ सकता है. Therefore, after a breast conservation surgery, which treatment is mandatory? We always need to give radiotherapy to the patient. We always need to give radiotherapy to the patient after a breast conservation surgery. If radiotherapy could not be given, or if breast conservation surgery would not be performed, in this, do we have another option? Yes, we do have another option. And what is that another option? That is what is called as simple mastectomy. That is what is known as simple mastectomy. So early invasive breast cancer, the earlier stages, can be treated by BCS followed by radiotherapy or simple mastectomy. Okay, next important thing I would like to talk about is the locally advanced breast cancer. If I talk about locally advanced breast cancer, guys, important is, what is the treatment over here? Now we cannot go for a breast conservation surgery over here, or now we can go for any simple mastectomy. That's the reason why we used to remove the breast and also the lymph nodes as well, all the lymph nodes, and also all the other tissues which lie on the side of the breast. So if we don't only remove the cancer, we also remove the adjacent structures. That is what is called as a radical surgery. तो radical surgery का मतलब क्या होता है? मतलब बस कैंसर नहीं निकाल रहे हो, तुम आसपास की चीजें भी निकाल रहे हो, mainly lymph nodes निकाल रहे हो. Okay, so radical surgery means when we are not only removing the cancer, but we are also removing the lymph nodes and all the adjacent structures which might be involved. Okay, so that is what is a radical surgery. So here also we used to perform a radical surgery. That was called as Halstead's radical mastectomy. I'll talk about that, don't worry. But nowadays, we thought, why to remove all these structures? In Halstead's radical mastectomy, we used to remove a lot of structures. So that's the reason why we came up with a modified versions of Halstead's radical mastectomy, and that modified version is called as MRM. What do I mean by MRM? Modified radical mastectomy. But you will say, so we directly go for MRM in a case of locally advanced breast cancer? No. What we try to do is, we try to first of all give chemotherapy to the patient. Okay, we try to give chemotherapy to the patient before surgery, and I hope all of you are quite aware, if chemotherapy is given before surgery, that is what is called as neoadjuvant chemotherapy. If chemotherapy is given before surgery, अगर surgery से पहले तुम chemotherapy देते हो, that is what is neoadjuvant chemotherapy. So if we give chemotherapy prior to surgery, that is called as neoadjuvant chemotherapy. And what is the role of this chemotherapy? This chemotherapy will help us to decrease the size of cancer. This chemotherapy will help us to decrease the size of cancer, and that is what is called as downgrading or downstaging of cancer. That is what is known as downgrading or downstaging of cancer. So first of all, we will decrease the size of cancer with the help of chemotherapy, and then we will perform the removal. And that removal is done by, I told you, a surgery known as MRM, that is modified radical mastectomy. But even after MRM, there are chances that the cancer can again recur. वापस से आ सकता है cancer. So if there are high chances of recurrence, even after a modified radical mastectomy, we again need to follow up with the help of radiotherapy. So what is the overall treatment in a case of locally advanced breast cancer? So please remember, here we give neoadjuvant chemotherapy to the patient. Neoadjuvant chemotherapy is given to the patient, followed by MRM, that is modified radical mastectomy, followed by radiotherapy. That is the overall treatment option in cases of locally advanced breast cancer. That's important. Next, if now, as I've told you, that the breast cancer is a hormone dependent cancer. Now, what do I mean by this term? That means the cancerous cells in a case of breast cancer, the cancerous or the malignant cells in the case of breast cancer have receptors for the hormone. And which was that hormone? Mainly it is the estrogen. Sometimes it can also be progesterone as well. Okay? So usually these breast cancer cells which are there, they have receptors for these hormones, so that the hormone can come bind to this receptor and that will stimulate the cell. So if the cell is stimulated, what will happen? If the cell is stimulated, there will be more number of cell divisions. If there is more and more cell divisions, definitely the cancer will keep on increasing in size. So that is what is meant by the hormone receptor positive breast cancer. What do I mean by hormone receptor positive? That means the breast cancer cells are having the hormonal receptors on their surface to which the hormone can come, it can bind, and it will stimulate the cancerous cells to divide and divide and divide. And that will increase the size of cancer further. Now in this condition, what can be done? If a breast cancer cell is having hormonal receptor, what is the problem? The hormone is coming and binding to this, right? So what we should do, we should give a drug. We should give a drug which will come and bind to this receptor. If we give a drug which will bind to this receptor, will this receptor be available for estrogen now? No. So now it is not available for estrogen. Estrogen cannot bind at this receptor. So if estrogen could not bind at the receptor, will this receptor be stimulated? No. There is inhibition of the receptor. Okay, and therefore the breast cancer cell does not get any stimulus for cell division, and that is how you treat the breast cancer. Rather, the size of the breast cancer starts decreasing. Okay, and this is usually done by antagonists or blockers. These are usually done by drugs which are antagonists or blockers. Okay, so now usually if the breast cancer cells are having ER receptor, that is estrogen receptor, or PR receptor, that is progesterone receptor on their surface, that is what is called as ER/PR positive breast cancer. In cases of ER/PR positive breast cancer, definitely we can treat the breast cancer with the help of hormonal therapy. We can treat the breast cancer in these conditions with the help of hormonal therapy. Which is the hormonal therapy? Let's see that now. If a ER/PR positive breast cancer is there in a female and the female is premenopausal. What do I mean by premenopausal? The patient has not achieved her menopause. Okay, that means patient में अभी भी menses चालू है. Okay, so that is what is premenopausal female. If I talk about a premenopausal female, and second condition about a postmenopausal female, the hormonal therapy that we use in both these females is different. The hormonal therapy we use in both of these females is different. Very good. For a premenopausal female, the hormonal therapy of choice is by drugs called as SERM. Okay, it is by the drugs known as SERM. What is SERM? Selective estrogen receptor modulator. Okay, so selective estrogen receptor modulator. What these drugs will do? They will come, they will bind to the ER receptor and they will block this receptor. So you will say, sir, if these drugs come and they bind to the receptor and they block the receptor, why we are not calling them antagonists or blockers, and why we are calling them as modulators? So this comes from pharmacology. I hope all of you have studied that selective estrogen receptor modulator, it is called as because it is agonist at some site whereas it is antagonist at some site. Okay, it is agonist. It will stimulate some sites and it will inhibit some sites. So please remember, estrogen receptors are not only present in the breast, right? They are present at multiple sites in the body. They are also present on your endometrium in the uterus as well, right? So if she is a, please remember, if she is a young female, that means a premenopausal female, definitely you cannot give a drug which will block all the estrogen receptors, because otherwise that can cause endometrial atrophy and the patient will stop having menses. Okay, or the patient will not have child as well. Okay, she cannot bear child as well. So that's the important thing. She cannot be pregnant. That's the reason why we need a drug which is agonist at some sites and antagonist at some sites, and that is what is SERM, selective estrogen receptor modulator. And that drug that you need to remember is tamoxifen. Raloxifene is also used, but preferably tamoxifen is used because efficacy is more somewhat with tamoxifen. But what are the side effects of tamoxifen? That has been commonly asked. So please remember, the most common side effect of tamoxifen, as it is a hormonal therapy, the most common side effect of tamoxifen, it is not endometrial cancer, mind it. Okay, it is hot flushes. So the most common side effect of tamoxifen is hot flushes. The other side effects can be DVT, deep venous thrombosis, or it definitely can be, please remember, endometrial cancer. Why endometrial cancer will develop? Because please remember, this tamoxifen, it will block the estrogen receptors in the breast, but it will stimulate the estrogen receptors in the endometrium. If the estrogen receptors in the endometrium are stimulated, there will be endometrial hyperplasia, and endometrial hyperplasia can further progress to endometrial cancer as well. That's the important thing you need to remember. Yes. Next, if I talk about a postmenopausal female, postmenopausal female may, what is the main source of estrogen now? Because her ovaries are atrophied. If her ovaries are atrophied, the estrogen is not secreted from her ovaries. So the main source of estrogen in this female is the adipose tissue. We discussed about adipose tissue now. Adipose tissue has this enzyme known as aromatase, which converts androgens to estrogens, right? So in a postmenopausal female, the main source of estrogen is definitely this adipose tissue and this aromatase enzyme. So just block this aromatase enzyme so that the androgens are not converted to estrogen, and that is done by aromatase inhibitors. Okay, that is what is done by aromatase inhibitors, and these aromatase inhibitors are drugs like, anybody? These aromatase inhibitors are usually drugs like, the drug of choice for PCOD, answer is letrozole. Okay, so it is usually letrozole. Please remember that. Okay, it is letrozole. No issues with this, anybody? Or the other drug can be anastrozole as well. What is the most common side effect? What is the most common side effect of letrozole? So the most common side effect of letrozole, as it is decreasing estrogen levels, and the patient is already postmenopausal, there will be very high chances of osteoporosis in the patient. There will be very high chances of osteoporosis. That you need to remember. Okay, so please remember, tamoxifen is safe in pregnancy. Please remember, tamoxifen usually it cannot be given to the patient during pregnancy. Important is because it causes endometrial hyperplasia, and if there is too much of endometrial hyperplasia, implantation could not occur. Okay, so that's the reason why we try to avoid it during pregnancy. No issues with this, anybody? Next is HER2/neu positive breast cancer. Okay, these are another receptors which are present over the breast cancer cells known as HER2/neu. These HER2/neu positive breast cancer, you need to remember, the HER2/neu positive breast cancer, the treatment of choice usually, or the drug of choice they will ask you, and that has been asked commonly, is known as a monoclonal antibody known as trastuzumab. Okay, the drug is known as trastuzumab. It is also known as Herceptin. Okay, so either trastuzumab or Herceptin. Okay, along with chemotherapy. Yes, chemo has to be given in the patient, but if they ask you the single best drug or the drug of choice, it is trastuzumab or Herceptin. No issues with this, anybody? But chemo is always given along with it. Please remember that. Okay, no issues with this. So this is the table that you need to remember for the treatment or management in cases of breast cancer. Please remember that. Okay, so for management of breast cancer, you need to remember this table for sure. If I talk about, as I've spoken about surgeries, I'll just give you an idea what are these surgeries, mastectomies. Okay, so if I say a patient is undergoing simple mastectomy, what do I mean by this? If a patient is undergoing simple mastectomy, what are the structures removed? We remove the breast tissue, we remove the nipple areola complex, and we remove the pectoralis fascia. Next, if they say a patient is undergoing a Halstead's radical mastectomy. What did I tell you? In Halstead's radical mastectomy, almost everything was removed. In Halstead's radical mastectomy, almost everything is removed. That means the breast tissue is removed, plus the nipple areola complex is removed, plus the pectoralis fascia is removed. Along with that, now we will also remove how many levels of axillary lymph nodes do we have? I hope all of you are quite aware. There are 3 levels of axillary lymph nodes, level 1, 2 and 3. So we will remove level 1, 2 and 3 axillary lymph nodes. Yes, all axillary lymph nodes are removed. Level 1, 2 and 3 axillary lymph nodes are also removed. Along with that, we also remove the pectoralis major and the pectoralis minor muscle. Okay, so you can see everything is removed, almost everything is removed. Then if I talk about the modified version of Halstead's radical mastectomy, and that is what is called as MRM, modified radical mastectomy. In modified radical mastectomy, I will remove the breast tissue, I will remove the nipple areola complex, I will remove the pectoralis fascia. Along with that, I will definitely remove the level 1, 2 and 3 axillary lymph node. So therefore, it is known as radical now, because I am removing the axillary group of lymph nodes. But what is not removed or what is spared is usually the pectoralis major muscle. Pectoralis major muscle is never removed. Pectoralis major muscle is never removed. But what is plus minus? It may or may not be removed. That plus minus which may or may not be removed is pectoralis minor muscle. Major is never removed, but pectoralis minor muscle is plus minus. Now important is pectoralis major muscle, if it is removed, if pectoralis major muscle, if it is removed, either it is called as a Scanlon's MRM, either it is known as a Scanlon's MRM or a PT's MRM. Whereas if it is only retracted, that means it is not removed, it is only retracted, pulled back, then that is what is called as Auchincloss. Then that is what is known as Auchincloss MRM. Okay, so these are the questions which have been asked, okay, about mastectomy. So you need to remember them properly. You need to remember these important conditions properly, these important treatments properly. Okay, no issues with this, anybody? Sure. Once we are done with this, let's move further. As I've spoken about BCS, that is breast conservation surgery, I have told you that breast conservation surgery, important is breast conservation surgery, we take how much margins? We only take 1 millimeters of normal margins. Okay, important is breast conservation surgery is always followed by radiotherapy. So there will be some contraindications to breast conservation surgery. So the contraindications to breast conservation surgery are where we could not give radiotherapy. जहाँ radiotherapy नहीं दे सकते वहाँ BCS नहीं कर सकते. That's the important thing. Okay, so where radiotherapy could not be done, BCS is also contraindicated. And what are these conditions? Usually a pregnant female. In pregnancy, BCS is contraindicated usually. Okay, so apart from that, if it is multicentric, because if it is multicentric breast cancer, definitely what happens? Multicentric means, see, just a minute. If it is a multicentric breast cancer, that means it is not only present in one quadrant but many quadrants. Can you save the breast tissue now? No, you are not able to save the breast tissue. Therefore, again, there is no use of performing a BCS in this patient. Okay, so if it is a multicentric breast cancer, okay, or it is a multifocal breast cancer, okay, it is a multifocal breast cancer, important. Okay, or if the patient had a prior radiotherapy to the chest, if a patient was having a prior radiotherapy to the chest. So these are important contraindications you need to remember for BCS. There was a question on contraindications on BCS. Please remember that. Important is, once we are done with this, now let's talk about the other conditions as well. Okay, once we do mastectomy or once we do removal of the breast tissue, as I've told you, we also remove the axillary lymph nodes, right? We also remove the axillary lymph nodes. So what is an indication to remove the axillary lymph node? Please remember, the indication to remove an axillary lymph node is when the lymph nodes are palpable. When the lymph nodes are palpable, definitely I will remove the axillary group of lymph nodes. Okay, so why? If the lymph nodes are palpable, that means they have grown in size. And why they have grown in size? Because they have been involved with the cancer. So if the lymph nodes are palpable, that is what is suggestive. Please remember, if the lymph nodes are palpable, that is suggestive that they are involved with cancer, and therefore I need to go for lymph node clearance or lymph node dissection. Okay, I need to go for a lymph node clearance or lymph node dissection. The question was, how many lymph nodes are removed in axillary lymph node clearance? How many lymph nodes are removed in axillary lymph node clearance? You need to remember, minimum 10 lymph nodes are removed. minimum 10 lymph nodes should be removed in axillary lymph node clearance. Please remember, minimum 10 lymph nodes are to be removed in axillary lymph node clearance. Now, if the lymph nodes are not palpable, guys, if the lymph nodes are not palpable, are we going to leave them as it is? No, we are not going to leave them as it is. Why? Because at times it can happen that the lymph nodes are not palpable, but still they are involved with breast cancer. ठीक है, तो कभी कभी क्या हो सकता है, lymph nodes palpable तो नहीं है, but still उनमें cancer फैल चुका है. Okay, so if the lymph nodes are not palpable and we need to see if they are involved with breast cancer or not, we need to go for a technique known as sentinel lymph node biopsy. Okay, we go for a sentinel lymph node biopsy, and I hope all of you are quite aware. Sentinel lymph node biopsy is done when the lymph nodes are not palpable, but you need to see, please remember, if the lymph nodes are involved or not. And the best technique for that, the best technique for performing a sentinel lymph node biopsy is combination of two techniques. What is combination of these two techniques? There is combination of, one is called as the blue dye technique, where we inject a dye. Okay, one is called as the blue dye technique. And second one that you need to remember is the radionucleotide technique. Second one that you need to remember is the radionucleotide technique. So these are the two important techniques which when combined together is the best technique for sentinel lymph node biopsy. Okay, it is the best technique for sentinel lymph node biopsy. Shabash. No issues with this, anybody? Chalo. So that was important about the lymph node removal as well in cases of breast cancer. Okay, because majority of the breast cancer also involve the lymph nodes. Therefore, it is very important to remember about that condition also. Important is, now once you have removed the breast, definitely, please remember, you can see the new breast has been formed. Okay, the new breast has been formed. So you can see the new breast which is formed, usually it is reconstructed. So this is what is called as BRS. What do I mean by BRS? Breast reconstruction surgery. So BRS is nothing but breast reconstruction surgery, and you can see we have used a flap to reconstruct the breast. नई breast बनाने के लिए हमने body में से ही कहीं से flap उठाया है. Okay, so you usually use various kinds of flap to reconstruct a breast. The question is, which is the best flap used for breast reconstruction surgery? The best flap used for breast reconstruction surgery, an important one-liner in your exam, answer is DIEP. Okay, answer is DIEP flap. That is deep inferior epigastric artery perforator flap. Okay, the best answer is DIEP flap, that is deep inferior epigastric artery perforator flap. Then if they ask you which is the most common flap used, the most common one is not the DIP flap. The most common one used is the tram flap. And what is tram? So the most commonly used is the tram flap, that is transverse rectus abdominis myocutaneous flap. Okay, the most common one to be used is tram, that is transverse rectus abdominis myocutaneous flap. No issues with this, anybody? That's important over here. Okay, so that was about your breast reconstruction surgery also. Okay, once you have removed the breast, you need to reconstruct the breast as well in the patient. Okay, now important thing is, all of you will be answering me one important question, that what is the most common, okay, what is the most common site for metastasis in cases of breast cancer? What is the most common site for distant metastasis? What is the most common site for distant metastasis in cases of breast cancer? All of you will be answering it. What is the most common site of metastasis, distant metastasis in cases of breast cancer? Very good, Rohan. Very good. So the most common site is definitely the bones. Very good. The most common site is definitely the bones. Which bones? It is the vertebral column. Okay, the vertebrae. And mainly which vertebrae? Very good, all of you. It is the lumbar vertebrae. Very good. It is the lumbar vertebrae followed by the thoracic vertebrae. Okay, it is the lumbar vertebrae followed by the thoracic vertebrae. And it spreads to the lumbar vertebrae. Via which route? There are three routes of spread of cancer. Cancer तीन जगहों से फैल सकता है. एक, either it can spread by direct invasion, okay, direct contact. Second, it can spread via the lymphatic route. And third, it can spread via blood, that is the hematogenous route. Here, it mainly spreads by the hematogenous route. Okay, it spreads by the blood or the hematogenous route. And via which vessels? That has been asked again. So it usually spreads via the Batteson's plexus of veins. Plexus का मतलब होता है network. Okay, so plexus means network. So it spreads via the Battison's plexus of veins. And important is breast cancer will cause a metastasis to the bones, but it will form the bone or it will destroy the bone. What do I mean by this? Whether it will be a osteoblastic metastasis, that is a bone forming metastasis, or it will be a osteoclastic metastasis, that is a bone breaking metastasis. So there can be two types of metastasis from the cancer. Important is, please remember, there will be two types of metastasis from the cancer. After vertebrae, it is the femur. After vertebrae. Okay? So usually, more commonly in breast cancer, we have the osteoclastic metastasis. But breast cancer is such a cancer in the body which shows both types of metastasis. Breast cancer is such a cancer in the body which shows both types of metastasis. Definitely more common being osteoclastic. And now a question to all of you is, please remember there is another cancer in the body where also the most common site of distant metastasis is the bones. That too the lumbar vertebrae. That too it spreads to the lumbar vertebrae via the same Battison's plexus of veins. But over there, the more commoner type of metastasis is not osteoclastic, it is osteoblastic. Which is that cancer? Please let me know. Everything remains same except osteoblastic metastasis is more common in that type of cancer. What is that cancer? Please let me know in the chat box. As you can see over here, you can see the bone has been destroyed. The lumbar vertebrae has been destroyed over here. Okay, so this is a case of osteoclastic metastasis or a bone breaking metastasis in a case of breast cancer. No issues with this, anybody? Osteoclastic or osteolytic metastasis, whatever you call it. Okay, no issues with this, anybody? Osteolytic, osteoclastic metastasis. Chalo. Very good, Raja. It is the prostate cancer. Very good. In prostate cancer, everything remains same about distant metastasis. Only thing that changes is over there, more common is osteoblastic metastasis. Very good, all of you. Okay, shabash. Now, if I talk about next important conditions. Okay, so we have talked about breast cancer. Now we will be talking about another condition. And what is this condition over here? So this condition over here, you can see that the nipple is usually dry. Okay, the nipple is usually dry. It is cracked out. Okay, and when does the skin becomes dry and it cracks out? In eczema, right? So here also it seems it is an eczema-like condition of the nipple. Eczema जैसी condition है ना nipple की. This condition of nipple is what is known as Paget's disease. This is what is known as the Paget's disease of nipple. Okay, it is known as the Paget's disease of nipple. And what happens in the Paget's disease of nipple? You can see there is an eczema-like condition. It is not eczema. Eczema is different again. Please remember. It is eczema-like condition of the nipple. Okay. It is an eczema-like condition of the nipple. And whether it is unilateral or bilateral, it is usually unilateral. Eczema is bilateral. But please remember, Paget's disease of nipple is eczema-like condition of nipple. It is usually unilateral. Please remember that. And important is, here you can see the nipple areola complex which is there. This nipple areola complex has been completely destroyed. Nipple areola complex is completely destroyed over here. Now important is, why Paget's disease of nipple is so much important? Because Paget's disease of nipple is a marker of underlying malignancy. What do I mean by this? If a patient is having Paget's disease of nipple, that means the patient might be having some breast cancer. ओके इसका मतलब क्या है? समझो कि अगर किसी पेशेंट में पेजेस डिसीज है निपल का, दैट मींस उसके ब्रेस्ट में कोई ना कोई तो कैंसर या मैलिग्नेंसी होगी. मे बी तुम्हें पैल्पेट नहीं हो पा रही है, बट कोई ना कोई मैलिग्नेंसी होगी जरूर. ओके, सो इट इज अ मार्कर ऑफ एन अंडरलाइंग मैलिग्नेंसी. एंड व्हाट आर दीज मैलिग्नेंसीज? इट इज यूजुअली इन्वेसिव डक्टल कार्सिनोमा or DCIS, that is ductal carcinoma in situ. That's important. Okay, now important is how you make a diagnosis. You make a diagnosis with the help of a punch biopsy. And once you take a punch biopsy from the nipple, what is seen? And that was a previous year question. Once you take a punch biopsy from the nipple, you are able to see Paget cells on biopsy. You are able to see Paget cells on biopsy. And very good treatment. Very good, Mohit. Treatment is treat the underlying malignancy. Okay, treat the underlying malignancy. ओके, जो भी कैंसर है पेशेंट में उसको ट्रीट करो. ओके, सो ट्रीट द अंडरलाइंग कैंसर और ट्रीट द अंडरलाइंग मैलिग्नेंसी इन अ केस ऑफ पेजेस डिसीज. दैट्स इंपॉर्टेंट. ओके, चलो नेक्स्ट, इफ आई टॉक अबाउट दिस कंडीशन, एंड व्हाट इज दिस कंडीशन? यू कैन सी दिस इज द ह्यूज और अ मैसिव ब्रेस्ट ट्यूमर, और रादर इट इज द लार्जेस्ट ब्रेस्ट ट्यूमर. बट व्हाट इज द स्पेशल फीचर अबाउट दिस ब्रेस्ट ट्यूमर? Though it is the largest breast tumor, It never goes beyond the pectoralis fascia. Okay, ये सबसे बड़ा ब्रेस्ट ट्यूमर जरूर होता है, बट ये पेक्टोरालिस फेशिया को कभी भी इन्वेड नहीं करता यूजुअली. ठीक है, सो दैट्स अ स्पेशल फीचर अबाउट दिस काइंड ऑफ अ कैंसर और अ ट्यूमर. एंड व्हाट इज दिस? This type of a tumor is known as cystosarcoma phylloids. This type of a breast tumor is known as cystosarcoma phylloids, also known as the phylloids tumor. It is also known as the phylloids tumor. Okay, important is cystosarcoma phylloids is majorly a benign tumor or a malignant tumor, and a lot of people get confused. They feel, okay, so such a huge tumor na, so therefore they tend to mark it as malignancy. But please remember, majority of the cases of cystosarcoma phylloids are benign in nature. Majority of the cases of cystosarcoma phylloids are benign in nature. Please remember. How the patient is going to present to you? Definitely the patient is going to present to you with a rapidly growing breast mass. There's a very rapid or a very fast growing breast mass which is there, and along with this huge breast mass which is there, along with this, just a minute, I'll use another, along with this huge breast mass which is there, patient will also have these skin color changes. You can see the skin over the breast has started changing its color. Why there are skin color changes which are seen? Because due to this huge tumor, there is compression of the blood vessels supplying the skin. Okay, and due to that there will be decreased blood supply to the skin. That causes necrosis of the skin. Okay, so there is pressure necrosis from the breast tumor that causes color change. A very clinical, very important hint. Huge breast tumor with skin color changes, make a diagnosis of cystosarcoma phylloids. A previous year question asked at least twice or thrice in the examination since August 2020. Please remember that. Okay, as I've told you, most of the cases are benign in nature. Usually it is more common in which age group? It is more common in the third or fourth decade of life. It is more common in third or fourth decade of life. Investigation of choice is what? Again, definitely, now we are not sure, right? It is always cystosarcoma phylloids. We need to see whether it is benign or malignant. So definitely the investigation of choice is a biopsy. Investigation of choice is a true cut biopsy that we do. Okay. And what is done for treatment? That's important. So what is done for treatment in this condition? Please remember, the treatment is carried out. What did I tell you? Most of these phylloids tumor, they are only lying above the pectoralis fascia. They never invade the pectoralis fascia. मतलब ये pectoral fascia के ऊपर ही होते हैं, अंदर तक नहीं जाते. Therefore, for treatment, we will only go for a wide local excision. We will only go for a wide local excision. Okay, in most of the cases, only a wide local excision can be done. We don't need to go for a mastectomy even. But in certain conditions, like if there is recurrence, okay, again वापस हुआ एक tumor, या फिर if it is a malignant cystosarcoma phylloids, okay, it is a malignant cystosarcoma phylloids, or if, please remember, it is a very large breast tumor, then in that condition you need to go for a simple mastectomy. Then also you can see we are not removing any other structures. Then also we are only removing the breast tissue, nipple areola complex and the pectoralis fascia. That is simple mastectomy. Okay, so even if it is malignant or it is recurrent, only go for a simple mastectomy. That's important. Okay, chalo. Once we are done with this as well, let's move further. Now talking about the benign breast tumor. And now we have already discussed which is the most common benign breast tumor. Now we know the most common cause of breast lump is also this one, and the most common benign breast tumor is also this one. So we know the most common benign breast tumor, it is none other than fibroadenoma of breast. Okay, it is none other than fibroadenoma of breast. Important is fibroadenoma of breast is more common in which age group? It is very common in females between 15 to 25 years of age. That is very younger females. Okay, it is more common in females between 15 to 25 years of age. How the patient is presenting to you? The patient presents to you with a painless breast lump, right? The patient presents to you with a painless breast lump, important. And when you palpate this breast lump, what you can feel? This breast lump, okay, when you palpate this breast lump, you will feel that this breast lump is firm and this breast lump is mobile. As it is a mobile breast lump, that means अगर घुमाओगे तो वो घूमेगा breast lump. Okay, so that is a mobile breast lump. Therefore, fibroadenoma breast is also known as breast mouse. चूहे जैसा घूमता है ना? Therefore, it is also known as breast mouse. That's important. As it is mobile, it is also known as breast mouse. Okay. Now, what is done for investigation? What is the investigation of choice over here? As we know, it is a benign breast tumor. It is a benign breast tumor. What is done for investigation? What is done for investigation? Anybody? Just let me know in the chat box. What is done for investigation? Please let me know. Chalo, if a female is coming to you with a breast lump which is painless, which is firm, and which is mobile, you suspect, okay, it might be a case of fibroadenoma of breast. Therefore, after clinical examination, you send the patient to a radiologist. And for what? You send the patient for a radiological investigation. As it is a younger female, you will ask the radiologist to perform an ultrasound. Once the radiologist has performed an ultrasound, I hope all of you are quite aware, if a patient is undergoing a ultrasound, MRI or mammography for a breast lump, the radiologist will always report in a specific manner. Okay, every radiologist has to report ultrasound, mammography and MRI in a case of breast lump in the same standardized format. एक ही format में सबको report करना होता है, and that format is what is called as BIRADS. That format is known as BIRADS. What is BIRADS? The full form has been asked. It is breast imaging reporting and data system. It is breast imaging reporting and data system. So here we have total 7 categories usually, okay, from BIRADS 0 to BIRADS 6, which will tell you about whether the breast region is benign, whether the breast lump is benign or the breast lump is malignant. The radiologist will tell you. Okay, so in cases of fibroadenoma, the radiologist will give a score of BIRADS 2. In cases of fibroadenoma, the radiologist gives a score of BIRADS 2. इसका मतलब होता है the breast lump which is there, it is 100% benign. It is 100% benign. So will you go for any biopsy now? You know it is a benign breast tumor. So why to go for any biopsy? Just go for routine screening in the patient. Okay. So investigation of choice is only ultrasound. Okay. Investigation of choice is only ultrasound because the radiologist will say most of the times it is confirmed 100% it is a benign tumor. But if the radiologist is having a suspicion, that plus minus, it may be benign, it may be malignant. Okay. In that condition, you will definitely go for further a FNAC or a true cut biopsy as well. No issues with this, anybody? That's important. Okay. So plus minus FNAC or true cut biopsy should be done. But single best answer should be ultrasound for a benign breast tumor. Now, important is, as we perform mammography, usually we don't, because we know fibroadenoma is more common in younger females and mammography is not done in younger females. So over here, if I perform a mammography, I can see these macro calcifications. Because fibroadenoma is a benign breast tumor, these macro calcifications are what are called as popcorn calcification. Okay? What is done for treatment? So we know that in cases of fibroadenoma breast, the treatment is nothing but observation and follow-up. Why? Because we know it is a benign breast tumor. Therefore, definitely we only go for observation and follow-up in the patient. That's important. Okay. But definitely, if there is an indication of surgery, we need to go for removal as well. What are the indications of surgery? That was again a previous year question. So please remember, the most common indication for a surgical intervention in cases of fibroadenoma, the most common indication for a surgery in cases of fibroadenoma is cosmetic indication. It does not feel good. Okay, the patient says, "Acha nahi lag raha, bas nikal do." Okay, it does not seem good. Therefore, please remove it. So, most common indication of surgery in a case of fibroadenoma is cosmetic. Other conditions can be if the breast lump is painful, because normally it is painless. Now, if it is painful, it is suggestive of malignant conversion. Next, if it is rapidly growing in size. Okay, if it rapidly grows in size. Okay, so if it rapidly grows in size. Next important, if the patient is having a family history of breast cancer, because if a patient is having family history of breast cancer, there are very high chances that this fibroadenoma can turn into a malignancy also. Or if there is a giant fibroadenoma. And what is a giant fibroadenoma? Which is more than 5 centimeters in size. So these two have been asked. Most common indication is cosmetic and a giant fibroadenoma. That means cancer more than 5 centimeters in size, or tumor more than 5 centimeters in size. No issues with this. And once we have removed the tumor, then I can send it to the pathologist now. Because I've told you, usually we don't perform a true cut biopsy. So once I've removed the tumor, I'll send it to the pathologist. And in that, I'll be able to see this classical sign. What is seen? You can see it is a fibroadenoma. That means it is a tumor which mainly arises from these fibrous tissue and not from the glandular tissue. Okay. So there is excessive fibrous tissue which is seen in the patient. Therefore, there is compression of the glandular tissue. And it seems the glandular tissues which are there, it seems as if they are the horns of a reindeer. ठीक है, तो जो reindeer होता है ना, उसके सींगों जैसा लग रहा है. This is what is called as the antler sign. So the biopsy or the histopathological examination of fibroadenoma will show us this classical antler sign. It will show us the antler sign. Chalo. Moving further, talking about next condition, and that is breast pain or mastalgia. If I talk about breast pain or mastalgia, please remember, usually some patients will only have pain during the menstrual cycles, and that is called as cyclical mastalgia. Whereas some patients will have breast pain anytime during the menstrual cycle. Okay, so some patients who only have pain during menses, that is cyclical mastalgia. Some patients have pain anytime. Okay, that is what is non-cyclical mastalgia. More common is definitely the cyclical mastalgia, and the most common cause of cyclical mastalgia, you need to remember, is fibrocystic disease of breast. Okay, it is known as fibrocystic disease of breast, also known as fibroadenosis. That is one and the same thing. It is known as fibrocystic disease of fibroadenosis. Please remember. Okay, so fibrocystic, what is a cyst? As I've told you, sac which contains some amount of fluid. So there is multiple cysts which are formed usually in the breast of this patient in cases of fibroadenosis or fibrocystic disease of breast, commonly seen between 25 to 40 years of age. Next is non-cyclical mastalgia. Important in cases of non-cyclical mastalgia, please remember, one of the causes can be Maunders disease. And what is Maunders disease? Which is seen in the image beside. Maunders disease is usually nothing else but it is superficial thrombophlebitis. What is thrombophlebitis? We discussed yesterday. Thrombophlebitis is nothing but inflammation of the veins. So it is superficial thrombophlebitis of the chest veins. When the chest veins undergoes inflammation, that is called as thrombophlebitis, and that is known as Maunders disease. So you can see these chest veins have undergone inflammation, and now once you palpate it, क्या feel होगा? They will feel like a cord or they will feel like a string. Okay, these veins, they become so hard that they will feel like a cord or a string, and therefore Maunders disease is also known as string disease. Maunders is also known as string disease. What is the treatment over here? Definitely inflammation is the cause. Therefore, the treatment is nothing else but painkillers, that is analgesics. Usually analgesics are only given to the patient. No issues with this, anybody? So that's important. You need to remember that. Next one is this one. These are some abnormalities in the development of breast. Okay, in the first image, what you can see that the patient is having multiple nipples. Okay, so if a patient is having multiple nipples, that is what is called as polythelia. So if a patient is having multiple or many nipples, that is what is called as polythelia. Next is, in the second picture, you can see that the patient is having no nipples. Breast tissue is present, but nipples are absent. If nipples are absent, that condition is what is called as athelia. If nipples are absent, that condition is known as athelia. Next is, over here you can see the patient is not even having breast and the patient is not even having nipples. So if the patient is not having breast tissue, that is what is called as amasia or amastia. That is called as amastia or amasia. That is one and the same thing. Amastia or amasia when there is absence of breast tissue. But please remember, what is Poland syndrome then? Poland's is a variant of amastia itself. What is seen in Poland's? Whatever I'm discussing, guys, are all the PYQs which have been asked some or the other time in some of the other examinations. Okay, Poland syndrome is nothing but absence of breast tissue, that is amastia, plus there is also absence of pectoralis major muscle. Okay, in Poland syndrome there is also absence of pectoralis major muscle along with the pectoralis major muscle is also absent along with the breast tissue. And here you can see in this condition, this is what is called as Poland syndrome. And one of the sides, the patient is not having breast also, and the patient is not also having pectoralis major muscle as well. Only the nipple is present. Okay, so that is a case of Poland syndrome. No issues with this, anybody? So this is the case of Poland syndrome. Sure. So these were the important things I had to talk about. Okay, and when a patient is having many breast tissue, like many nipples, a patient can also have many breast tissue. That is called as polymastia or polymasia. Many breast tissue is known as polymastia or polymasia. And the question was, what is the most common site for this extra breast tissue? The most common site for this extra breast tissue is the axilla. The most common site for this extra breast tissue is the axilla. Okay, chalo, आगे बढ़ते हैं. Now talking about the discharge from the breast. Okay, there will be discharge from the nipple, right? And the most common physiological discharge from the nipple is milk. Normally क्या आता है nipple से बाहर? Milk आता है ना? So definitely the most common physiological discharge from nipple can be milk. But at times what can happen? There can be some amount of pathological discharge from the nipple also. And these pathological discharge can be of various types. The first one that we'll discuss is a blood-stained nipple discharge. If there is a blood-stained nipple discharge from the nipple, you need to see whether this blood-stained nipple discharge is from a single duct. So, if the blood-stained nipple discharge is from a single duct, the most common cause for it is a duct papilloma. The most common cause for it is actually a duct papilloma. What do I mean by this? There is a small benign tumor in the duct. Okay, that is called as a duct papilloma. That is the most common cause of single duct blood-stained nipple discharge. But if there is a blood-stained nipple discharge from multiple ducts, if there is a blood-stained nipple discharge from multiple ducts, then the cause is more likely a breast cancer. Then the cause is more likely to be a breast cancer. That's important. Okay. Next, if I talk about a serous discharge, serous matlab a yellowish or a straw colored fluid coming out from the nipple. That is what is called as a serous nipple discharge. If they ask you serous nipple discharge, the most common cause of serous nipple discharge in a single duct or in multiple duct is the same thing. Okay, so whether it is single duct or multiple ducts, serous nipple discharge ka most common cause is only one, and that I've told you is also a cause of cyclical mastalgia. That is nothing else but fibrocystic disease of breast, also known as fibroadenosis. Next important, if there is a greenish, blackish or sometimes even a bluish nipple discharge, greenish, blackish or sometimes even a bluish nipple discharge, please remember here the most common cause is definitely duct ectasia, and that has been again an important question. Okay, so if there is a greenish, blackish or a bluish nipple discharge, the most common cause for this condition is usually a duct ectasia. What is an ectasia? Ectasia का मतलब होता है dilatation. Ectasia means dilatation. So there is dilatation of multiple ducts inside the breast. Which are the ducts inside the breast? Lactiferous ducts. So there is dilatation of these ducts. Normally these are the ducts. There is dilatation of the duct. And if there is dilatation of the duct, what will happen? The milk will stay inside the duct. Okay, and if the milk stays inside the duct for a longer period of time, okay, पानी भी अगर ज्यादा समय तक जमा रखोगे तो उसमें भी infection हो जाएगा. Okay, so if you keep the water also accumulated in a specific site for a longer duration of time, it also gets contaminated. Just like that, if a milk also stays over here for a longer duration of time, it gets contaminated and there is infection of these ducts, and that infection is what is called as periductal mastitis. That infection is what is known as periductal mastitis. That was another important question in your exam. That duct ectasia further causes periductal mastitis, and that periductal mastitis is known as what? That periductal mastitis is known as Zuska's disease. That periductal mastitis is what is called as Zuska's disease. Please remember that. Okay, so that you need to remember properly. Now, if I talk about the treatment for all the pathological nipple discharge, if there is a pathological nipple discharge from a single duct, then we will only remove that particular duct. And that is what is called as microdocectomy. Ectomy का मतलब होता है removal. Ectomy means removal. So microdocectomy, that means removal of only one duct. Whereas if the discharge is from multiple ducts, then we need to do, okay, then we need to do a conical excision at the level of nipple. Okay, then we need to do a conical excision of these ducts, and that is what is called as, very important, a Hadfield's procedure. That is what is known as Hadfield's procedure. And they have asked you what is the treatment of choice for duct ectasia. You need to remember duct ectasia usually occurs mainly from multiple ducts, and therefore the treatment of choice in cases of duct ectasia will be the Hadfield's procedure, which is nothing but the conical excision of the lactiferous ducts. Okay, now talking about the last topic about the breast, and that is what is three important things. Now, first question that I am going to ask you. This image is not the part of a question. This image was not a part of the question. The question was previous year, a lady delivered a child 2 months ago. Now complains of pain and fullness in the breast. She's only complaining of pain and fullness or heaviness in the breast. And she gives history that the child is refusing to feed. That means the child is not drinking milk. The child refuses to feed. What is the diagnosis and management in this condition? I wait for your answer. Jaldi se answer karo. A previous year August question and also asked in multiple other exams. Please let me know. Faster. No answers? Okay. So please remember. Okay. So please remember this is a condition known as. Please remember this is a condition which is called as not breast abscess. I've told you image is not a part of the question. And a lot of people make the same mistake. They call it as a breast abscess. No, it is not a breast abscess. And it is a case of breast engorgement. It is a case of breast engorgement. Please remember. Okay. So it is a case of breast engorgement. What do I mean by breast engorgement? If the milk could not come out. Please remember, if the milk could not come out, definitely as the child is refusing the feed, the milk is not able to come out, and therefore the milk stays inside the breast. And if the milk stays inside the breast, therefore there will be collection of milk within the breast. That causes heaviness in the breast. Okay, that causes heaviness and fullness in the breast. Okay, that leads to heaviness or fullness in the breast, and due to this heaviness there is pain in the breast also. There is pain in the breast also. Please remember that is what is the case of breast engorgement. And what is the treatment for this? What is the treatment for breast engorgement? The important thing is the treatment for breast engorgement will be, now what is the problem? A lot of milk has been collected within the breast. Now let out that milk, express out that milk properly. Nikalo us milk ko bahar. The treatment is what is expression of milk. And this is a mistake. I don't want any one of you to repeat this mistake in your exams. Okay. So the treatment is nothing but expression of milk. But now during expression of milk, the patient will have a lot of pain. So you need to use some warm and moist compresses. Okay. So kuch garam kapda use karo and then press the breast so that it will be let out. Okay. Expression of milk with warm moist compresses should be done. Okay. That is important. Now definitely in lactation, the patient is also at a risk of developing infection of the breast. And what is infection of the breast? Infection of breast is nothing but mastitis. Infection or inflammation of breast is nothing but mastitis. What is the most common time? Most common time we know it is during lactation of breastfeeding. Okay. What is the most common cause for it? So the most common cause for it, please remember, the most common cause for it is an organism known as Staph aureus. And what is the most common source of this Staph aureus? So please remember, the most common source of this Staph aureus. The most common source of the Staph aureus will be the baby's mouth. Okay, the most common source of the Staph aureus is the baby's mouth usually. That you need to remember. Okay. So during lactation, mastitis is more common. Most common cause being Staph aureus. Most common source being baby's mouth. Here, what will be the complaints of the patient? Here, the patient might have fever because it is an infection. And at the site, okay, at the site, that means at the breast, the patient will have inflammatory signs. And what are the inflammatory signs? At the site or in the breast, the patient will have pain. There will be warmth. There will be redness. Okay. And there can be a swelling as well. But usually swelling is a less likely feature in cases of mastitis. So these are the usual complaints. What is the treatment? Definitely antibiotics. And we know usually during pregnancy or lactation, we cannot use all the antibiotics. So we use some antibiotics, and the question has been asked, which antibiotic is used? That was the FMG question. So it is nothing but the best one to be used is amoxiclav. That is amoxicillin plus clavulanic acid. The others, which was amoxiclav, is not an option. So the other drugs that we can use is cloxacillin or dicloxacillin. That is penicillin should be used. Okay. So amoxiclav is the best one. If that is not an option, cloxacillin or dicloxacillin. Next important, if I talk about, now if you do not treat mastitis or the breast infection in time, it will further go and progress into a breast abscess. Now what will happen? The infection can grow so much that it causes a lot of pus, and if the pus collects, then that leads to breast abscess formation. That leads to formation of an breast abscess. Okay, so breast abscess is also commonly seen during lactation or breastfeeding. Why? Because breast abscess is nothing but a complication of mastitis itself. Right, so it is also commonly seen during lactation. Now important is, in breast abscess, what will be the signs? There will be fever in the patient, and all the signs of mastitis will be there. There will be all the signs and symptoms of mastitis in the patient. But important is, you will say, sir, how to differentiate it then? So please remember, a late sign of breast abscess which can be present. A late sign of breast abscess that they commonly give in the examination or in the question is usually a fluctuant mass or a fluctuant swelling. they will say there is a fluctuant swelling over the breast or there is a fluctuant mass over the breast, because this is a very characteristic finding on examination to differentiate between mastitis and between a breast abscess. So fluctuant swelling will be a late sign. If not that, they will definitely give the investigation of choice. And abscess is what? Pus collection. And pus is what? Fluid. And for fluid, what is the best friend of a fluid? Which investigation? Ultrasound. So here investigation of choice is definitely ultrasound of breast. And ultrasound usually shows you a pus filled cavity or a fluid filled cavity. And that is usually mentioned in your question as well. Okay. So they either mention a fluctuant swelling or they mention ultrasound showing a fluid filled cavity. Or they will classically give this image over here. What is seen in this image? You can see a fluctuant swelling over the breast along with the inflammatory signs. Okay, only inflammatory signs was mastitis, but a fluctuant swelling along with inflammatory signs is the case of breast abscess. Okay, so treatment is definitely what? Usually, according to clinical practice or according to Bailey also, please remember we will try 2 attempts of ultrasound guided aspiration. We will try 2 attempts of ultrasound guided aspiration, and even if that fails, then you go for incision and drainage. But in your examinations, a lot of times it was asked what is the best management. So therefore, best management is always incision and drainage. But clinical practice mein, we usually try 2 attempts of aspiration and then finally we go for an incision and drainage. And just answer me in the chat box. We discussed yesterday for incision and drainage, which is the number, which number blade is generally used. Okay. Which number blade is generally used? I'll continue with thyroid, then we'll take a break. Thyroid is smaller as compared to breast. Okay. So I'll continue with thyroid. Is it fine with everybody? Please let me know. Answer the question also and please let me know as well. Very good, Himanshu. It is the number 11 blade. Okay, very good, but it is the number 11 blade that we use. Shabash. So let's continue with thyroid now once and then we'll take a break. If I talk about thyroid now, thyroid is another gland that we need to study in endocrinal surgery. Important is this thyroid gland is located where? This thyroid gland is located in the middle part of your neck usually. Okay, and this thyroid is a shaped gland, as you know. All of you might be quite aware, this thyroid gland is actually a butterfly shaped gland. It has this first lobe, it has the second lobe, and connecting the first and the second lobe, we have the isthmus. Connecting the first and the second lobe, we have the isthmus. Thyroid is supplied by 3 main arteries. What are these arteries? Superior thyroid artery, inferior thyroid artery, and the thyroid ema artery. Okay. Then thyroid is drained by 3 main veins. Superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Now the question was, which is the most common vessel ligated during thyroid surgery? The most or the first vessel, the better answer would be, the better question will be the first vessel ligated during thyroid surgery. Okay, so please remember the first vessel ligated during thyroid surgery is the middle thyroid vein. The first vessel ligated during a thyroid surgery is the middle thyroid vein, and that has been a PYQ. Please remember that has been a PYQ. Middle thyroid vein is the first one to be ligated. Please remember that. Okay. Now important is this thyroid which is there, it lies in close relation. You might have studied this in ENT also. It lies in close relation to 2 nerves. At the superior pole of the thyroid gland, we have this nerve called as ELN. And what is ELN? ELN means external laryngeal nerve. So ELN is external laryngeal nerve. It is nothing else but the external branch of superior laryngeal nerve, which also supplies your larynx, right? So it is external branch of superior laryngeal nerve. Next one that lies in close relation to the inferior pole of thyroid. The one which lies in close relation to the inferior pole of thyroid is the RLN. That is recurrent laryngeal nerve. That is known as recurrent laryngeal nerve. So please remember, during thyroid surgery, there is very high risk that both these nerves can be injured. While you are removing the thyroid, जब तुम thyroid निकाल रहे हो ना, there is a very high risk कि इन दोनों में से कोई एक nerve injure हो सकती है. ठीक है? So I talk about that during thyroidectomy surgery. Now let's start discussing about some benign conditions of thyroid. And the first one that I'll discuss over here, it is this. Okay? So here I have what? Here you need to make a diagnosis for me. Okay? Here you need to make a diagnosis for me. Okay? So please remember, usually here I have a child or I have an adolescent. Okay, I have a child or an adolescent patient who is coming to me, and the main complaint of the patient is a midline neck swelling. The main complaint of the child is a midline neck swelling, as you can see in the image. Okay, it is a midline neck swelling. And what is the characteristic feature of this midline neck swelling? That this midline neck swelling moves with what? Whenever the child swallows something, that is deglutition. Okay, so this midline neck swelling moves with deglutition or protrusion of tongue. That means जब भी ये बच्चा कुछ निगलता है या टंग जबान हिलाता है, तब ये midline neck swelling जो है ना वो मूव करती है उसके साथ. Okay, so this midline neck swelling moves with deglutition or protrusion of tongue. That is a characteristic feature. What is your likely diagnosis? Thank you so much, Raj. Means a lot. Very good, Mohit. So it is a case of, very good, Raja also. Okay, so it is a case of not ectopic thyroid. It is not an ectopic thyroid. It is a case of thyroglossal cyst. So please remember, this is a classical case of thyroglossal cyst. Okay, it is a case of thyroglossal cyst. Important is just understand once. I am explaining now. Please remember, where is thyroid formed? So please remember, sorry, thyroid is formed on the tongue. And where on the tongue? At the junction of anterior 2/3 and posterior 1/3 of the tongue. And what is this site called as? This site where the thyroid is formed on the tongue, this site is called as foramen cecum. Okay, this site is what is called as foramen cecum. So that has been asked. Please remember, where is thyroid formed? Thyroid is formed on the tongue at the junction of anterior 2/3 and posterior 1/3 at a site known as foramen cecum. Once the thyroid is formed on the tongue, then it goes down into the neck. Then it goes down into the neck via this tract, and this tract is known as the thyroglossal tract. It goes down into the neck with the help of a tract known as thyroglossal tract. Now, once the thyroid goes into its original position in the neck, then what will happen? This thyroglossal tract will obliterate or it will disappear. Okay, एक बार thyroid जो होता है वो एक बार neck में आ गया तो thyroglossal tract क्या हो जाता है? गायब हो जाता है. But in some patients, what happens is this thyroglossal tract remains open. Okay, this thyroglossal tract remains patent. And what happens? There is collection of fluid in this thyroglossal tract. So when there will be collection of fluid in this thyroglossal tract, that is what is called as a thyroglossal cyst. समझ गए? So when there is collection of fluid within this thyroglossal tract, that leads to formation of a thyroglossal cyst in the patient. The question was, what is the most common site of thyroglossal cyst? Now, that was a previous year question, and I hope all of you are able to answer that. The most common site of a thyroglossal cyst, you need to remember, it is beneath the hyoid bone. Okay, just a minute. The mirroring was stopped. The most common site of this thyroglossal cyst is usually beneath the hyoid bone, and that is what is called as subhyoid. I need to use another one. That is what is known as subhyoid, also known as infrahyoid. Okay, so the most common site is subhyoid or infrahyoid. That was a previous year question. No issues with this, anybody? So the diagnosis of thyroglossal cyst has been asked, the site has been asked, and important, treatment has been asked. So what is the treatment for a thyroglossal cyst now? Please tell me. The treatment for a thyroglossal cyst is क्या निकालोगे? Definitely you will remove the thyroglossal cyst, guys, right? Then you will also remove the thyroglossal tract so that again it should not form. And definitely you will see that the hyoid bone is very closely attached to the thyroglossal tract. Therefore, at times you also need to remove some part of the hyoid bone also. That surgery is what is called as the cyst trunk surgery. That surgery is known as the cyst trunk surgery or the cyst trunk operation. No issues with this. Next condition in relation to this only. If a patient was suffering from a thyroglossal cyst, okay, if a patient was suffering from a thyroglossal cyst, and in a case of thyroglossal cyst, I performed an incision and drainage. I did not perform a cyst trunk surgery. Rather, I performed an incision and drainage. Or this thyroglossal cyst underwent a rupture. फट गया वो. Okay, एक तो मैंने IND कर दिया या फिर this thyroglossal cyst underwent a rupture. दोनों में से एक हुआ. So now what will happen definitely? Please remember, this will lead to formation of a thyroglossal fistula. This will lead to formation of a thyroglossal fistula. Now in simple terms, understand what is the basic difference between a sinus fistula and a diverticulum. Important is just understand it once, so it will be much easier for all of you. Now, if there is a abnormal connection or abnormal communication between two organs, this is what is called as a fistula. Abnormal communication or abnormal connection between two organs. One of the organ can also be the skin. Skin is also an organ. Okay? So abnormal communication between two organs is a fistula. Next, if there is only one-way communication with the organ, if there is only a one-way communication with an organ. That means it is a blind tract. It has only single opening. It is a blind tract. This is what is called as a sinus. Only one-way communication with an organ, or one-way communication with skin usually is known as a sinus. And third important, if there is one-way communication with an organ only, if there is one-way communication with an organ only, or we can say, okay, so one-way communication with an organ, or there is an outpouching from an organ, and this outpouching from an organ is what is called as a diverticulum. Outpouching from an organ is known as diverticulum. So these are the three important things, okay? So that I wanted to tell you. So please remember this, okay? Chalo. So going back to our topic. Is, we were talking about thyroglossal cyst. So definitely incision and drainage or rupture of a thyroglossal cyst leads to formation of a thyroglossal fistula. Usually it is formed in the lower part of a neck. And what is seen in the lower part of a neck? Opening will be seen in the lower part of the neck. That is what is a thyroglossal fistula. What is the treatment of thyroglossal fistula? It is same. And this has been asked. What is the treatment of thyroglossal fistula? Don't worry, it is the same one, that is the cyst trunk surgery. Okay? That is remove the tract and part of a hyoid bone as well. Moving further, talking about enlargement of the thyroid gland. And if I talk about enlargement of the thyroid gland, I hope all of you are quite aware. What is enlargement of thyroid gland called as? Enlargement of thyroid is known as what? All of you are quite aware that enlargement of thyroid gland is what is called as a goiter, right? Enlargement of thyroid gland is what is known as a goiter. That's important, okay? So if there is only swelling or if there is only enlargement in the neck, this is a normal type of goiter. But sometimes the swelling can be so massive. Sometimes swelling itni zyada badi ho sakti hai. What will happen in that cases? The swelling or the thyroid will enlarge behind the sternum. So please remember, this is the neck of the patient. This is the chest of the patient. You have the sternum bone over here. Now this thyroid is enlarging so much that it grows behind the sternum. And this type of a goiter will be called as retrosternal goiter. This is the case of normal goiter. See, this is the case of normal goiter. Na? The case of normal goiter which is present only in the neck. But here you can see, here the patient is not having neck swelling as such. Okay, no huge neck swelling. But you can see there is swelling on the chest. Why? Behind the sternum, the thyroid is enlarging in size. So this is what is the case of retrosternal goiter. This is what is the case of a retrosternal goiter. No issues with this, anybody? That's important. Please remember that, okay? Now, if I talk about what is the most common cause of a goiter, okay? What is the most common cause of a goiter? I need an answer for this. A lot of you should answer this. Medicine. Okay, so most common cause for goiter, please tell me that. There can be various types of goiter. It can be a simple nodular goiter when there is only one nodule formed in the thyroid gland. First thing. Second, it is a diffuse goiter. What do I mean by diffuse goiter? There is a uniform enlargement of the thyroid gland. पूरी thyroid gland एक जैसी enlarge हो रही है. That is a diffuse goiter. Okay, next can be a toxic multinodular goiter. What do I mean by toxic multinodular goiter? That means the thyroid is growing into multiple nodules. Such kind of enlargement is what is called as a multinodular goiter. Very good, Himanshu. It is iodine deficiency. Overall, the most common cause of goiter or thyroid enlargement is iodine deficiency. Please remember. Okay, it is iodine deficiency. That you need to remember for sure. And iodine deficiency is not seen in one patient, right? अगर आयोडीन की कमी है वो इस इलाके में सबकी कमी होगी. That means usually in India we had it earlier, but अभी हमारे पास क्या है? देश का नमक, टाटा नमक. That's the reason why due to iodized salts now in India the incidence of iodine deficiency goiter has gone down. It is still high in the countries like Africa, usually the African countries. Okay? So over there a lot of people have iodine deficiency and therefore most of them develop goiter. That is what is called as an endemic goiter. Okay, that is what is known as an endemic goiter. Please remember. Okay, there will be third part as well. No, surgery is huge. There will be third part as well. Okay, yes, hilly areas mein it was more common, but nowadays it is not seen in our hilly areas also. Himachal mein it was common because we have iodized salts. Okay, so that's important. You need to remember this one. Now, important is what is the treatment of this condition. Okay, so what is the treatment of this condition? So usually treatment of this condition is either we can go for a radioactive iodine therapy in the patient. Okay, we can go for radioactive iodine therapy. First of all, we will only try iodine in the patient. We will only give iodine if it is due to iodine deficiency. We will only give iodine to the patient if it is due to iodine deficiency. But if it has grown too much in size, then we can try a radioactive iodine therapy or we can go for a surgical excision. Better is definitely surgical excision. We will go for a surgical excision of the thyroid, definitely. Okay, no issues with this, anybody? So that's important. Now, if I talk about retrosternal goiter, this is the classical question which came in your examination. Okay, in retrosternal goiter, if there is a retrosternal goiter and you ask the patient to elevate both of his arms above the head, okay, उस patient को बोलो दोनों हाथ सर के ऊपर उठाए. What will happen? This retrosternal goiter which is there, it will compress the superior vena cava. And as it compresses the superior vena cava, therefore, blood is not able to drain into the heart. All that blood will remain in the face of the patient. Okay. And that causes facial congestion, or it causes facial plethora, also known as redness in the face, as you can see. And this sign which is seen in a case of retrosternal goiter is characteristically known as the Pemberton's sign or the Pemberton's test. Okay. So this test or the sign which is seen in a case of retrosternal goiter is known as the Pemberton's test or the Pemberton's sign. That is, on bilateral arm elevation, there is a facial plethora which is seen. Okay, important. ये चाचा याद रखने हैं. ये चाचा इमेज में आए थे, यही इमेज आई थी तुम्हारे एग्जाम में. Moving further now. No issues with this, anybody? Important is retrosternal goiter can be a primary retrosternal goiter or a secondary retrosternal goiter. What is the basic difference? I'll just explain it to you. Primary retrosternal goiter, that means there was some ectopic thyroid tissue in the mediastinum in the patient, and there was enlargement of that thyroid tissue itself. So it was actually a mediastinal goiter. But secondary ka matlab, this enlargement started from the neck and then it grew into the mediastinum. Okay, the enlargement of thyroid tissue started from the neck and then it grew into the mediastinum. 90% of retrosternal goiters are secondary. 90% of the retrosternal goiters are secondary, and therefore a question which has been asked, that which incision is commonly given for a surgical excision of retrosternal goiter? Is it a chest incision or a neck incision? So you need to remember, most of the cases start in the neck itself, so we only prefer a neck incision in cases of retrosternal goiter itself. Very rarely, only 2% cases, definitely. Please remember, it is 2% cases, please remember, which will 10% cases which can require a sternotomy. And what is sternotomy? Giving an incision over the sternum and opening up the thorax of the patient. Please remember this. No issues with this, anybody? That's the important thing. So you need to remember that. Okay. Now talking about an important condition, and that not important investigation, and that is, what is this? What is this? This is what is a radioactive iodine scan. This is what is a radioactive iodine scan. Now, thyroid जो होता है ना, thyroid की एक प्रेम कहानी होती है. Okay, so thyroid has a love story, and what is that love story? Thyroid is in madly love. Sorry, thyroid is in love with a girl madly, and who is that girl? That girl is iodine. Okay, so thyroid loves iodine too much. Wherever it will see iodine, it will take up that iodine. Wherever it will see iodine, it will take up that iodine. Okay, whether that iodine is harmful for thyroid or beneficial for the thyroid, it will not even think about that. ठीक है, तो जैसा तुम्हारे साथ होता है, बस लड़की दिख जाए तो definitely, okay, whether it is harmful for you or beneficial for you, you go behind her. So that what happens with thyroid also. So that's the important thing. So usually that happens over here. So radioactive iodine scan mein, usually we take this, we take the benefit of this property of thyroid. The thyroid always takes up iodine. So here also we give a iodine to the body, but this iodine is not the normal iodine. This is a radioactive iodine. And what is the special feature about a radioactive iodine? It will emit radiations. Ye radiation chhodega. This will be harmful for the thyroid. Okay. So for radioactive iodine scan, we usually give a radioisotope of iodine. And please remember, we know that radioactive iodine scan is not only used for treatment, but it is also used for diagnosis. Okay. It can also be used for treatment as well as diagnosis. For diagnosis, the radioactive isotope of iodine that we use, okay, the radioactive isotope of iodine that we use is what is the most common one is iodine 123. It is iodine 123. The half-life has been asked. So the half-life or the duration of action of iodine 123. Beech ka do hata do. Okay. So the half-life is what is 13 hours for iodine 123. The half-life is around 13 hours for vice versa. So half-life of iodine 123 is 13 hours. The others is definitely iodine 125 and iodine 127, which are used for diagnosis. Why these ones are used for diagnosis? Because they stay in the thyroid for a very short duration of time, for a few hours itself. So once thyroid takes up this iodine, These iodine will emit radiations. We can take a image with the help of a gamma camera. Okay, we can take an image with the help of a gamma camera, and definitely then this thyroid will go off. Okay, this thyroid will be perished. So that is what we want. We want a very short acting radioactive iodine for diagnosis. But for treatment, we want this iodine to stay. Okay, for treatment, we want this iodine to stay for a longer duration of time. Therefore, for treatment, we prefer iodine who is having a longer half-life. Okay, we prefer iodine which is having a longer half-life. So it will stay in the thyroid gland for a longer duration of time, and it will damage the thyroid cells. It will start damaging these thyroid follicular cells. And if the thyroid cells are damaged, definitely there will be decreased T3 and T4 production in the patient. Okay, so that's the important thing. So treatment ke liye we prefer iodine 131, as most of you have answered in the question as well. Iodine 131, it has a longer half-life, as I've told you, and the half-life of iodine 131 is around 8 days. Okay, so these have been the questions. Okay, the half-life of iodine 131 is 8 days. Now, important question that I want to ask you, definitely treatment, as I've told you, iodine 131 or the radioactive iodine therapy can be used in conditions where there is excess amount of T3 and excess amount of T4 which is secreted by the thyroid gland. So that we will give iodine which will emit which radiations. So that's important. This radioactive iodine emits beta radiations or beta rays. Okay, and these beta rays will cause what? These beta rays will damage the thyroid follicles. So once the thyroid follicles are damaged, the levels of T3 and T4 will come down. So radioactive iodine therapy is used for which condition? It is used for treating, please remember, it is used for treating any cause of hyperthyroidism. It is used for treating causes of hyperthyroidism like Graves' disease or thyroid cancer. It is used for treating hyperthyroidism, that is Graves' disease or thyroid cancer. And this has been asked, which rays are emitted? Okay, radiology plus surgery question. Which rays are emitted? Please remember, it is the beta rays which are emitted. Important is my question to you is, which was the recent FMG examination question in June 2022. The question was, please remember, like, okay, which radioactive isotope of iodine is used for brachytherapy in cases of prostate cancer? So which radioactive isotope of iodine is used for brachytherapy in cases of prostate cancer? So please answer this question to me. Till that, I'll further move with the images of radioactive iodine scan. If I talk about the radioactive iodine scan, okay, this one that you can see over here, there is decreased uptake of iodine in a specific part of thyroid. That means this part of thyroid is not functioning properly. So this is what is called as a cold nodule, or it is called as the non-functioning nodule. Okay, next one you can see, in certain part of the thyroid, okay, certain part of thyroid is taking up more amount of iodine. That means this part of thyroid is working overtime. That means this is what is called as a hot nodule, where there is more uptake of iodine, also known as hyper-functioning nodule. My next question to you is, very good. Okay, very good all of you. It is iodine 125. That was a previous year question. Please remember this. So iodine, a lot of people thought treatment of prostate cancer. So a lot of people thought it is iodine 131 only. No, iodine 131 is used for treatment within the thyroid gland. But if they say brachytherapy in prostate cancer, answer is iodine 125. Okay, that was a PYQ of FMG. Next important is, now please tell me which nodule will have higher risk of malignancy. Okay, which nodule will have higher risk of thyroid cancer? Is it the cold nodule or the hot nodule? Please let me know that. Then, if all the parts of thyroid are having increased uptake of iodine, diffuse increased uptake is what is the case of hyperthyroidism, and we know the most common cause of hyperthyroidism is Graves' disease. Next, if there is diffuse decreased uptake, as you can see in this condition, throughout the thyroid gland there is decreased uptake of iodine. This is called as diffuse decreased uptake, and this is what is cause of thyroiditis. This is because of thyroiditis, which is the most common cause of hypothyroidism in India. Most common cause of hypothyroidism worldwide is iodine deficiency, but in India it is Hashimoto's thyroiditis. Okay, very good all of you. It is the cold nodule. A lot of people can make mistake. Please remember, cold nodule has high risk of malignancy as compared to a hot nodule. Here the risk of malignancy is 20%, whereas in hot nodule the risk of malignancy is only 4%. And they knew that a lot of people are going to make a mistake over here, therefore they have asked this question earlier. Okay, that's important. Okay, and if you are able to see some parts of cold nodules and some parts of hot nodules within the thyroid gland, then this is what is suggestive of a toxic multinodular goiter. That is what is suggestive of a toxic multinodular goiter. Chalo. Moving further, then talking about a very important topic, and that is what is thyroid tumors. To understand thyroid tumors, just understand the cut section of a thyroid follicle. Okay, so I have taken a cut section of thyroid. These are the thyroid follicles which are there. Okay, so in thyroid follicles we have these cells, and what are these cells called as? So these cells are the cells which are responsible for production of T3 and T4, that is thyroid hormones, and these cells which are present within the follicle are called as the follicular cells. Okay, so these are called as the follicular cells, and there will be some cells between the thyroid follicles, and these cells which lie between the thyroid follicles are called as parafollicular cells of thyroid. Okay, a lot of people are confused that parafollicular C cells are present in parathyroid gland. No, parafollicular C cells are present within the thyroid gland, in between the follicles. Okay, and there will be third important types of cells. These are called as lymphoid cells. Now a lot of people will feel lymphoid. Yes, lymphoid cells का काम क्या होता है? Lymphoid tissue का काम होता है to act as a local watchman or a policeman. Okay, lymphoid cells will fight infection in every organ. So there are lymphoid cells in every organ of your body. Okay, important is to understand the cancers. Please remember, if the cancer arises from the follicular cells, okay, then it will be called as differentiated or undifferentiated thyroid cancer. So the cancer can either arise from the follicular cells, or it can arise from the parafollicular cells, or it can arise from the lymphoid cells. That I had to tell you. Okay, let's talk about the thyroid tumors now. If I talk about the thyroid tumors, guys, important is, if I talk about the thyroid tumors, please remember, if they ask you which is the most common benign thyroid tumor, if they ask you which is the most common benign thyroid tumor, answer should be a follicular adenoma. Okay, so please remember, the most common benign thyroid tumor answer is follicular adenoma. Then if they ask you malignancies or the malignant tumors, okay, so usually just like any other organ, thyroid can also have metastasis from other primary cancer, and if there is metastasis from other primary cancer, this is called as secondaries. This is what is called as secondaries. But there can be some cancers which will arise from the thyroid cells. Okay, कुछ cancers ऐसे होंगे जो thyroid में खुद में बनेंगे, बाहर से नहीं आ रहे. Okay, so there will be some cancers which will arise from the thyroid cells itself, and these are called as primary thyroid cancers. These are known as primary thyroid cancers. Important is, if the cancer arises from the follicular cells, I told you it can be either differentiated thyroid cancer or it can be undifferentiated thyroid cancer. Just to understand the basic difference between both of this, you will say, sir, both of them are arising from follicular cells now. So what's the basic difference? So differentiated means the cells you are able to make out easily. Okay, whereas in undifferentiated, here you can see the architecture is completely distorted, it is completely disturbed. In simple terms, undifferentiated का मतलब होता है खिचड़ी, तुम्हें नहीं समझ में आ रहा कुछ भी उसमें. ठीक है, तो it is undifferentiated cancer. No issues with this, anybody? So differentiated thyroid cancers can be either follicular carcinoma of thyroid or it can be papillary carcinoma of thyroid. So follicular thyroid cancer or papillary thyroid cancer. Whereas anaplastic thyroid cancer is a version of undifferentiated thyroid cancer. Anaplastic is nothing but undifferentiated thyroid cancer. Next, if I talk about the one which will arise from the parafollicular C cells, okay, the one which will arise from parafollicular C cells is called as medullary carcinoma of thyroid. The one which arises from the parafollicular C cells is known as medullary thyroid cancer, and the one which arises from the lymphoid cells will be called as thyroid lymphoma. The one which will arise from the thyroid cell will be called as thyroid lymphoma. If I talk about important, which is the most common one first of all, okay, so please remember the most common type of thyroid cancer that you need to remember. The most common type of thyroid cancer, okay, so the most common type of thyroid cancer is the papillary thyroid cancer. The most common type of thyroid cancer is the papillary thyroid cancer. Important, okay, and papillary thyroid cancer is more common in which age group? Now please remember, papillary is also differentiated and follicular is also differentiated. So you need to remember two important things. One, the age group of the patient. Second, the risk factors in the patient. And these two will help you make the diagnosis very easy. Okay. So in papillary thyroid cancer, the more commonly the age group which is involved is the younger population. That is people between the third or the fourth decade of life. So usually the third or fourth decade of life, that is people between 20 to 40 years of age commonly. Okay. And apart from this, what are the risk factors associated with papillary thyroid cancers? So the risk factors which are associated, two important ones. If a patient is having a long standing, for longer time, the patient was having a thyroglossal cyst. We discussed about thyroglossal cyst now. So if a patient was having a long standing thyroglossal cyst, or second, if the patient was having a radiation exposure. So the patient had some cancer earlier for which he was given a radiotherapy. That is a risk factor for developing papillary thyroid carcinoma. So long-standing thyroglossal cyst or radiation exposure. Okay? That's important. What is the complaint? Definitely in cases of papillary thyroid cancer or any type of thyroid cancer, patient will have a mass or a swelling in the neck. That is usually complaint. And if the thyroid cancer grows too much in size, बहुत ज़्यादा बड़ा हो जाता है, then it starts compressing the trachea, and then the patient will definitely have pressure symptoms. And what are these pressure symptoms? The patient will have dyspnea, that is सांस लेने में दिक्कत होगी, or the patient will have stridor, or the patient can have dysphagia, or the patient can have hoarseness of voice. Why there is hoarseness of voice? Due to damage or due to involvement of the recurrent laryngeal nerve. Okay? So that can happen. Now important is what will be the investigation of choice over here. The investigation of choice over here is definitely a ultrasound, because for thyroid usually you can easily perform a ultrasound because it is very superficial. बहुत ऊपर है ये, ठीक है? So ultrasound should be done. Along with that, we will also take a FNSC, fine needle aspiration cytology. And once we take a FNSC or a biopsy, I'll be able to see this kind of a feature. And what is this feature you can see over here? You can see that the malignant cells which are there, the cancerous cells, their nuclei does not have a nucleoli. It looks like the eyes of a cartoon which came in 80s or 90s, that was called as Orphan Annie. Therefore, in cases of the biopsy or FNAC, in cases of papillary thyroid cancer, we have this Orphan Annie nuclear appearance. Sarkari question of your exam. Sarkari, Bakaida Sarkari. Okay, this is what is called as Orphan Annie nuclei appearance. This is characteristically known as the Orphan Annie nuclei appearance. Whereas the other feature which is seen, there will be something, these kind of calcified concentric bodies. What are these calcified concentric and lamellated bodies called as? These calcified concentric and lamellated bodies are known as. These will also be seen in cases of papillary thyroid cancer. Jaldi se answer it once. So those are known as, those are a type of dystrophic calcification in this cancer. Very good all of you. And that is what is called as the Samoma bodies. Okay, those were called as the Samoma bodies. Samoma bodies ka mnemonic you need to remember. Samoma bodies are seen in PSM. Samoma bodies are characteristically seen in PSM. P stands for papillary thyroid cancer, and second is papillary renal cancer. S stands for serous cyst adenoma of ovary. S stands for serous cyst adenoma of ovary. M stands for meningioma or mesothelioma. M stands for meningioma or mesothelioma. That's important, okay? So that was about your papillary thyroid cancer. I'll talk about treatment at once itself, okay? Whereas in some conditions, what can happen? There can be a occult or a hidden papillary thyroid cancer. Occult or a hidden papillary thyroid cancer means what? Here, can you see any neck swelling in the patient in the midline? No, there is no midline neck swelling which is seen in the patient over here, okay? So you can see there is a hidden papillary thyroid cancer. Why? Because the patient is having a papillary thyroid cancer, due to which there is a metastasis to the lymph nodes in the neck. Due to which there is metastasis to the lymph nodes in the neck. Okay. So once we take a biopsy or FNSC from this lymph node, I'll be able to see cancerous thyroid cells in that. Okay. So that is what is the metastasis from a hidden papillary thyroid cancer. Okay. So if there is metastasis to lymph nodes from a hidden papillary thyroid cancer, this is what is called as lateral aberrant thyroid. This is what is called as lateral aberrant thyroid. Okay, so this is what is known as lateral aberrant thyroid. Please remember this. Okay, no issues with this, anybody? So that is important usually. That is what is important. Chalo. No issues with this, anybody? Then once we are done with this, next one that we are going to discuss is this one, that is follicular thyroid cancer. Important is follicular thyroid cancer is the second most common thyroid cancer. Follicular thyroid cancer is second most common thyroid cancer, or just follow the statement properly. It is the most common thyroid cancer. It is the most common thyroid cancer in cases of iodine deficient areas. Okay, so wherever there is iodine deficiency, then the most common thyroid cancer can be follicular thyroid cancer. Okay, that is the important treatment you need to remember. Overall, most common is papillary thyroid cancer, but in iodine deficient areas, most common is follicular thyroid cancer. What did I tell you? Age will be the one differentiating feature. So over there in papillary, younger population between third and fourth decade was involved. Here, people more than 50 years of age will be commonly involved. Next important here, important is what is the risk factor. Over there it was long standing thyroglossal cyst and radiation exposure. Here it is usually a multinodular goiter. Okay, as you can see in this picture, there is a multinodular goiter in this female. That is an important risk factor for developing follicular thyroid carcinoma. So these are the two important keywords for you to take up. Important is what is the investigation which is done for follicular thyroid carcinoma. Okay, important is, okay, it is usually, please remember, important one to be remembered is over here the FNSE that we used to do in cases of papillary thyroid cancer, it is not useful, and this is a Sarkari question again which has been asked in the recent neetpg and in multiple FMGE examinations as well. FNSE is not useful to make a diagnosis in follicular thyroid cancer. Reason, they have asked you the reason in the recent exam, and that is important. Please remember why it is not useful, because it cannot differentiate. It cannot differentiate between, FNSE cannot differentiate between a follicular adenoma, which is a benign tumor, and a follicular carcinoma, which is a malignancy. That's the reason why, as it is not able to differentiate between a follicular carcinoma and adenoma, it is not useful to make a diagnosis of follicular thyroid cancer. Okay, because over here we only have cells, we have cells in cytology, na? So that's important. No issues with this, anybody? Chalo. Okay, so that was the two important cancers. The third one, which arises from the parafollicular C cells, the one which arises from the parafollicular C cells. Okay, so the one which arises from the parafollicular C cells is called as medullary thyroid cancer. And this medullary thyroid cancer, please remember, usually you need to remember this, it arises from parafollicular C cells. And these parafollicular C cells are known to secrete a hormone. And what is that hormone? So these parafollicular C cells are known to secrete a hormone known as calcitonin. Therefore, the tumor marker for all other thyroid cancers, the tumor marker for all other thyroid cancers is serum thyroglobulin. For all other thyroid cancers, the tumor marker is serum thyroglobulin. But for medullary thyroid cancer, the tumor marker, the better tumor marker is calcitonin. The better tumor marker is calcitonin. No issues with this, anybody? That's important. Now, important you need to remember is, in medullary thyroid cancer, the patient will definitely have neck swelling. Okay, neck swelling is seen in any type of thyroid cancer. Here also the patient will have neck swelling. But along with that, these cancerous cells will also secrete a lot of serotonin, and therefore the patient suffers from serotonin syndrome. So, usually in a case of medullary thyroid cancer, the patient suffers from serotonin syndrome also. Important is that to be remembered. Next, medullary thyroid cancer is associated with which syndromes? Medullary thyroid cancer is seen in patients suffering from which syndrome? So the answer should be MEN2A and MEN2B syndrome, multiple endocrine neoplasia. MEN2A and MEN2B syndrome. The patients who are suffering from MEN2A, that is Sippel syndrome, or MEN2B syndrome, they are at a higher risk of developing medullary thyroid cancer. And the gene which is mutated over here is known as the red proto-oncogene. The gene which undergoes mutation in these syndromes is known as red proto-oncogene. If I do a true cut biopsy in this patient, I'll be able to see such kind of a picture. This pinkish appearance which is seen, it is nothing but the amyloid rich stroma. So if they mention that the FNSE or biopsy is showing a amyloid rich stroma, then definitely, please remember, your diagnosis should be medullary thyroid carcinoma. Your answer should be medullary thyroid carcinoma. Okay, no issues with this. Now if I ask you, among all the thyroid cancers, which one has the best prognosis? Among all the thyroid cancer, which has the best prognosis and which one has the worst prognosis? Please let me know that first. Say which one has the best prognosis, which one has the worst prognosis. More than enough, bhai. I'm trying to cover almost everything. Okay, So please let me know which one has best and which one has worst prognosis usually. Very good. Best prognosis is seen with papillary thyroid cancer. Best prognosis is seen with papillary thyroid cancer. But worst prognosis is seen with khichdi. Worst prognosis is seen with khichdi, and that is what is anaplastic thyroid cancer. Worst prognosis is seen with khichdi, that is what is anaplastic thyroid cancer. Anaplastic thyroid cancer, important points, it is more common in 6 to 7 decade of life. That means very elderly patient. It is more common in 6 to 7 decade of life. Here the patient will have a hard swelling. Okay, when you palpate the swelling, there will be a very hard swelling. The patient will also have pain. Okay, there will be a painful swelling in a case of anaplastic thyroid carcinoma. Please remember that. Okay, so that is usually seen, and the patient will have signs and symptoms of invasion. What do I mean by invasion? That means आसपास के structures को involve या damage कर रहा है. The patient will have signs and symptoms definitely of hoarseness of voice, dyspnea, stridor, dysphagia, all of these. Okay, so that is very characteristic. Moving further, now talking about the TNM staging, just important. Not so important as breast cancer. Breast cancer is ज़्यादा important. Okay, but it is similar to breast cancer. Okay, so T1 is nothing but a cancer less than equal to 2 centimeters in size. T2 is more than 2 centimeters but less than equal to 5 centimeters. Okay, so T2 is more than equal to more than 2 but less than equal to 5 centimeters. T3 is more than 5 centimeters, and T4, important, T4 is nothing but extra thyroidal extension. When the cancer spreads beyond thyroid now, that is what is called as T4, extra thyroidal extension. Important is there is an update over here that you need to remember. T3B, which is there, it is a new category. T3B is suggestive of strap muscle involvement. Yes. So you will say, sir, आपने तो बोला कि extra thyroidal is T4. Yes, but except strap muscles. So strap muscle is T3B. Strap muscle are nothing but ribbon muscles of your neck. Omohyoid, sternohyoid, sternothyroid, thyrohyoid, all of these hyoid wala muscles. So these strap muscles of neck, if they are involved, it is T3B. That you need to remember. ये important है, याद रखना बस, ठीक है? No issues with this. Now talking about the management or treatment in a case of thyroid cancer. Now we know we will remove the thyroid definitely if a patient is suffering from thyroid cancer, and that removal is what is called as ectomy. So thyroidectomy. If I talk about thyroidectomy, guys, important is if we only remove one lobe of the thyroid, that is called as lobectomy. But that is not commonly practiced nowadays. Not even for cancer, not even for any other condition. Next is hemithyroidectomy. Hemithyroidectomy is removal of one lobe of the thyroid along with that connection. And what was that connection called as? Isthmus. So one lobe plus isthmus, if it is removed, it is called as hemithyroidectomy. Subtotal thyroidectomy, please remember, subtotal thyroidectomy is usually leaving behind 5 to 8 grams of thyroid. So 5 to 8 grams of thyroid is saved. We remove most of the thyroid, but at least 5 to 8 grams of thyroid is saved. And what is a total thyroidectomy? Please remember, total thyroidectomy means removal of both the lobes. We will remove both the lobes of thyroid along with the isthmus. Remove both the lobes of thyroid along with isthmus. Better for thyroid cancer is always a total thyroidectomy. Better for thyroid cancer is always a total thyroidectomy. Some people will ask, sir, what is near total? So near total is nothing but leaving behind 1 to 4 grams of tissue. 1 to 4 grams of thyroid is saved. That is what is near total, also known as Hartley-Dunhill procedure. Done with this. Now important is the complications of thyroidectomy. That has been commonly asked. So if they ask you, a patient underwent a total thyroidectomy surgery, now presents with perioral, that means around the mouth. Okay, there is paresthesia. What is paresthesia? Decreased the sensation. He is not able to feel proper sensations around mouth. And there is carpopedal spasm. What is carpopedal spasm? As you can see over here. This is what is carpopedal spasm. हाथ पैर टेढ़े हो गए patient के. What is the likely cause of this condition? Please tell me that. A patient underwent this thyroidectomy surgery. What is the likely cause? What can be the complication? This is the previous year question. If they ask you the most common complication after surgery, if they ask you most common complication of total thyroidectomy surgery, as we have discussed in all other surgeries also, here also the most common complication is hemorrhage or bleeding. Here also the most common complication is hemorrhage or bleeding. So very good. The answer, why the patient is having decreased sensation, or there is perioral paresthesia, numbness or tingling sensation along with this carpopedal spasm, the likely cause in this patient is hypocalcemia. A lot of you are definitely right. It is due to decreased serum calcium levels, hypocalcemia. But hypocalcemia हुआ क्यों इस patient में? I hope all of you are quite aware that this thyroid gland which is there, behind the thyroid gland we have small on the posterior aspect or thyroid gland ke piche, we have these four small glands. And what are these four small glands called as? These four small glands are called as parathyroid glands. So while you are removing the thyroid, जब thyroid निकाल रहे थे, गलती से क्या हो गया? The parathyroid glands were also removed. You have also removed the parathyroid glands. Now, once you remove the parathyroid glands, what will happen? There will be parathyroid insufficiency. Accidental removal of parathyroid glands causes which complication? The accidental removal of parathyroid gland during thyroidectomy surgery causes parathyroid insufficiency. What do I mean by this? There will be decreased amount of parathormone in the patient. And we know parathormone is known to increase serum calcium levels. As parathormone is low, definitely the serum calcium levels will also be low. And that causes hypocalcemia in the patient, and that leads to all of these features. The earliest and the most common symptom or the complaint of patient is perioral paresthesia, numbness or tingling sensation. But if they ask you the signs which are seen, one is called as the carpopedal spasm. This carpopedal spasm is also known as the Trousseau sign. This is also known as the Trousseau sign, also known as obstetrician's hands. Okay, when you inflate the BP cuff, patient will have this carpopedal spasm known as Trousseau signs or obstetrician's hands, which is the first sign of hypocalcemia. The second important sign is this one. When you tap along the facial nerve, patient will have facial twitching. Okay, there will be spasm of a group of muscles causing twitching or abnormal facial expression. This is what is called as the Chvostek sign. This is what is called as the Chvostek sign. Both of these are signs of hypocalcemia in the patient. Okay, so that's important. Please remember, this is a very important complication in the patient. Okay, and even after the thyroid surgery, the patient can have a post-operative respiratory distress. Yes, there can be post-operative respiratory distress after a thyroid surgery in the patient, and the most common cause for it is usually a laryngeal edema. Most common cause for it is a laryngeal edema, but other cause can be RLN injury as well. What is RLN? We know it as recurrent laryngeal nerve injury. So if there is a bilateral recurrent laryngeal nerve injury, that causes a post-operative respiratory distress after a thyroidectomy surgery. But if they ask you, which is the most common nerve injured during thyroid surgery? Which is the most common nerve injured during a thyroid surgery? I hope all of you are quite aware. It is not the RLN. More commonly, it is the ELN followed by RLN. Now, Bailey also has changed. Please remember. Okay, Bailey clearly says it is ELN followed by RLN. Don't follow the previous year norms. No. Chalo. Now take a break, 15 minutes of break, and then we'll get back and discuss vascular surgery starting with GIT then. Okay, sure. Welcome back, guys. Shall we start? If we start early, we'll be able to finish it off early. Let's start. JIT, don't worry, we'll not complete it today. We'll be continuing it tomorrow also, because tomorrow's topics will be urology, hepatobiliary, and hernia. Those are smaller. So if anything is left in JIT, we'll continue that further. Shall I begin? Just let me know in the chat box once I can begin. I'll just proceed. Okay, great. Sure. So now talking about vascular surgery, guys. Important again. Commonly questions have been asked from vascular. So at least remember the important things about vascular surgery. Not everything becomes important, but at least the important and the commoner ones have been repetitively asked in your exam. So let's start about vascular surgery. In vascular surgery, I'll be talking about three important things. First, definitely the arteries. In arteries, I'll be talking about two conditions. One, where there is a gradual arterial obstruction. When there is a blockage in the arteries, but that develops very slowly. धीरे 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 करके artery अगर block होती है, that is what is gradual arterial obstruction. Next, I'll talk about sudden arterial obstruction. Sudden, that means all of a sudden, अचानक से artery completely block हो जाती है. That is what is called as a sudden arterial obstruction. I'll talk about that. Next, definitely I'll be talking about veins. And in veins, definitely in the lower limbs, we will talk about the superficial veins and we will talk about the deep veins. In deep veins, we'll be talking about a disease known as DVT, deep venous thrombosis. Whereas in superficial veins, we will talk about a disease which is very important, known as varicose veins. Okay? Whereas lastly, I'll be talking about some topics or some points which are important for lymphedema. Okay? Now let's start with, first of all, that is gradual arterial obstruction. For those who are confused still, please remember gradual का मतलब होता है slow. Okay, gradual or slow arterial obstruction. Now please let me know what is the most common cause of gradual arterial obstruction. If they ask you the most common cause of gradual arterial obstruction, for example, consider this as your artery and there is a obstruction over here or a blockage over here. Why does a blockage develops in an artery? Usually due to formation of a thrombus, usually. Okay, or usually when a thrombus is formed, along with that the fat cells or the foamy cells come, then a fatty streak is formed, and then finally a plaque is formed. What is that plaque called as? Atherosclerotic plaque. Okay, that causes obstruction, blockage, or narrowing of a vessel, mainly the arteries. So that is what is the cause. The most common cause of gradual arterial obstruction is what is called as atherosclerosis. The most common cause of gradual arterial obstruction is what is called as atherosclerosis. Now a lot of people are confused between atherosclerosis and the second most common cause of gradual arterial obstruction, called as Berger's disease. Now just call it Berger's always. The reason being because Berger's is also IgA nephropathy. To avoid that confusion, for your understanding, always call it Berger's. So that becomes very easy. Okay, so that's important. Now the risk factor for both these conditions is smoking. In the recent examination, there was a question, and the question was, a 52-year-old patient comes to you with complaints of a 52-year-old person has come to you with, he's a chronic smoker and he's complaining of pain usually. Okay, he's complaining of pain usually in the lower limbs. Okay, and there is also gangrene which has set in. Usually. Okay, so a lot of people marked it as Berger's disease. Please remember, important is you need to remember that most important factor or the most important risk factor for atherosclerosis as well as for Berger's disease, both of it is smoking itself. Okay, so the most important and the most common risk factor for both of them is smoking. If they say an elderly patient, yes, the chances of atherosclerosis will be more. Okay, so that's the important thing you need to remember over here. So atherosclerosis, if I talk about, as I've told you, it is more commonly seen in patients who are more than 50 years of age, that is usually elderly patients, and the risk will further increase if the patient is a chronic smoker, or definitely the patient is having obesity, or the patient is suffering from type 2 diabetes mellitus or hyperlipidemia. So all of these factors definitely increase the risk of atherosclerosis. Now in atherosclerosis, we know there is blockage of the arteries, and if this is the lower limb, if there is blockage of artery in the lower limb, what will happen? Blood supply distal to the blockage will be decreased. And if the blood supply distal to the blockage is decreased, definitely the patient will start having pain. So the earliest complaint of the patient, okay, the earliest complaint of the patient in cases of gradual arterial obstruction, the earliest symptom is when the patient starts walking, the patient experiences pain. When the patient is sitting normally, there is no pain. Okay, so please remember, जब patient बैठा है कोई दर्द नहीं हो रहा, but patient जैसे ही चलना शुरू करता है वैसे ही pain या दर्द start होता है. That is what is called as intermittent claudication. Please remember, this is what is known as intermittent claudication. That means pain usually when the patient starts walking. Okay, so as we know, whether it is atherosclerosis or it is Buerger's disease, both of these are more common in the lower limbs as compared to the upper limbs. Yes, okay, Buerger's as well as atherosclerosis are more common in the lower limbs as compared to the upper limbs. Okay, so usually when the patient starts walking, patient experiences pain, that is intermittent claudication. But when the patient starts writing and then there is pain, that is again suggestive of blockage in the upper limbs. Okay, that is called as writer's spasm. That is also a type of claudication in the upper limbs, that is known as writer's spasm usually. Okay, important is that. Then further what will happen, intermittent claudication ke liye ek important one liner that you need to remember. The intermittent claudication is classified according to a grading, and that name of grading is important. It is classified into 4 grades according to the severity of intermittent claudication, and that grading is called as Boyd's grading. So the question was, Boyd's grading is used for, so Boyd's grading is used for classification of severity of intermittent claudication. That's important. Okay, now intermittent claudication will further progress to what? Now intermittent claudication mein there was obstruction in the vessel, okay, but at least somewhat blood was there. Now when the blockage further increases, the patient will start having rest pain. Now whenever the patient is sitting also or standing also, the patient starts having pain. That is called as rest pain usually. And rest pain occurs due to what? Because there is decreased blood supply to the nerves, and if there is decreased blood supply to the nerves, what will happen? The nerves will get irritated, and due to that they start paining. That is called as rest pain, which is also known as cry of dying nerves. Okay, that is also known as cry of dying nerves. Once that happens, then definitely the patient will further progress to what? There will be coldness in the limb because decreased blood supply. There will be numbness in the limb, that is what is decreased sensations. Okay, or there will be paresthesias. Okay, along with this, definitely what will happen, the patient will also start having in the lower limb, okay, or distal to the obstruction, the patient will start having color changes also. There will be color changes in the skin as well, or there will be ulcerations as well. There will be ulcer as well. This is what is suggestive of pre-gangrene in the patient. All of these features are together suggestive of pre-gangrene, and further the patient will finally land up into gangrene. So again important, gangrene is not only a feature of Buerger's disease. Gangrene can be seen in any cause of gradual arterial obstruction or sudden arterial obstruction. Please remember. So gangrene जैसे ही देखा तो बस इतना नहीं सोचना है, ठीक है? So it can also be seen in a case of atherosclerosis. That's important. Okay. So this is the classification you need to remember. Now once they ask you what is the investigation of choice, so first of all, if I talk about examination, on examination you will try to palpate the pulse of the patient, and if you try to palpate the pulse distal to the obstruction, the pulse will be very low volume, right? Distal to the obstruction, as there is decreased blood supply, there will be a low volume pulse or a very feeble pulse. Whereas proximal to the obstruction se pehle, okay, there will be a high volume pulse which will be felt. There will be a high volume pulse which will be felt. Apart from that, you will also go for ABPI. What is ABPI? Ankle brachial pressure index. Okay, so ankle brachial pressure index is measured where we will measure systolic blood pressure at the ankle upon systolic blood pressure at the arm. Okay, the ratio is calculated, systolic blood pressure at ankle and systolic blood pressure at arm, and that has been asked. Please remember, normally it is between 0.9 to 1.3. Normally it is between 0.9 to 1.3. Please remember that. If it decreases to less than 0.9, that is what is suggestive of intermittent claudication. If it decreases to less than 0.9, that is suggestive of intermittent claudication. If it decreases to less than 0.5, that is suggestive of rest pain. If it decreases to less than 0.5, it is suggestive of rest pain definitely. Okay, and when it decreases to less than 0.3, that is suggestive of critical limb ischemia. That means now gangrene is inevitable to happen. Abhi gangrene hoke hi rahega. Okay, so when the ratio is less than 0.3, that's important. But if they ask you what is the investigation of choice, so if they ask you investigation of choice for any vessels, we will try to go for a non-invasive investigation. Non-invasive मतलब जहाँ patient को prick करने की जरूरत ना पड़े, where you do not need to prick a patient or when you do not need to insert anything in the oral cavity or anywhere in the patient. That is what is called as a non-invasive investigation. Please remember that. Okay. So for vessels, the non-invasive investigation, as these vessels are superficial in the limbs, na, so therefore we can just go for a type of ultrasound. And what is the type of ultrasound that we have? Usually we have a type of ultrasound which can tell you about the blood flow. Okay. So usually the blood which is coming towards the probe, it will be red in color. The blood which is going away from the ultrasound probe, it will be blue in color. That is what is called as color Doppler. Along with color Doppler is a video, for example, it will tell you about the blood flow. Along with that, we also do a ultrasound B scan, which takes a picture. So Doppler is a video, B scan is a picture. So definitely both of these are done together, and the investigation of choice together, both of these is what is called as a duplex scan. So the investigation of choice is a duplex scan for any type of gradual arterial obstruction, whether it is atherosclerosis or it is Berger's disease. So as I've told you, it is combination of two things, that is ultrasound, B scan and a color Doppler definitely. Okay. So that's important. If you need to mark single, if Doppler duplex is not an option, अगर duplex option में नहीं है, then mark it as color Doppler. Okay, if duplex is not an option, then mark it as color Doppler. Okay, so that's important. No issues with this. But if they ask you what is the gold standard investigation, if they ask you gold standard investigation, then please remember the gold standard investigation is usually the angiography. Okay, it is invasive. Please remember why angiography is not considered as the investigation of choice, because it is invasive. You need to prick the patient for that, and that's the reason why it is not the investigation of choice, but it is the best or the gold standard investigation, which will tell you about the blockage, how much blockage is there, at how many sites the blockage is there, and this is what is the angiography. The image was given and they just asked what is the below given investigation. So you see, when a contrast or when a dye is injected into the vessels and then an X-ray is taken or a CT is taken, that is what is called as an angiography. Graphy का मतलब होता है picture, angio का मतलब होता है vessel. So picture of a vessel is what is known as angiography. Here this one is a coronary angiography. That means angiography of heart vessels. And you can see there is blockage in the heart vessels over here. It is the left anterior descending artery or the left circumflex artery which is showing the blockages. Okay, so that is what is angiography. Just remember the picture. That's important for us. Important thing next, apart from this, I would like to tell you is sorry. Okay, important is which is the most common vessel. Which is the most common vessel affected with atherosclerosis? And the question has been asked earlier as well. The most common vessel affected with atherosclerosis is your abdominal aorta. Okay, so the most common vessel affected with atherosclerosis is abdominal aorta. Second most common are your coronary arteries which supply the heart. Okay, second most common are your coronary arteries which supply the heart. Okay, and the third most common is the popliteal artery. Third most common is the popliteal artery. And the question again was, which is the most common peripheral vessel affected with atherosclerosis? Now you know abdominal aorta and coronary artery, they are the central arteries. So if they ask you the most common peripheral vessel, it is the third most common site, that is nothing else but your popliteal artery. So please remember about all of this. Okay, so it is the popliteal artery which is the most common peripheral vessel affected with atherosclerosis. Whereas if they ask you overall most common, then your answer should be abdominal aorta. Not an option, go for coronary arteries. Please remember that. And coronary arteries ka agar atherosclerosis ho jata hai, if there is blockage in the coronary arteries, that what lands up your patient into myocardial infarction. Okay, chalo. That was important to be remembered. Now if I talk about the treatment of the patient, once you are done with the investigation, I will talk about the treatment. Now if I talk about treatment, what is the first line management? The first line management is always lifestyle changes or lifestyle modification. Why? Because there were a lot of risk factors in the patients which can be changed, and that will help patient to improve his condition. So lifestyle modification or lifestyle changes should be done, like weight reduction should be done if the patient is obese. The patient should stop alcohol and smoking, because these are two most important risk factors which will increase risk of atherosclerosis. The patient will go for regular exercise, that should be done. But if the lifestyle changes or the lifestyle modification, if they fail, then what should be the next line of management? Then the next line of management is medical management. Medical management, that means we will give drugs to the patient. And which are those medications that we give? We generally give vasodilators to the patient. Okay, so that the blockage, even if there is a blockage now, if we give vasodilators, at least the blood supply is restored. Okay, there will be more amount of blood supply. Which are these vasodilators given over here? No, they are not CCBs or nitrates. Here the vasodilators which are given, they act as both. They act as antithrombotic also. That means they will decrease the coagulability or they will decrease the viscosity, that is decrease the thickness of the blood. मतलब वो गाढ़ापन जो होता है ना खून का वो कम कर देते हैं. So these drugs which are given usually as vasodilators are cilostazol or oxypentaphyllin. Okay, cilostazol or oxypentaphyllin like drugs can be given to the patient over here. Apart from that, heparin is given in sudden arterial obstruction. Okay, so important is that. Next important, we will also give statins to the patient because I've told you one of the important risk factor is hyperlipidemia or dyslipidemia. So statins are also given to the patient as well. Okay, so that is important to be remembered. Please remember these are the drugs that we generally give. And yes, we will also give antiplatelet drugs as well. And the long-term antiplatelet drug that we prefer giving is aspirin to the patient will be given. Aspirin. Okay? If medical management also fails, now we need to go for a surgical management. If I talk about surgical management, guys, definitely the first line surgical management is always a PTA. What do I mean by PTA? Percutaneous transluminal angioplasty. What is plasty? Plasty का मतलब होता है repair. Plasty means repair. What is angio? Blood vessel. So repair of the blood vessel is what is called as angioplasty. Okay. So that is percutaneous transluminal angioplasty. Why transluminal? Because we are going inside the vessel and then we are repairing the vessel. What we will do? We will take a balloon along with us and we will inflate that balloon over here so that the vessel gets dilated or at least the thrombus gets fragmented into pieces. Okay. So that is called as balloon angioplasty. Okay, that is known as balloon angioplasty, or we can just place a stent over here, or we can just place a stent over here. At this side, we can just place a stent over here. Okay, and that is what is called as a stent angioplasty. The stents that we can use are either a metallic stent or a drug-eluted stent that can be used over here. No issues with this, anybody? So that's the important thing. Important. Now for angioplasty, the catheter that we use is shown over here. This has been asked. Okay, what is the below given instrument? So this catheter that we used for a vascular surgery or for angioplasty, this is what is called as a Fogarty's vascular catheter. This is what is known as the Fogarty's vascular catheter. Okay, that is generally used for angioplasty. You can see this balloon over here. No issues to anybody? So that's important to be remembered. Now, if angioplasty also fails in the patient, then definitely the best treatment is grafting. Okay, then the best treatment is artery bypass grafting. Okay, so the best treatment is nothing else but artery bypass grafting. Okay, and when we do that in heart, it is called as coronary artery bypass grafting, CABG. And when we do it in other vessels, it is called as artery bypass grafting. Now, if I talk about which is the best autologous graft, what do I mean by autologous? Auto means from ओन सेल्फ, खुद से ही अगर वो ग्राफ्ट निकाल लो, मतलब पेशेंट की बॉडी से अगर तुम ग्राफ्ट निकाल रहे हो, उस ग्राफ्ट को ऑटोलॉगस ग्राफ्ट बोला जाएगा. नाउ द ऑटोलॉगस ग्राफ्ट शुड बी सच वेयर देयर आर लीस्ट चांसेस ऑफ अथेरोस्क्लेरोसिस, बिकॉज इफ यू आर placing another vessel which is again having higher chances of atherosclerosis, there is no use. So which is the vessel in the body which has least chances of atherosclerosis? Then if the question is that, your answer should be Lima or Rima. What is Lima or Rima? That is right or left internal mammary artery which supplies the breast. Okay, Lima or Rima, that is right or left internal mammary artery. They have least chances of atherosclerosis. Therefore, they are the best autologous graft preferred. If that is not an option, go for great saphenous vein. Go for second best answer as great saphenous vein. Next is which is the best synthetic graft. Okay, if they ask you the best synthetic graft, usually above the inguinal ligament. That means for larger arteries, if they ask you the best graft, then answer is Dacron. Okay, which is a synthetic textile graft. Okay, Dacron. But if they ask you below the inguinal ligament for smaller vessels, then your better answer is PTFE. That is a polytetrafluoroethylene. Okay, so it is polytetrafluoroethylene graft. No issues with this. The most common synthetic graft used nowadays is Dacron usually. The most common synthetic graft used nowadays is Dacron, a commonly used graft. No issues with this, anybody? That's important. Next, talking about, that was all about your atherosclerosis. Okay. Next, if I talk about this condition. So in atherosclerosis also you can see this gangrene, and in Buerger's disease also you can see gangrene, as I've told you, both the conditions. Buerger's disease also will produce all of these symptoms. Patient will start with intermittent claudication, then rest pain, then pre-gangrene, and finally gangrene. So what is different in Buerger's disease? Let's discuss that. If I talk about Buerger's disease, another name for Buerger's disease is, I hope all of you are quite aware of that name, and that is called as thromboangiitis obliterans. Okay, what is obliterans? Obliterans means narrowing. Okay, thromboangiitis means inflammation of the vessel. Okay, so thromboangiitis obliterans is another name for Buerger's disease. Please remember that. Okay, and here definitely what is important to be remembered? Here it is usually diagnosed with the help of a criterion. What is that criteria called as for diagnosis of Buerger's disease? That is important again. It is known as the Ollens criteria. So for diagnosis we use the Ollens criteria, and there are three important features in Ollens criteria which should be met or which should be fulfilled to make a diagnosis of Buerger's. ठीक है, ये तीन criteria पूरे होने चाहिए. What are these? First of all, the patient who is commonly affected. Commonly I'm saying. Okay, the patient who is commonly affected is a young male that is between less than 40 to 45 years of age. So 40 to 45 years of young males are affected. First criteria. Second criteria is usually here the patient should have a history of smoking or any kind of tobacco use. The patient should have a history of smoking or any kind of tobacco use. And third important criteria, here definitely the patient should have signs and symptoms of distal ischemia. What is the symptoms of distal ischemia? Okay, what are the signs and symptoms of distal ischemia? As I've mentioned already above, these are the signs and symptoms of distal ischemia. That is intermittent claudication, rest pain, coldness, numbness, paresthesias, color changes, ulceration, pre-gangrene or gangrene. So these signs or symptoms should be present in the patient. That makes a diagnosis of Buerger's disease definitely. Okay, that makes you a diagnosis of Buerger's. No issues with this, anybody? That's very important. Now here if they ask you, what is the investigation of choice? Okay, Buerger's is also, here they have given, this is a previous year image which was given for Buerger's. But please remember, Buerger's is also more common in the lower limbs itself. Now please tell me, investigation of choice for Buerger's is again the same, and that is what is duplex scan. Okay, that is also a duplex scan over here. But if they ask you gold standard, again here also it is the same. That is nothing but an angiography. Important is that the angiography in cases of Buerger's disease shows a classical feature. And what is that classical appearance or classical feature in cases of Buerger's disease on angiography? You can see that the main vessel, if it is blocked now, as it is slowly blocked, therefore the body forms new vessels, and these new vessels are called as collaterals, and these collaterals will be very fragile. Okay, and these are called as corkscrew appearance or the corkscrew collaterals. Okay, so definitely on angiography you can see the corkscrew appearance of the collaterals, new vessels which are formed. Okay, so that's important to be remembered. If I talk about treatment, okay, if I talk about treatment in cases of Buerger's disease, so in cases of Buerger's disease, the small and the medium sized vessels are affected. You saw in atherosclerosis, major vessels were affected, larger vessels. But in Buerger's disease, the very small and medium sized vessels, like the tip of the toes, tip of the fingers, these are the vessels which are commonly affected. Please remember that. Okay. Now important is over here, if I talk about the treatment of the patient, what should be done for treatment? As in cases of bypass grafting, we need a vessel distally also, because graft is usually placed in between the okay, so for example, consider this is the blockage. So we need a graft which connects the vessel proximal to the blockage and distal to the blockage. But what did I tell you over here? This blockage in cases of Buerger's disease is starting from distal and it is coming to proximal. So that's the reason why bypass grafting is not possible in cases of Buerger's disease. That is the reason why here for treatment, we cannot use any bypass grafting. Okay, we will only go for either what? We will only go for medical, first of all, lifestyle modifications. That is, ask the patient to reduce weight, ask the patient to stop smoking and regular exercise. If that fails, go for medical management. If that fails, definitely you need to go for a surgical management, and that which is commonly done is known as lumbar sympathectomy. That medical management which is commonly done is known as lumbar sympathectomy. What is lumbar sympathectomy? Now usually we have lumbar ganglia, that is L1, L2, L3 and L4. Once you remove this lumbar ganglia, yesterday also I discussed lumbar spinal nerves which arise. These lumbar spinal nerves are sympathetic or they are parasympathetic. So all of us are quite aware the lumbar fibers which arise from the spinal cord, they are sympathetic in nature. As they are sympathetic in nature, they will cause vasodilation or vasoconstriction. We know they cause vasoconstriction in the periphery. That's the reason why when we remove all these lumbar ganglia, what will happen? The sympathetic fibers will be cut. And if the sympathetic fibers are cut, then vasoconstriction will not occur. What will happen? There will be vasodilatation in the periphery. Okay, the vessels in the periphery will be dilated and there will be more blood supply in the fingers or the toes of the patient. Okay, and that's what we want. But important is, if you cut bilateral lumbar ganglia, if you are wanting to cut L1 to L4 bilaterally, please remember, if you cut all of these lumbar ganglia L1 to L4 bilaterally, the patient will land up into impotence. The patient lands up into impotence. So that is a risk factor. So if you need to perform a bilateral lumbar sympathectomy, at least preserve one of the lumbar ganglia. So we usually preserve L1 ganglia at least on one side. That is, unilateral L1 ganglia should be preserved. Okay. Otherwise, the patient will land up into impotence if we are performing a complete bilateral lumbar sympathectomy. Okay. So to prevent impotence, we will always need to preserve at least one lumbar ganglia, that is the first lumbar ganglia, at least on one side. Okay, so that should be done. Moving further, that is lumbar sympathectomy, which has to be done in the patient. No issues with this. And the question was, lumbar sympathectomy is indicated in, the lumbar sympathectomy is indicated during rest pain, but it is absolutely contraindicated in, intermittent claudication. Please remember, we do not perform lumbar sympathectomy in cases of intermittent claudication. If a patient comes to you with complaints of intermittent claudication, we will not go for lumbar sympathectomy. Okay. No issues with this. Chalo. Now, let's discuss about Leydig syndrome. Leydig syndrome is important. So, Leydig syndrome, if you need to remember, just remember important few points about Leydig syndrome. So this is the abdominal aorta, and we know the abdominal aorta divides into two vessels. What are these vessels called as? These are called as your common iliac arteries. The abdominal aorta divides into two common iliac arteries. If there is blockage at this bifurcation, if there is blockage at the division of the abdominal aorta itself, that is what is known as Leydig syndrome. Okay, so there is a aortoiliac obstruction. And if there is a aortoiliac obstruction, what are the signs or symptoms in the patient? These two will help you make the diagnosis. The patient will have pain in the buttock region. That is what is called as gluteal claudication. Along with gluteal claudication, the patient can also have impotence. So along with gluteal claudication, patient has impotence because decreased blood supply to the penis of this patient. Treatment is what? Treatment is usually a graft repair, and which is the graft used for major vessels? We know it is the Dacron graft. Okay, so treatment is usually a Dacron graft repair that has to be done. Inshallah. Moving further, talking about this condition and classical Sarkari question of FMGE examination, and that is what is Raynaud's phenomena. Okay, so if I talk about Raynaud's phenomena, please remember, if I talk about Raynaud's phenomena, what is Raynaud's phenomena? So usually we know that Raynaud's phenomena is more common in which sex? It is more common in females. And whenever a patient is exposed to cold water, okay, whenever a patient is exposed to cold water, that has been a very common question or common history. But nowadays they have started asking about the another history, and that was asked in recent neetpg, and they will also be asking you in the recent FMG examination, and that is what is prolonged vibration. Yes, a patient, for example, who is having a prolonged vibration, like a person who has been using a drill machine for a longer duration of time. Okay, so those patients are also at a higher risk to develop Raynaud's phenomena. Okay, so either a history of exposure to cold water or to prolonged vibration can cause Raynaud's phenomena. And what is seen in Raynaud's phenomena? There is spasm. Okay, spasm is nothing but constriction. So there is spasm of arterioles as well as venules. The small vessels like the arterioles and venules, they undergo spasm. There is spasm of the arterioles and venules in the patient, in the fingers or toes. Okay, so arterioles or venules which are present in the fingers of the patient or in the toes of the patient, they undergo spasm or they undergo vasoconstriction. Okay, so that is what is seen usually. And due to that, what will happen? The patient will start showing color changes. Now important is, just remember, I am showing it to you. Please remember, if the arterioles as well as the venules, okay, if the arterioles as well as the venules both are under spasm, the blood supply will be decreased. The blood supply is completely stopped, and therefore first color change that you see is white. Okay, there will be complete whitish appearance of the fingers or toes. Next, what will happen? Now the arterioles will dilate. Okay, the arterioles will dilate, but the venules are still in spasm. The venules are still in spasm. That's the reason why the oxygenated blood mixes with the deoxygenated blood, and the appearance that you see is usually blue in color. Okay, and lastly, finally, what happens? The arterioles are dilated already. Now the venules will also dilate, and now the normal blood supply will be established, and therefore the fingers or the toes will turn red in color. So the mnemonic is WBR. Okay, the sequence of the color changes in Raynaud's phenomena have been asked. It is white, blue, red. WBR. Okay. Now important is Raynaud's phenomena can be of two types. Either it can be a primary Raynaud's phenomena or a secondary Raynaud's phenomena. And this has been a question of your FMG examination. Please remember, primary Raynaud's phenomena is also known as Raynaud's disease. Primary Raynaud's phenomena is also known as Raynaud's disease. And what is the cause? It is unknown. And unknown causes are called as idiopathic. Yes. If the cause of Raynaud's phenomena cannot be found, it is called as primary Raynaud's phenomena, and it is also known as Raynaud's disease. But if the Raynaud's phenomena is associated with some other diseases, and which are these diseases which are common in females? So if Raynaud's phenomena is associated with some connective tissue diseases, connective tissue disorders like systemic lupus erythematosus, that is SLE, or scleroderma in a patient, or rheumatoid arthritis, all of these patients are developing Raynaud's phenomena. But that Raynaud's phenomena which is associated with connective tissue diseases is a secondary Raynaud's. Okay, and that has been a question. In previous exam, primary and secondary both were in option. So if there is no cause mentioned, go for primary. If they are saying the patient is a known case of any connective tissue disorder, go for secondary. What is the treatment in this condition? Okay, so treatment in this condition, here it is a clinical diagnosis that we usually see with the classical history of the patient. Treatment, usually we will manage the patient with the help of drugs only. Okay, drug of choice. First line is always a lifestyle modification. And what is the lifestyle changes that we will recommend to the patient? Avoid using cold water. Okay, avoid using cold water or wear warm clothing. And if it is a patient who is using drill machines for quite a long time, now we'll ask the patient to change at least, okay, or get relaxed. Don't use drill machines for a longer time. Apart from that, if they ask you what is the drug of choice in medical management, we know the drug of choice for medical management in this patient is nothing but CCBs, and that has been a question. Calcium channel blockers are the drug of choice for Raynaud's phenomena in a patient. If that is not an option, you can go for nitrates as well. Okay, so that's important. Next, if I talk about aneurysms. Guys, now. What is an aneurysm? So if this is a vessel, okay, and if there is a dilatation in the vessel, that is what is called as an aneurysm. So any kind of dilatation in a vessel will be called as an aneurysm. Please remember, okay. So usually aneurysm is nothing but dilatation in a vessel. Okay, it is nothing but dilatation of a vessel. What is the most common or the most important risk factor? So if they ask you the most important risk factor for aneurysm, answer is again atherosclerosis. The most important risk factor for aneurysm is atherosclerosis. Please remember that. Okay, no issues with this. Whereas if I talk about other risk factors, it can be fibrillin 1 gene mutation on chromosome number 15, that is Marfan syndrome, or Ehlers-Danlos syndrome, collagen 1 defect. Okay, so Marfan syndrome, Ehlers-Danlos syndrome, or atherosclerosis are considered as important risk factors associated with aneurysm, because in Marfan's and Ehlers-Danlos, the blood vessel wall or the skin becomes extremely stretchable. Okay, therefore there is a dilatation which is seen. No issues with this, anybody? That's important. Now, usually most of the patients are asymptomatic. Please remember, most of the patients are asymptomatic. Some of the patients can develop a problem, and for that you need to remember which are the most common vessels affected with atherosclerosis, because atherosclerosis is a very important risk factor for aneurysms. So if they ask you which is the most common vessel affected with aneurysm, answer should be circle of Willis. Okay, yes, the vessels which will supply the brain. Okay, so the most common vessels affected with aneurysm, answer is circle of Willis. But if they ask you which is the most common vessel outside the brain, which is the most common extracranial vessel affected with atherosclerosis, then your answer should be what? Please remember, most common extracranial vessel. It is nothing else but the abdominal aorta. And we know why, because abdominal aorta is also the most common site for atherosclerosis. The most common vessel overall, answer is circle of Willis, but most common extracranial, answer is abdominal aorta. If they ask you most common peripheral, that also we know. Most common peripheral vessel affected with atherosclerosis, popliteal artery. So the most common peripheral vessel affected with aneurysm is also the popliteal artery itself. Yes, it is the infrarenal abdominal aorta. That means once the renal vessels have arrived, definitely below L2 usually. Okay, so it is the popliteal artery. It is the most common peripheral vessel. Now if they ask you which is the most common visceral vessel, most common visceral vessel. Viscera का मतलब होता है internal organ. The vessel which supplies the internal organ, which is the most common one. So please remember, the most common visceral vessel affected with aneurysm is the splenic artery. Then your answer should be splenic artery. No issues with this, anybody? That's important to be remembered, guys. Okay, these are important things to be remembered, definitely. Okay, all of these. Next, if I talk about, so abdominal aorta is very commonly affected now. So first of all, if the brain is affected, that the circle of Willis is having an aneurysm, we discussed yesterday, if there are small aneurysms in the circle of Willis or in the anterior communicating artery, they will rupture, and as they rupture, definitely they are going to cause intracranial hemorrhage. And which one? Please let me know which intracranial hemorrhage occurs due to spontaneous rupture of perianeurysms of anterior communicating artery. Next, if there is a abdominal aorta aneurysm, that can be asymptomatic completely, or maybe that can cause a mild discomfort in the patient. Usually that does not grow so much that it starts compressing other organs. It is very small. Okay, so that's important, guys. Please remember that. Now if I talk about the investigation in this patient, so please remember, if they ask you investigation of choice in a case of aneurysm, usually it is known as CT angiography. Okay, the investigation of choice is a CT angiography, which shows a characteristic sign, and that sign is a half moon shape. That is what is called as a crescent sign or a meniscus sign. That is known as a crescent or a meniscus sign. Very good, all of you. Yes, spontaneous rupture of perianeurysms can cause SAH, subarachnoid hemorrhage as well. Very good. So investigation of choice, as I've told you, it is CT angiography. Definitely that will tell you whether the vessel is dilated or not dilated. Okay. Apart from this, if I talk about the treatment, so treatment is, now as there is a high risk of rupture, definitely we need to replace the vessel. Okay. Usually if the patient is asymptomatic, we can just go for observation. But if abdominal aorta ka diameter, if the abdominal aorta ka diameter is more than 5.5 centimeter, if the abdominal aorta ka diameter is more than 5.5 centimeter, that is a danger sign. What do I mean by this? Definitely after this, if there is more aneurysm or more dilatation, the abdominal aorta is going to rupture and the patient will die. That's the reason why, if the abdominal aorta ka size is more than 5.5 centimeter, or if the patient turns symptomatic, then we'll go for a surgery, and that is what is called as a EVAR we can do. What is a EVAR? Endovascular aneurysmal repair. Okay, EVAR is nothing but endovascular aneurysmal repair, or we can go for a open surgery, and that is called as a open Dacron graft repair. I told you bypass grafting should be done. So open Dacron graft repair. Okay, so these are the treatments for aneurysm in a patient. Next, if I talk about this question, okay, so important is, please mention about the diagnosis in this question. A patient presents with diffuse chest pain. Okay, throughout the chest there is pain in the patient, diffuse chest pain, which is radiating to the interscapular area. In between the two scapula, the pain is going. Okay, so the pain is radiating to the interscapular area or to the back. That is a very characteristic question. Recent NEET 2023 also, it had the same question. So please let me know, if a patient is having diffuse chest pain which is radiating to the interscapular area, what is your likely diagnosis? The blood pressure of patient is around 90 by 50 millimeters of mercury. What is the investigation of choice? What say? What is your, very good Mohit, it is a case of aortic dissection. Very good. Classical symptom hai ye tumhara. Okay, diffuse chest pain radiating to the interscapular area. If they say, if the patient was having an epigastric pain radiating to the back, then your diagnosis would have been acute pancreatitis. But if they say chest pain radiating to the back, then your answer is more likely to be aortic dissection. You will say in MI also, but in MI usually it mainly radiates to the left arm. Here it mainly radiates to the back or the interscapular area. So the diagnosis over here is definitely aortic dissection. Okay, it is a classical case of aortic dissection. What do I mean by this? So aortic dissection usually occurs in patients who are hypertensive and who are not taking their medications on time. That causes an uncontrolled hypertension. Due to this uncontrolled hypertension, there is a tear in the artery. There is a tear in the vessel, or there is a tear in the artery, mainly the aorta. Okay, and that causes what? Now the blood was only flowing in the blood vessel lumen. Till now the blood was only flowing in the lumen of the blood vessel. I hope all of you are quite aware how many layers a blood vessel wall has. A blood vessel wall has, first of all, the tunica intima, then it has the tunica media, and then finally it has the tunica externa as well. Now what is seen? there is damage or there is a tear in the tunica intima. As there is a tear in the tunica intima, all the blood, okay, most of the blood starts flowing in this lumen. Okay, most of the blood will start flowing in this lumen between tunica intima and tunica media. So इधर का blood क्या हो जाएगा? If the blood starts flowing into another lumen, the blood flow in the main lumen will start decreasing. The blood flow in the main lumen is decreasing definitely, and that's the reason why what will happen, the patient can land up into hypotension, which is seen over here as well. The patients become hemodynamically unstable. The patient lands up into hypotension, that is BP decreases to 90 by 50 millimeters of mercury, because now the blood is flowing into another lumen between tunica intima and tunica media. That is aortic dissection now. Sure. Moving further, as I've told you, important risk factor is uncontrolled hypertension. What will be the complaint that we have discussed? It is diffuse chest pain which radiates to the back or to the interscapular area in the patient. What is the investigation of choice? Now the investigation of choice differs, guys. If it is a stable patient, that means the BP of the patient is normal. Okay, then definitely we can go for a CT angiography. Then it is CT angiography, and the CT angiography classically shows this sign. What is this sign? You can see this is the main blood vessel lumen जहाँ से blood flow होता है, and this is that extra lumen which has been created. The extra lumen which has been created is this one, and this is the classical sign. What is this sign called as? It is known as the tennis ball sign. This is what is known as the tennis ball sign. Okay, so tennis ball sign has been given in the examination. It is a classical feature seen in cases of aortic dissection on CT angiography. That's important. But as our patient is unstable, can we send our patient for CT? नहीं. मैंने क्या बोला था? If you send a unstable patient for CT, the patient will go alive inside the CT machine, but will come dead outside the CT machine, because it is a very time-taking procedure. That's the reason why in unstable patients, we will go for a transesophageal echocardiography. We will go for a transesophageal echocardiography, and that is the answer to this question. That is the answer to this question, guys. Okay, because our patient is unstable, okay, his blood pressure is dropping. That is the reason why we will go for a transesophageal echo. Now, once you have done echocardiography in this patient or a CT angiography in this patient, you will classify the patient according to the classification that we have for aortic dissection. Just remember the first name. Pehla name to just need to remember. That is called as the DBK classification, according to which the aortic dissection is classified into type 1, 2 and 3. But another classification is important. And why? Because this classification is going to decide the treatment, and that is called as the Stanford classification. Okay, so if I talk about Stanford classification, this is important because this decides the treatment. Now Stanford A and Stanford B we have. Stanford A matlab the aortic dissection is only in the the aortic dissection is in the ascending plus the descending aorta. Stanford A ka matlab the dissection is in the ascending plus the descending aorta. But Stanford B matlab that aortic dissection is only in the descending aorta. The aortic dissection is only in the descending aorta. Very good. Now, if the patient comes to me with aortic dissection, what should be my management? If they ask you what is the first line management, okay, what is the first line management? My first line management is to give a beta blocker, but the shortest acting beta blocker. And what is that shortest acting beta blocker? Very good. It is esmolol. Definitely. So I will give IV esmolol to the patient. Okay. So I will give IV esmolol to the patient. That has to be the first line management. But then my definitive management should be according to the Stanford classification. That means if a patient is Stanford A, if my patient is Stanford A, definitely I'll go for immediate surgical management or surgical correction. I'll go for immediate surgical management or surgical correction. But if my patient is Stanford B, that is only the descending aorta is involved. So in this patient, I will go for monitoring. First, once I have given esmolol, esmolol should be given in both the conditions. Once I have given esmolol, I will see if the patient improves or not. But if the patient does not improve, rather the patient's condition worsens. The patient's condition worsens, then here also I need to go for a surgical management. But if they ask you what is the first line for Stanford A, answer is surgical management. And what is the first line definitive management for Stanford B? Answer is monitoring. If the patient's condition worsens, then I'll go for surgical management. Okay? Chalo. Then if I talk about sudden arterial obstruction. Sudden arterial obstruction ki agar main baat karu, when what will happen? For example, this is the artery. There was a thrombus which was formed over here. Okay, thrombus takes times to develop. Definitely. So thrombus is a case of gradual arterial obstruction. But when the thrombus gets dislodged, मतलब यहाँ से निकल गया ये thrombus, and then that thrombus goes into a small vessel and blocks that vessel, that causes a sudden arterial obstruction. So if there is a sudden arterial obstruction due to dislodgement of a thrombus, that condition is what is called as an embolism. So when a thrombus gets detached from its site and blocks some other vessel at some other site, that is known as an embolus, and that condition is what is called as an embolism. So sudden arterial obstruction is nothing but embolism itself. Now important is, usually embolism is characterized by, as we know, embolism is a vascular emergency now, because it will cause sudden and a complete arterial obstruction of a particular vessel. So it is considered as a vascular emergency. And there are classically 6 P's of embolism. What will happen if the artery is completely blocked? Okay, if the artery is completely blocked, definitely, so please remember, definitely the patient will have pallor. There are 6 P's. So first, there will be pallor. Okay, decreased blood supply causes pallor. Second, the patient will have pain because the nerves will not receive enough blood supply. There will be pain. Next, there will be coldness now, because blood supply is decreased. There will be coldness. That is called as poikilothermia. The patient will have poikilothermia. That is nothing else but coldness. Next, the patient will have what? The patient will have paresthesia. And what is paresthesia? Decreased sensation. But a lot of people will also have anesthesia. That is complete loss of sensation as well. Okay. Next, definitely what will happen? The patient will have, the patient is having paralysis. Okay, paralysis, that means the patient is not able to move the muscle. Paralysis bhi samajh sakte ho. And lastly, finally, the patient will have pulselessness. Finally, the pulse will be absent. And this was your previous year question, that which is the last sign to appear in cases of embolism. So the last sign to appear in cases of embolism is pulselessness. The last feature to appear is pulselessness. That's important. Okay. So these are the 6 P's of embolism in a patient. Now, if a patient comes to you with embolism, there can be embolism to any vessel. It can be embolism to the vessels of upper limb, lower limb, to the heart that causes myocardial infarction, to the lungs that causes pulmonary embolism, to the brain that causes cerebral embolism, anything. Okay. If a patient is having embolism, what is the investigation of choice? So investigation of choice, definitely, please remember, it will again be a duplex scan itself. Yes, investigation of choice is again a duplex scan in the patient. And once you have made a diagnosis, what should be the management in a case of embolism? So please remember, what is the first step in a case of embolism? First step in a case of embolism is usually to give a subcutaneous injection, of low molecular weight heparin. Why? So that the thrombus should not grow further. Okay, so first step is to give a subcutaneous injection of low molecular weight heparin. We can also give IV. Okay, IV can also be given, subcutaneous can also be given. Don't worry about that. Okay, low molecular weight heparin injection should be given, so it will not let the thrombus grow in size further, और नहीं बढ़ने देगा उसको size में. ठीक है. If I talk about early and late management of the patient, what do I mean by early management? Early management, that means the patient has come to you within 6 to 12 hours. Okay, within 6 to 12 hours of blockage, the patient comes to you. Matlab, here the patient will not have any gangrene. So in this condition, I can go with a Fogarty's catheter and I can remove the embolus. And if I remove the embolus with the help of a Fogarty's vascular catheter, that is called as embolectomy. That can be done. Or definitely we can perform thrombolysis. That means we can break down the thrombus or the embolus. And this breaking down of thrombus or embolus is usually done with the help of a drug. And what are these drugs called as? You might have studied recombinant tissue plasminogen activator. And these recombinant tissue plasminogen activator are drugs like altiplase, tenecteplase. Streptokinase and urokinase are not used commonly nowadays due to allergies. Okay, so these are usually altiplase like drugs. Okay. If the patient presents to you late, that means when the gangrene has already occurred, if the patient presents to you late, then definitely when there is gangrene, there is no other option than amputation. Okay, cutting. Okay, so there is no other option than amputation if the patient presents to you late with gangrene. Okay, so that is important about embolism. Next, if I talk about is this condition. Okay, a 45-year-old female took a long flight and after landing she complains of chest pain and she dies on the way to the hospital. What is the cause of death and what is the underlying cause in this patient? So please let me know what is the underlying cause in this patient and what is also the cause of death in this patient. What is the underlying cause and what is the cause of death in this patient? Very good, very good. The underlying cause in this patient is DVT, okay? Whereas the cause of death, very good, it is pulmonary embolism. Shabash. So now if I talk about DVT, guys, what is DVT? DVT is nothing but deep venous thrombosis. Now, as I've already told you, that in the lower limbs or in the legs, we have two types of venous system. One is called as the deep venous system, which carries majority 80% of the blood, and then we have the superficial venous system, which carries only 20% of the blood. Now, important is DVT or deep venous thrombosis is more common in, definitely we know it is more common in the lower limbs, that too in the leg. Which area of the leg? It is more common in the calf region. Okay, it is more common in the calf region. And which veins? So it is more common in the soleal veins of the leg. Okay, so it is more common in the calf region, in the soleal veins of the leg. Please remember. So what has happened over here? In the lower limbs, in the deep veins, there is a thrombus which has been formed. And what is the reason for thrombus? You might have studied in pathology recently. There is a classical virtuous triad which is responsible for thrombus formation. What is the classical virtuous triad? First, the most important factor is endothelial injury. Second factor important is stasis of blood flow. Blood aage nahi badh raha. Okay, there is stasis of blood flow. And third important factor is usually hypercoagulability. That means increased viscosity or thickness of blood. Gaadha ho gaya blood zyada. ठीक है? So these are the classical features which will cause deep venous thrombosis in a patient. When there will be higher risk of deep venous thrombosis in a patient, usually the risk factors which are associated with deep venous thrombosis are usually when the patient is not moving. What is that? Prolonged immobilization. When a patient is in bed for a longer duration of time, क्या हो जाता है उसकी वजह से? The blood is not able to move. It stays at one place for a longer duration of time, and that causes stasis. And when there is stasis, there will be high risk of formation of a thrombus. So prolonged immobilization is the most important risk factor. What are the causes of prolonged immobilization? See, important is when a patient is bedridden. Okay, so either he can be a ICU or a comatose patient, a bedridden patient. Okay, second, a patient who has underwent a major surgery like total hip replacement or total knee replacement surgeries. They usually classically give you these two surgeries. Or if the patient is having a vertebral column fracture. We know in cases of vertebral fracture, patient needs a prolonged bed rest of almost 3 to 6 months usually, okay? Or if a patient is taking a long flight from New Delhi to New York. That is a classical question that they mentioned, and that has been asked in the previous year exam also. So if the patient is taking long flight and she is not walking in the flight, there will be high risk of thrombus formations in the deep veins of your leg. Okay, so prolonged immobilization is the most important risk factor. Now what will happen if the patient is in a long flight? Okay, she has not walked for a longer time. Now there was a thrombus which was formed in her deep veins of leg. Now as soon as she starts walking, as soon as she started walking, what has happened? There is contraction of the muscles of the leg. As the muscles of the leg will contract, this thrombus can get dislodged from here, okay, and that will go where? That will go to the lungs, okay, and in the lungs it will cause blockage, and that is what is called as pulmonary embolism. So what are the classical signs or symptoms in a patient? So the clinical feature in a case of DVT, the patient is having thrombus in the legs. So due to that, the patient is only having pain and swelling in the calf. The patient only has pain and swelling in the calf region. That's the classical sign of a DVT. But important is when the patient is having pulmonary embolism, you might have studied this in medicine also, then the patient will start experiencing chest pain. Okay, then the patient starts experiencing chest pain. The patient will have respiratory distress, or there will be dyspnea in the patient. Okay, so all of these signs, or there will be a raised jugular venous pressure as well. All of these signs will be seen. Okay, and please remember, pulmonary embolism is also the cause of death in this patient. Okay, it is also the cause of death in this patient. No issues with this, anybody? That's important. Now definitely if a patient comes to me with deep venous thrombosis, usually it is a female, okay, or it can be a male as well. After prolonged immobilization, there will be pain and swelling in the calf region. I will try to examine the patient. Once I examine the patient, there are two clinical signs which are seen. So which are the two clinical signs seen in a case of DVT? So consider this as your leg and this as your foot. If I try to dorsiflex the foot, there will be a lot of resistance or stiffness in the calf. This is called as the Hormone sign. This is what is known as the Hormone sign. So first sign which is seen. Okay, second sign important which is seen is when I try to press the calf, there will be a lot of pain, and that is what is the Moses sign. So that has been asked in your examination again. So Moses sign and Homan sign are features of, both are features of DVT, deep venous thrombosis. And now we know again the investigation of choice for vessels. Non-invasive investigation is a duplex scan. So here also your answer should be a duplex scan itself. Okay. Important is now what should be the treatment in the patient. If the patient comes to you with an episode of DVT, when there is extreme pain and swelling in the calf region, okay. So if a patient is coming to me with an episode of DVT, so I will give him low molecular weight heparin. I will give him low molecular weight heparin. Along with that, heparin is an injectable drug, right? I will also give oral warfarin to the patient. You will say, sir, both? Yes, because warfarin usually takes 5 days to act. That's the reason why for initial 5 days, we need to give low molecular weight heparin also. So this should be given for the first 5 days in the patient, okay? And after 5 days, when you will generally discharge the patient, only continue the patient on oral warfarin. Only continue the patient on oral warfarin. This treatment should be given for how much time now? Please remember, if, okay, this is what is called as anticoagulation, because we are giving anticoagulant drugs. So if the patient is having first episode itself, एक ही बार हुआ है, the patient is coming to me with first episode of DVT, just give this treatment for 3 months. This has changed. Initially, earlier it was 6. So just give anticoagulation for 3 months. But if the patient is coming to me with second or third, fourth episode, that is recurrent case, then definitely continue the anticoagulation lifelong. Then continue the anticoagulation lifelong. That is important. Okay? Then more important than the treatment of DVT, they are more interested to ask you how DVT can be prevented in a patient. So for prevention of DVT, please remember how prevention of DVT can be done. Prevention of DVT can be done either via pharmacological route, and for pharmacological route, we give a anticoagulant drug, that is low molecular weight heparin. That's the best drug for prevention of DVT. Whereas we can also use some mechanical techniques. And what are these mechanical techniques for prevention of DVT? So the most important which is given over here, this image came in your exam earlier. What is this? You can see a machine which is there. This machine will control these stockings. And what are these stockings? These are compression stockings. Okay, they will increase the pressure. There will be air which will fill up in the stockings, and these stockings, as soon as the air fills up, they will compress your legs. As they compress the legs, the muscles will be compressed, the deep veins will be compressed, and therefore there will not be any risk of thrombus formation, because you will keep on doing this for at least 3 to 4 times a day. And that is what is called as pneumatic compression stockings. So if a patient you know is going to have a prolonged immobilization, so therefore recommend prolonged pneumatic compression stockings in the patient. Okay, recommend these pneumatic compression stockings. And apart from that, if a patient has underwent a surgery and there is no other contraindication, just go for early ambulation. What is early ambulation? Ask the patient to walk as soon as possible. You might have seen a lot of surgeons asking the patient to walk on even the first or second day of surgery. That is the reason, because we don't want our patient to get 2 important things. 1, DVT, and 2, pressure source. That's the important thing. Therefore, next, if I talk about varicose veins, okay, if I talk about varicose veins in a patient, okay, so in varicose veins, definitely here it is not a problem with the superficial veins of the, here it is not a problem with the deep veins of the leg. It is a problem with the superficial veins of the leg. Now, as I've told you, there are deep veins of the leg which carry almost 80% of the blood supply, and there are superficial veins of the leg which only carry 20% of the blood supply. So they are not used to a lot of high blood pressure. And in between these two, okay, the deep veins and the superficial veins, we have connections, and these connections are either called as, these connections which are present, these connections are either called as junctions. We have 2 junctions, or these are called as perforators. Okay, we have 4 perforators. वैसे तो 100 to 150 perforators होते हैं every leg में. Okay, important is, please remember these junctions which are there. One is the junction between a deep vein, that is called as femoral vein, and a superficial vein called as great saphenous vein. So the junction is called as saphenofemoral junction. And the second junction which is there is between a deep vein known as popliteal vein and a superficial vein known as short saphenous vein, and that junction will be called as saphenopopliteal junction. Or we have multiple perforators. Okay, these perforators, in the proximal thigh it is the Hunterian perforator, above knee it is the Dodds perforator, below knee it is the Boyd's perforator, and above the medial malleolus in the leg it is the Cockett's perforator. Okay, but overall these are the named ones. Overall there are 100 to 150 only. Okay, so that's important. Now what has happened over here? See, please remember, this is the deep vein, this is the superficial vein. Okay, just a minute. Deep vein and superficial vein. Normally we know in veins we have valves. Okay, normally we know in veins we have valves. Okay, and in between the deep and the superficial vein, that means at the junction or at the perforator also we have some kind of valves. Okay, we have some kind of valves in the perforators or at the junctions also. Okay, and these valves, please remember, these valves are only one-way valves. What do I mean by one-way valves? That means the blood can go from superficial veins to the deep veins. The blood can only go from superficial veins to the deep veins. It will never go from deep veins to the superficial veins. Okay? तो blood कहाँ से कहाँ जाएगा? Blood superficial veins से deep veins तक जाएगा. उल्टा नहीं जा सकता. But if this valves are not present at all, if the valves are not present, okay, or if the valves are defective, in this condition what will happen? Now the blood can flow both ways. Therefore, the blood, whenever there is increased pressure in the deep veins, the blood will go into the superficial veins. Are these superficial veins used to a lot of blood? No, because they only carry 20% of blood, na? So they are very narrow, they are very shorter ones. They are not used to handle a lot of blood. But now, as they are handling a lot of blood, they will undergo dilatation. What will happen to these? These will undergo dilatation and they will become tortuous. What is tortuous? See. Okay, आधे टेढ़ी हो जाएंगी. That is what is tortuosity. Okay, so they will become dilated and they will become tortuous, and that is what is called as varicose veins. Okay, that is what is called as varicose veins. When the superficial veins get a lot of blood supply from the deep veins and they cannot handle it, and therefore they undergo dilatation and become tortuous, that is what is varicose veins. Please remember. And why that has happened? Because the valves which were there, they were either completely absent or they were defective in nature. Okay, and that is what is called as incompetence. Okay, incompetence मतलब नलायक. तुम्हारे जो junctions थे या perforators थे वो नलायक है, because these valves are not acting properly. These valves are nalayak. No issues with this. That is what is incompetence. So chalo, let's discuss further. So varicose veins, as I've told you, it is nothing but dilatation and tortuosity. Dilatation and tortuosity of the superficial veins of leg. Okay, so it is dilatation and tortuosity of the superficial veins of leg. That's the important thing. Please remember that. Okay, now usually it will occur in definitely the lower limbs. Okay, because there is deep and superficial vein system only in the lower leg itself. Okay, so that's the funda. Now what will be the complaint of the patient? So usually how the patient is going to present to you, the clinical feature, the patient will have a dull aching pain. The patient will only have a dull aching pain, or the patient will come to you with these kind of features. Okay, the patient will come to you with these dilated veins on the leg. Okay, that will be the complaint of the patient usually, dull aching pain or these dilated veins which will be seen. Okay, important is, please remember, this varicose veins which are there, what is the investigation of choice for that? Yes, you can make a clinical diagnosis definitely, because you are able to see the varicose veins, but still to assess कि which junction is incompetent or which perforator is incompetent, कौन नालायक है इसमें. Okay, to identify that, the investigation of choice is again a duplex scan. Again, it is a duplex scan. Important is, once you have assessed, okay, varicose veins, or once you have diagnosed varicose veins, the classification which you do is known as CAP classification, and that was your question in recent FMGE examination. CAP classification is generally used for. So please remember, the CAP classification is generally used for what? CAP classification is used for classifying the varicose veins, where C stands for, at least remember the full form. Okay, C stands for what? C stands for clinical manifestation, when the classification is done based on the clinical features of the patient. E stands for etiological classification, when the classification is based on the cause or etiology. A stands for anatomical classification, when the classification is based on which veins are commonly involved or which junction is involved. And P stands for pathophysiological classification. That means what is the cause of this varicose veins in the patient. Okay, so at least important is to remember the full form. Okay, nowadays they are started asking about the C classification also, but at least remember this. Okay, that's important. Now if I do the CAP classification and the investigation of choice is done, one of the stages in varicose veins is this one. What is seen over here? You can see the leg which is there. Okay, in this part of the leg there is loss of fat. There is loss of fat. The muscles you can see over here, there's a muscle contracture which can be seen. and once you palpate this, you can feel it has become woody hard. Okay, एकदम wood जैसा hard बन चुका है ये, ठीक है. This gives which kind of appearance to you? Anybody? Okay, this classically gives you a inverted champagne bottle appearance, and that was the image which came in your exam. Inverted champagne bottle appearance is seen in which condition? It is definitely seen in varicose veins, but it has a specific name. What is this condition is called as? This is known as lipodermatosclerosis. Okay, so inverted champagne bottle appearance is seen in one of the stages of varicose veins known as lipodermatosclerosis. That was a PYQ again. Please remember this. Okay? Shabash. Now, if I talk about the treatment of the patient in cases of varicose veins, if the patient is having problem at the great saphenous vein or in the saphenofemoral junction, there is incompetence or there is a defect, then the treatment of choice, the classical surgery that we perform, the conventional one, is known as which operation? Then it is known as the Trendelenburg operation. It is known as the Trendelenburg operation. Okay? And this Trendelenburg operation, what do we do? So we ligate this connection here itself. We ligate this connection here itself, so that the blood should not go from the deep veins to the superficial veins. There is flush ligation which is done of the saphenofemoral junction, and we strip off the great saphenous vein also. हम great saphenous vein को खींच लेते हैं, निकाल देते हैं, ठीक है. So flush ligation of saphenofemoral junction along with stripping of great saphenous vein. Next is short saphenous vein. If there is defect in the short saphenous vein or the saphenopopliteal junction is defective or it is incompetent, यहाँ पे we will go for flush ligation. But at which junction now? Very good. Flush ligation of saphenopopliteal junction. So here we will do a flush ligation of saphenopopliteal junction. Next, if there is some problem in the perforators now, तुम्हारे perforators नालायक है. If there is incompetence of the perforators, okay, the valves are defective in the perforators, then the best surgery for perforators which is performed nowadays is called as SEPS. What is SEPS? Subfacial endoscopic perforator surgery. Why? Because in this we only give one incision, we insert a camera, and then we keep on ligating one after the other perforator. That is called as a subfacial endoscopic perforator surgery. But if that is not an option, the earlier surgery which was done was called as Dodd and Cockett surgery. The earlier one was Dodd and Cockett surgery. Next important is newer modalities. If I talk about the new modalities, and these are considered as the surgery of choice nowadays. Okay, these are considered as surgery of choice nowadays. So please remember that you need to remember what are these surgeries of choice nowadays. Okay, these are the considered best ones. These are either called as EVLT. What is EVLT? Endovenous or endovascular laser treatment. Endovenous or endovascular laser treatment, or the second one which is having equal efficacy, मतलब वो भी उतनी अच्छी है, that is called as RFA. That is radio frequency ablation. That is radio frequency ablation. Okay, so these are the best treatments of the surgery of choice which are done nowadays in the patient. Okay, so that was all about it. Important is just remember, when there is collection of lymph, that is called as lymphedema. Okay, that will cause swelling. Lymphedema, most common cause of lymphedema, please remember, it is filariasis. Most common cause of lymphedema is filariasis, that is caused by Buscheracia bancrofti, which causes Bancroftian or lymphatic filariasis, which can further progress to elephantiasis as well. Whereas lymphedema ke secondary, okay, lymphedema can also occur secondary to. It can be a complication after. It can be a complication of axillary lymph node dissection, or it can be a complication of breast surgeries as well. Okay, so usually after a breast surgery, within few weeks, the patient can develop swelling in the arm, and that is what is the case of lymphedema that has been asked to you in the previous year examination. Please remember, lymphedema, when it stays for a span of 8 to 10 years, that was the question. If there is a prolonged lymphedema for 8 to 10 years, it can further progress to a secondary malignancy. There can be malignancy of the lymphatic vessel, that is lymphangiosarcoma, and this lymphangiosarcoma has a specific name known as Stewart-Travis syndrome. That is known as Stewart-Travis syndrome. That is a complication of lymphedema, long-standing lymphedema. Okay, so that's important. Now at least I'll start with important points of GIT. At least I'll try to cover esophagus. Okay, so then there won't be an issue. Okay, so we'll complete in time then. Okay, chalo. बढ़े आगे, take a deep breath and get ready for esophagus. Because we are doing revision, guys, please remember, so that's the reason why we need to be on our toes thoda. Okay? Shall I proceed? Shall I? Answer it. Chalo, let's start now. Okay? First of all, the first topic that I'll talk in GIT is the esophagus, definitely. Okay? If I talk about the esophagus, I hope all of you are quite aware that esophagus is a muscular tube which is 25 centimeters in length. And this esophagus usually has 4 constrictions. Yes, anatomically there are 4 constrictions, but when we perform an endoscopy, we will only be able to find 3 constrictions. Okay? So these 4 constrictions which are there, I'm just revising anatomy once. Okay, the first constriction, we will measure the distance from the upper central incisors. The first constriction is 15 centimeters away from the upper central incisors. And what is that first constriction of esophagus? It is the starting of esophagus. What is the starting? So where the pharynx will end and the esophagus will start. That is pharyngo-esophageal junction, also known as cricopharyngeal junction. That is the first constriction, which lies at which vertebral level? That's important. It lies at C6, at the level of C6. That is 6th cervical vertebra. Second constriction is usually 22 centimeters away from the upper central incisors, and that is due to crossing of arc of aorta. When the arc of aorta crosses the esophagus. Okay. Next constriction is 25 to 27 centimeters away from the upper central incisors, and that is due to crossing of left mainstem bronchus. When the left bronchus crosses the esophagus. And the last one, important one, when the esophagus, please remember, when the esophagus enters into the diaphragm. Okay, we know that esophagus is in the thoracic cavity, but when it enters into the abdominal cavity, it has to pierce or it has to go through the diaphragm, and that is 40 centimeters away from the upper central incisors, the esophageal diaphragmatic hiatus. No issues with this, anybody? So these are the 4 constrictions. Chalo, important. Now if I talk about the esophagus, we know the first congenital anomaly that we need to talk about esophagus is when the esophagus is not developed. Some part of the esophagus is missing. And what is this anomaly called as? This anomaly will be called as esophageal atresia. Okay. So when some part of the esophagus is missing, that is what is known as esophageal atresia in the patient. Okay. So that is what is atresia ka matlab hota hai absence of esophagus. Atresia means there is some part of esophagus which is missing. Okay. So esophageal atresia, we know, please remember this esophageal atresia, we know it is commonly associated with some other congenital anomalies also. And what are those congenital anomalies with which esophageal atresia is commonly associated? Answer is the Vacteral group of anomalies. Answer is the Vacteral group of anomalies, and that has been a question, guys, in your examination. Okay? So please remember the Vacteral group of anomalies. V stands for vertebral defects. A stands for anorectal malformation. C stands for cardiac anomalies. TE stands for, T is very important for us, TE stands for tracheoesophageal fistula. R stands for renal agenesis, and L stands for limb defects. If they ask you out of all of these anomalies which are there, most common one is, so you need to answer the most common anomaly out of all of this is the cardiac anomalies. But if they ask you which is commonly associated with esophageal atresia, which one is commonly associated with esophageal atresia, then you know the answer is tracheoesophageal fistula. So a lot of times what happens, some part of the esophagus is missing, but this part of esophagus also communicates with the trachea. I hope all of you are quite aware. Trachea is a tube or a pipe which is anterior, and uske piche, behind the trachea, there is another tube or another pipe, that is your esophagus. Okay, and we know connection or communication between 2 organs is what is called as a fistula. So if there is an abnormal connection between the esophagus and the trachea, if there is an abnormal connection between esophagus and a trachea, this is what is called as tracheoesophageal fistula. Now if I talk about this condition over here, it is divided into 5 types. Okay, so type A, which is there, guys, type A, the patient is only having, as you can see, there is no fistula, there is only absence of some part of esophagus. So type A, there is only esophageal atresia in the patient. Type A, there is only esophageal atresia. Type B, which is there, you can see there is absence of some part. That means the patient is having esophageal atresia, but along with esophageal atresia, the patient is also having a proximal tracheoesophageal fistula. The patient is also having a proximal tracheoesophageal fistula, abnormal connection between esophagus and trachea, and that too proximal to the atretic part. Next is टाइप सी में क्या दिख रहा है? Absence of some part of esophagus, that is again esophageal atresia is there. Along with that, you can see there is an abnormal communication again, but this time it is distal. So therefore, it is a distal tracheoesophageal fistula. Okay. Next important, here you can see there is absence of some part of esophagus, that is esophageal atresia again. But along with that, you can see a proximal as well as a distal fistula. So along with that, there is a proximal and a distal tracheoesophageal fistula. Proximal and distal tracheoesophageal fistula. Type E which is there, okay, type E which is there, you can see the esophagus is completely present. That means there is no esophageal atresia. So what is there only? There is only a tracheoesophageal fistula. There is only a tracheoesophageal fistula. So please remember, only esophageal atresia type A, only tracheoesophageal fistula type E. And किस तरह का दिख रहा है? It is looking as a H-shaped fistula. It looks as a H-shaped fistula. If they ask you, the common was, which is the most common type of esophageal atresia? So your answer should be, the most common type of esophageal atresia is type C. The most common type of esophageal atresia is type C. Please remember that, okay? Because 85% of cases are type C, okay? That means when there is a esophageal atresia, along with that, there is a distal tracheoesophageal fistula. That is the most common subtype. How we are going to suspect esophageal atresia in a patient during pregnancy? That means when the patient is pregnant, how you are going to suspect that a fetus might have esophageal atresia? कैसे पता लगेगा अगर माँ pregnant है तो उसके बच्चे में esophageal atresia हो सकता है या नहीं हो सकता? So please remember, I hope all of you are quite aware that the amniotic fluid which is there, it is formed due to fetal urine, but it usually maintains a balance in the amniotic fluid is maintained. Why? Because a lot of amniotic fluid is swallowed by the fetus. If the esophagus is not formed, will the baby be able to swallow the amniotic fluid? No. As the baby is not able to swallow the amniotic fluid, that is the reason why a lot of amniotic fluid will stay outside in the amniotic cavity itself. And that is what is suggestive of polyhydramnios. So polyhydramnios, if it is there in a pregnant female, that can be an indicator, that can be an indicator that the fetus might be suffering from esophageal atresia. Then if the child is born, at birth, what can be the indicators of esophageal atresia? At birth now, the saliva is not able to go inside. Therefore, all that saliva comes out from the baby's mouth. Okay. So there is excessive salivation, or there is excessive saliva which is drooling out. So there is excessive saliva which is drooling out or coming out from the baby's mouth. Okay. लाल टपकती रहती बच्ची की बहुत ज़्यादा. ठीक है. Then we can do a initial bedside investigation. And what is that bedside test that we can do? Here, a bedside test that we can do is we will take immediately a orogastric tube. What is a orogastric tube or a nasogastric tube? We will take a rice tube, that is a orogastric tube or a nasogastric tube, and we will try to insert it via his nose or via his mouth, via the baby's or the neonate's mouth or the nose. We are trying to insert the tube. Now, will that tube go inside? No, that tube will not reach the stomach. Why it will not reach the stomach? Because the esophagus is not formed, and that's the reason why you will get a resistance at around 10 centimeters. Okay, you cannot push the tube further, and what will happen? The tube will start coiling. So bedside test is try to insert a orogastric or a nasogastric tube, and you will get a resistance on that. Okay, to confirm this, we can perform the initial investigation. And what is that initial investigation? So the initial investigation that we perform is definitely a chest X-ray. And on a chest X-ray, what is seen? This was the recent FMGE 2023 question. On the chest X-ray, this is what is seen. You can see the nasogastric or the orogastric tube has coiled inside the esophagus. So coiling of the nasogastric tube is what is seen. Okay, there will be coiling of the tube which is seen in the proximal part of the esophagus. Okay. Now, if they ask you what is the investigation of choice to confirm your diagnosis. So my investigation of choice to confirm the diagnosis is contrast study. I will give a contrast to the child, usually a water soluble contrast like iohexol, and then I will perform a X-ray or a CT scan. Okay? So contrast study will be done in the patient. No issues with this, anybody? That will make my investigation. But for type E, okay, type E के लिए the best investigation is a tracheoesophagoscopy. For type E, the best investigation will be a take a camera and go inside. Go with the help of an endoscope and perform a tracheoesophagoscopy. For A, B, C, D, contrast study. For type E, best one is tracheoesophagoscopy. What should be the treatment in this patient now? If I talk about the treatment, if it is type A, what was type A? Only esophageal atresia. Okay, only esophageal atresia. That means there was no fistula in type A. Now, in esophageal atresia, what is there? The two ends are not connected. We will connect the two ends. Connection is what is called as anastomosis in surgery. So connection, we are trying to connect the two ends of esophagus, that is called as anastomosis. We are connecting one part of esophagus to another part of esophagus, and that is what is called as esophageal anastomosis, or also known as esophagostomy. Okay, so that's important. So if the two ends are close to each other, immediately you can go for a surgery, and that surgery, as I've told you, it is called as esophageal anastomosis, also known as esophagostomy. Whereas if the two ends are far away from each other, if the two ends are far away from each other, then you need to wait for some time. Why? So that the two ends will grow towards each other. If the two ends are very far away from each other, you need to wait for some time so that they will grow towards each other, and then you can connect them easily without stretching them. So that till that time, okay, so you need to wait now. So till that time, how you are going to provide nutrition to the child? So till that time, provide nutrition to the child by inserting a tube directly into his stomach. Okay, so that is what is called as gastrostomy. Directly provide nutrition from here. That is known as gastrostomy. So just perform a gastrostomy for a while. Okay, so gastrostomy is done for nutrition till the two ends of esophagus grows close towards each other, and then definitely go for a esophagostomy or a esophageal anastomosis. Okay. Next is, if there is type B, C, D or E, in all of these there was what? There was a tracheoesophageal fistula. So here it depends on the birth weight or the Watterson's criteria. But the final surgery that we perform in this patient is called as a Cameroon Head surgery. The final surgery that we perform is what is called as a Cameroon Head surgery. What do we do in this surgery? We usually cut the fistula first of all, then we repair the trachea, okay, and then we perform the anastomosis. That is what is called as a Cameroon Head surgery. No issues with this, anybody? That's important. Next question that we have, that was all about your esophageal atresia with tracheoesophageal fistula. Next question that I have over here, please remember, it is a patient who is presenting to me with heartburn. What is a heartburn? वो वाला दिल जले नहीं, ठीक है, जो लड़की छोड़ के जाने के बाद होता है. Okay, that is different. So here a patient is having a heartburn or a pain or burning sensation behind the sternum, retrosternal burn, retrosternal pain, or a heartburn. Okay, or the patient is having an epigastric pain or a retrosternal pain. The patient did not respond to lifestyle modifications. Okay, so lifestyle modifications is always the first line management. He did not respond to that. What is the next step? So what is your diagnosis over here? Please remember, the diagnosis over here is made by these classical symptoms. And what are these? Heartburn, retrosternal pain, epigastric pain. So usually it is a case of GERD. And what is GERD, anybody? I hope all of you are quite aware. GERD is nothing but gastroesophageal reflux disease. I hope all of you are quite aware. This is the esophagus and this is the stomach. Now in between both of them, there is this lower esophageal sphincter. And due to this lower esophageal sphincter, the acid is not able to go into the esophagus. The stomach acid which is there now, it is not able to go into the esophagus because of this sphincter. But what if the sphincter starts relaxing? Okay, ये sphincter क्या हो रहा है? ये sphincter बहुत ज़्यादा relax हो रहा है. If the sphincter starts relaxing too frequently, what will happen? The acid from the stomach will now go into the esophagus. Is the esophagus used to this acid? Esophagus को आदत है कि ऐसे acidic environment की? नहीं. So therefore the esophagus will start showing some changes. That is what is GERD. So please remember, when definitely the lower esophageal sphincter, okay, the lower esophageal sphincter starts relaxing too frequently, the acid will go into the esophagus. That is what is gastroesophageal reflux disease. Okay, so that is what you need to understand over here. Important is, gastroesophageal reflux disease is due to increased frequency. It is due to increased frequency of lower esophageal sphincter relaxation. More lower esophageal sphincter relaxation is occurring in the patient. Okay. Now the classical triad that I've told you, the patient will have heartburn, or there will be retrosternal burn, or a retrosternal pain, will be epigastric pain. Now this reflux can also come till the throat of the patient. Okay, and due to that the patient can have a sore throat as well at times, or the patient can have a hoarseness of voice as well, because this acid can also go into the larynx of the patient. Laryngopharyngeal reflux can occur. or this will keep on coming into the mouth, and therefore you will get a very bitter taste in the mouth. That is called as a sour brush. Okay, and this sour brush, as the acid is coming into the mouth, it will start damaging the teeth, and that will cause dental caries in the patient as well. Okay, so these are the usual symptoms, and GERD is your bread and butter if you are a physician. Okay, so usually what are the risk factors for GERD? Definitely if a patient is drinking a lot of tea and coffee, or smoking, alcoholism, obesity, all of these are risk factors for GERD. Now what is done for investigation? Once you are suspecting, okay, the patient is having GERD, investigation of choice is a upper GI endoscopy. Yes, please remember both of these questions have been asked. Investigation of choice is a upper GI endoscopy. But if they ask you what is the gold standard investigation, if they ask you what is the gold standard investigation, then your answer changes, guys. So please remember, your gold standard investigation is important. Then it is a 24-hour. Then it is a 24-hour pH monitoring. What is the normal pH in the esophagus? Esophagus का normal pH होता है 5 से 7. The normal pH of esophagus is 5 to 7. But as the acid is going into the esophagus, the pH of the esophagus falls low. Okay, the pH of the esophagus falls down. So therefore, the gold standard investigation is a 24-hour pH monitoring. That has been again a question. Both of these were questions. Okay, and on a 24-hour pH monitoring, we will see that the pH of esophagus is falling below 4. For more than 4 times in a span of 24 hours, that makes the diagnosis. Or we have a score, and what is that score known as? It is known as the D-Mister score. So if the D-Mister score which is there, the D-Mister score, when it is more than 14, okay, when the D-Mister score is more than 14, to be specific, more than 14.7, then that makes a diagnosis of your GERD in a patient. What is the first line management in a case of GERD? Definitely, if I talk about the treatment, the first line management is always lifestyle modification, lifestyle changes. Ask the patient to reduce weight, ask the patient to do regular exercise, ask the patient to avoid any fried fatty food, because this fried fatty food causes a lot of lower esophageal sphincter relaxation. Okay, what you have generally now during your preparation days. Okay, apart from that, ask the patient to avoid smoking and alcohol, ask the patient to avoid tea, coffee, chocolates. Okay, so all of these things. Okay, ask the patient to take only small frequent meals, and ask the patient to take the last meal usually before 2 hours of sleep. Okay, before 2 hours when you go to sleep. तुम बोलोगे सर जिंदा ही क्यों है फिर? ठीक है, so that's the important thing. Usually lifestyle modification should be done, but if that fails, definitely then you need to go for. Now here we have seen in the question they mentioned lifestyle modifications were done, but the patient did not respond, those failed. Then definitely we will go for a medical management, and the medical management or the drug of choice will be PPIs. What are PPIs? Proton pump inhibitors. Proton pump inhibitors will inhibit the proton pumps, decreasing the acids in the stomach. Okay, so PPIs are not only considered as the drug of choice, but they are so effective in GERD that they are also considered nowadays as the treatment of choice for GERD. Yes, surgery is not the treatment of choice, PPIs are the treatment of choice. Please remember that. Okay, so that's important. If I talk about the surgery now, if the patient is not even responding to the medical management or your PPIs, okay, then I'll go for the surgical management of choice and the surgery of choice that we do. I will pull up the fundus of the stomach, okay, the upper part of the stomach. Okay, so if I draw this as the stomach, so this is what is called as the fundus. I will pull up this part of the stomach and I will wrap it all around the esophagus. I'll wrap it all around the esophagus definitely. And this wrapping of fundus of the stomach around the esophagus is known as fundoplication. It is known as fundoplication. If it is done all around, that is 360-degree wrap karte hai. If we do a complete wrap of 360-degree around the esophagus, then that is what is called as a Nissen's fundoplication. And that is the surgery of choice in cases of GERD. That is the surgery of choice which is performed in cases of GERD. Okay? Very good. Next, talking about esophageal cancer now. Important is I would like to talk about important complications of GERD as well, because they are commonly asked. So please remember, if they ask you which is the most common complication of GERD, then the most common complication of GERD, if I talk about, then the answer is definitely, as there is a constant reflux into the esophagus undergoes inflammation. And agar esophagus ka inflammation ho jata hai, that is what is called as esophagitis. That is what is known as esophagitis. Okay, that's the important thing. But this esophagitis, this inflammation can further progress and there can be a cellular adaptation. So for example, if you are undergoing some stress, you might have studied in patho. What you try to do? You try to adapt to the newer environment. So does the esophageal epithelium. Esophageal epithelium भी क्या करता है, नए environment को adapt करने की कोशिश करता है. Esophageal epithelium tries to adapt to the newer environment and therefore it undergoes a metaplasia. What is metaplasia? Change from one adult cell type to another adult cell type. So here usually the normal epithelial lining of esophagus is squamous, but the squamous epithelial lining starts changing to columnar. Okay, it becomes columnar, and this is what is called as columnar metaplasia. This columnar metaplasia, which is seen in the esophagus, is a very special variety of metaplasia, and therefore it is also known as intestinal metaplasia. Yes, it is just as the same columnar epithelium which is also seen in the intestine. It is just as the same epithelium which is also seen in the intestine, and very good. This complication of GERD is what is classically known as the Barrett's esophagus. This complication is known as Barrett's esophagus. So Barrett's esophagus is nothing but intestinal metaplasia which is seen. Okay, important is now what will be the investigation of choice for Barrett's esophagus. The investigation of choice for Barrett's esophagus will be upper GI endoscopy should be done. But now upper GI endoscopy can show me a red velvety mucosa. I will take what? From that red velvety mucosa which has undergone metaplasia, I will take a biopsy. And then on biopsy, I will be able to see this classical or a specialized intestinal metaplasia. And what is the hallmark on biopsy? What is the hallmark feature of Barrett's esophagus? So along with the intestinal metaplasia, I am able to see a very characteristic type of cells. The cells which secrete mucin or mucus. And what are those cells called as? Goblet cells. Yes, along with intestinal metaplasia, I am able to see the goblet cells which are considered as hallmark feature of Barrett's esophagus in a patient. Okay? So that's important. What is the treatment in cases of Barrett's esophagus? So the treatment in cases of Barrett's esophagus, you need to remember, it is nothing but a 2-yearly surveillance with endoscopy. Okay, so it is a 2-yearly. After every 2 years, call the patient for an endoscopy and if required a biopsy. The 2-yearly endoscopic surveillance should be done. Okay, 2-yearly endoscopic surveillance has to be done along with biopsy if required. Okay, but if any of the biopsy shows not metaplasia but dysplasia, okay, any of the biopsy shows dysplasia, so you know कि metaplasia does not have a high risk of malignancy, but dysplasia has a very high risk of malignancy. Therefore, if any endoscopy shows, also any biopsy shows dysplasia, then try to ablate the abnormal mucosa, and that ablation of abnormal mucosa is either done with the help of radiofrequency ablation, or you can go for a argon photocoagulation. Radiofrequency ablation or argon photocoagulation. याद रखना, Barrett's is a very classical and a very common question of your exam. It is the examiner's favorite as well. GERD and Barrett's. So please remember about Barrett's. I know the treatment is not taught a lot of times. So here it is. No issues with this. Now if Barrett's is not treated, what will happen? There will be dysplasia, and that dysplasia can further progress into esophageal cancer. Now normally the normal lining of your esophagus, normal mucosa कौन सा होता है esophagus का? Squamous epithelium. So the normal cancer which will arise in esophagus will be a squamous cell carcinoma. But if a patient is suffering from Barrett's esophagus, what has happened? There's a columnar epithelium which is there now, and therefore if a cancer which will arise from columnar epithelium will be there, it will be a adenocarcinoma. So in cases of Barrett's esophagus, we do not see a squamous cell carcinoma commonly, we see a adenocarcinoma commonly. Okay, and adenocarcinoma, we will discuss about it now in the esophagus. Okay, next important is if I talk about the esophageal cancers. If I talk about the esophageal cancers, guys, okay, now there are two types of esophageal cancers or esophageal carcinomas. One is called as the squamous cell carcinoma, other is the adenocarcinoma. Please let me know which one is more common. Which one is more common, squamous or adeno? Which type of esophageal cancer is more common? Which type of esophageal cancer is more common? Now we know that the normal lining of your esophagus is definitely squamous. Therefore, the more common type of cancer, the more common type of esophageal cancer is squamous cell carcinoma. More common type of esophageal cancer is a squamous cell carcinoma. Okay, yaad rakhna. So this is more common. If I talk about squamous cell carcinoma is most common esophageal cancer worldwide. Yes, it is the most common esophageal cancer worldwide. Even it is the most common esophageal cancer in India. So where is adenocarcinoma most common? Adenocarcinoma is the most common type of esophageal cancer in the Western world, where the people are at a high risk of developing GERD due to obesity, due to sedentary lifestyle, due to their food eating habits. and due to which they will develop Barrett's, and due to which they develop adenocarcinoma. So overall, our India, most common type of esophageal cancer, squamous cell carcinoma. But in the Western world, most common type of esophageal cancer, it is definitely the adenocarcinoma. What is the most common site of squamous cell carcinoma of esophagus? If I divide the esophagus into three parts, this is the upper 1/3, this is the middle 1/3, and this is the lower 1/3. The most common site of squamous cell carcinoma is this one. So most common site of squamous cell carcinoma, it is the middle 1/3 of the esophagus. But where was Barrett's esophagus or GERD most common? GERD, there was acid reflux mainly in the lower 1/3 of the esophagus. So metaplasia will be more common in the lower 1/3 of the esophagus. Barrett's will be more common in the lower 1/3. Dysplasia more common in lower 1/3. Therefore, adenocarcinoma is also more common in the lower 1/3 of esophagus. Okay, so adenocarcinoma is more common in the lower 1/3 of esophagus. That's important. Okay, what are the risk factors now? At least remember the important risk factors for both the cancers. Common risk factor for both the cancers, we know the common risk factor for both the cancers is definitely your smoking and alcohol. Okay, सुन लो अच्छे से, ठीक है? So the most common risk factor for both the cancers is smoking and alcohol. Important is you need to remember that an important risk factor for adenocarcinoma, we know it is Barrett's esophagus, and Barrett's esophagus, we know it is nothing else but the complication of GERD itself. Okay, it is a complication of GERD. So these are important complications for adenocarcinoma. But if they ask you most important complication of squamous cell carcinoma, you need to remember a motility disorder that we'll discuss. It is known as achalasia cardia. So achalasia cardia is an important risk factor for squamous cell carcinoma of esophagus. Other risk factors for squamous cell carcinoma can be a preservative rich or a smoked food. It can be Tylosis palmaris or Tylosis plantaris. And important, it is a Plummer-Vinson syndrome in females. That's important, okay? No issues with this, anybody? Now, if I talk about esophageal cancer in a patient, what will be the complaint of the patient? Definitely, there is a cancer in the esophagus. So the patient will have difficulty in swallowing something. The patient will have dysphagia. As the patient is having dysphagia, the patient will not be able to eat a lot of things. Therefore, the patient will have chronic weight loss as well. Okay. And the patient can even develop cough. Why the patient develops cough? Because if there is esophageal cancer, this can grow till the trachea. And there can be a tracheoesophageal fistula. That can cause cough in the patient. Or the patient can have hoarseness of voice when there is involvement of the recurrent laryngeal nerve. Now, important is this dysphagia or difficulty in swallowing which is there to the patient. It will be more common, okay? This dysphagia which is there, it is more common for solids or liquids. किसको ज़्यादा दिक्कत होगी पास होने में? Which one will have more difficulty in passing? Definitely the solids. Solids will have difficulty in passing. Liquids can easily pass. Liquids can easily pass, right? So here definitely the dysphagia is more commonly seen to solids followed by liquids. Okay, so the patient will have more dysphagia to solids as compared to liquids. Now, once you are suspecting esophageal cancer in a patient, then you will definitely go for investigation. If I talk about what is the investigation of choice, answer is definitely we can reach till the cancer. And if you can reach till the cancer, if you can take a biopsy, that's the best thing. Okay, so definitely upper GI endoscopy should be done along with biopsy. So upper GI endoscopy plus biopsy is the investigation of choice for esophageal cancer. Next, what is the investigation of choice for distant metastasis? That means when the cancer spreads to the other organs. What is the investigation of choice? It is a whole body scan. And what is that scan called as? Very good. It is a PET scan. Important is what is the dye used in PET scan? That has been a question. PET is nothing but positron emission tomography. And the PET scan is used for distant metastasis. And the dye which is used is 18-FDG. What is 18-FDG? 18-fluorodeoxyglucose. Now, yes, glucose is used as a dye over here. Why? Because we know that cancerous cells or malignant cells eat a lot of glucose. They will require more amount of glucose as compared to normal cells. And that is the reason why patient suffers weight loss in cases of malignancy or cancers. Okay? So 18-FDG will be given, and wherever you will see more uptake of 18-FDG, जहाँ ज़्यादा uptake दिखेगा, that is what is suggestive of a metastasis. No issues with this, anybody? That's important. What is the half-life? That was a question. So half-life of 18-FDG is around 110 to 120 minutes. Half-life of 18-FDG is around 110 to 120 minutes. Next, to assess the depth or the T and N staging. So yaad rakhna, what did I tell you in other cancers? In other cancers, the T staging which was there, It was decided by the size of the tumor. But in cases of GIT cancers, the T staging which is there, it is assessed with the help of depth of invasion. That means कितना गहरा है कैंसर, कौन सी layers को involve किया उसने. Okay, so the T staging in a case of GIT cancer is assessed with the help of depth of invasion. How much deep the cancer is, that will tell you about the T staging. Okay, so for assessing the depth of invasion, or for assessing the T and N staging, okay, T and N only, then definitely, please remember, then definitely we will go for what? We will go for a endoscopic ultrasound, because endoscopic ultrasound can tell better about the layers which have been involved. Okay, endoscopic ultrasound. Whereas if they ask you about overall staging, important is if they ask you about overall staging, overall का मतलब होता है T and M, okay, along with distant metastasis also, then your best answer should be a PET CT. For overall staging, the best answer is a PET CT. Yeah. Okay? Then if I perform a barium swallow in a patient, I hope all of you are quite aware, when we give barium sulfate to the patient, barium sulfate is a dye or a contrast which will highlight the organ in from which it is flowing. Okay, जिस organ से flow कर रहा है उस organ को highlight करेगा, वो X-ray पे highlighted दिखेगा अपने को वो organ. ठीक है? Now once we give barium sulfate to the patient and we take a X-ray of the patient, ठीक है? If the barium sulfate is in the esophagus, that investigation is called as barium swallow. If the barium sulfate is in the stomach, that is what is called as barium meal. If the barium sulfate is in the small intestine, that is called as barium meal follow through. And if we have given the barium sulfate not orally but via the rectum and it is going ulta, okay, it is going in the retrograde fashion, then and we take an X-ray of the large intestine or the colon. So if the barium is in the large intestine or colon, that is called as barium enema. Okay, so that's important. So if I talk about barium swallow for the esophagus, you can see the part which is where there is a cancer, definitely it will not take up the contrast, and that is what is called as filling defects. So you can see this classical filling defects. Along with that, you will be able to see this shaggy irregular border. Please don't call it as the pencil tip or the bird beak sign. No, there is a classical difference. Bird beak sign is very sharp margins, very regular sharp margins. These are irregular shaggy margins. Okay, so no book calls it the same thing. No book calls it. Okay, so that's important. Please remember over here, it is the classical rat tail appearance. Very good. It is the classical rat tail appearance which is seen over here. Or sometimes even they call it as the apple core appearance. But apple core appearance is commonly seen on the barium enema in a case of colorectal cancer. Okay. Chalo. Now if I talk about the treatment now. Treatment is definitely what? Treatment is definitely esophagectomy. Surgery is the first line of management. Esophagectomy is nothing but removal of the esophagus. The proximal margin which is taken is huge. Okay. In other cancers, we generally take 1 to 2 centimeter margin. But here we take the proximal margin. ऊपर वाला जो margin होता है, it is around 10 centimeters. Whereas the distal margin that we take, नीचे वाला जो margin होता है, the distal margin, please remember, it is around 5 centimeters. Okay. The distal margin is around 5 centimeters. No issues with this, anybody? That's important. Then if I talk about the surgery of choice, if the cancer is in the upper 1/3 of the esophagus, if the cancer is in the upper 1/3 of esophagus, then the type of esophagectomy or the surgery we call it is known as McKeown surgery. It is known as a McKeown surgery. If the cancer is in the middle 1/3 of the esophagus, it is known as the Ivor-Lowy surgery. Then it is known as the Ivor-Lowy surgery. And this was the question. This has been the question. When the cancer is in the middle 1/3 of the esophagus, which is the surgery performed, you just need to remember the names. It is Ivor-Lowy surgery. And next, when the cancer is in the lower 1/3 of the esophagus, then the surgery which is performed is known as the Oringer surgery, also known as transhiatal surgery or the Oringer surgery. Okay? Sure. So these are the types of esophagectomy commonly performed in a patient. Next, if I talk about a classical condition, and that is this one. This barium swallow, as you can see over here, the lateral view. It is showing a outpouching from the esophagus. And I've already told you outpouching from an organ is called as a diverticulum. And the outpouching from an esophagus or a diverticulum from the esophagus, which is seen over here, is known as Zenker's diverticulum. Okay, so if I talk about Zenker's diverticulum, okay, so please remember, important is from where the Zenker's diverticulum will arise. I hope all of you are quite aware of the pharyngeal and the esophageal anatomy. Okay, so the pharynx and the esophagus have some circular muscles. And what are these circular muscles called as? These circular muscles are called as constrictor muscle. Okay, So first we have the superior constrictor muscle, then we have the middle constrictor muscle, and then we have the inferior constrictor muscle. But the funda with inferior constrictor is it has two kind of fibers. One are called as the thyropharyngeus fibers, and second, these oblique fibers are thyropharyngeus, and second are the circular cricopharyngeus fibers. The circular ones are known as cricopharyngeus fibers. These two together makes up the inferior constrictor muscle. Now you can see in between the inferior constrictor or in between the thyropharyngeus and cricopharyngeus. That was the question. Zenker's diverticulum arises between which two muscle fibers? Answer was between thyropharyngeus and cricopharyngeus. Okay. So in between this thyropharyngeus or cricopharyngeus, you can see this triangular space. You can see there are no muscle fibers in this triangular space. Or agar muscle fibers nahi honge, so this will be a very weak area. And weak areas are generally called as dehiscence. So this triangular weak area or dehiscence which is seen is known as Killian's dehiscence. And we know that Killian's dehiscence is the most common site. Please remember, this Killian's dehiscence is the most common site for your Zenker's diverticulum. Okay, so from here the esophagus will outpouch. Okay, there can be outpouching from here, known as Killian's dehiscence. Okay, so Zenker's diverticulum most common site is the Killian's dehiscence. Now it is more commonly seen in which population? Mainly the elderly age group. Important is Zenker's is a true diverticulum or a false diverticulum. What is the basic difference? Understand once. If the diverticulum has all the layers, mucosa, submucosa, muscularis, serosa. Okay, please remember esophagus does not have a serosa. Esophagus only has a adventitia. Serosa is not there. Okay, so if all the layers are present, it is called as a true diverticulum. But if only mucosa or submucosa are present, that is called as a false diverticulum. Important is Zenker's is a false diverticulum that you need to remember. Is it present since birth? No, it appears after birth. Therefore, it is not a congenital, rather it is an acquired diverticulum. Third important, if this outpouching occurs due to increased intraesophageal pressure, अगर esophagus के अंदर pressure बढ़ने की वजह से esophagus बाहर push हो रहा है, that is what is called as a pulsion diverticulum. If it occurs due to increased intraesophageal pressure, due to which the esophagus is pushed outside, that is called as a pulsion diverticulum. And Zenker is an example of pulsion diverticulum. If it is due to pull from outside, some outside structure is pulling the esophagus, then that is what is called as a traction. But Zenker's is a pulsion diverticulum due to increased intraesophageal pressure. Important is, what is the classical triad? So please remember the classical triad in cases of Zenker's diverticulum. Important is, the earliest feature is, now in this pouch, there can be collection of food. Okay, and when the patient will lie down, all this food will come into his mouth. That is called as regurgitation. So the earliest feature is definitely regurgitation. The other two features can be, the patient can have intermittent dysphagia. That means sometimes the patient can have difficulty in swallowing. Okay, so intermittent dysphagia can be there, or this food which is collected in this pouch can get infected and that can lead a bad odor, and the bad odor or bad breath is known as halitosis. So these are the classical features of the triad of Zenker's diverticulum. Now if a patient is having swelling, not every case of Zenker's diverticulum can have a neck swelling, because most commonly it arises posteriorly. Sometimes it can be seen as a lateral neck swelling. And if there is a lateral neck swelling on examination, if I press this lateral neck swelling, there is fluid inside this swelling, like this gurgling sound will come. And that is what is called as a Boyce sign. Rice sign is another one which is seen in ENT. When I press this swelling and there is a hissing sound like this, it is due to escape of air. That is seen in cases of laryngoscele in ENT. But here it is seen in cases of Zenker's diverticulum known as Boyce sign, which is a gurgling sound. Investigation of choice, as you can see over here in the image which is given, it is nothing else but the barium swallow. And the barium swallow lateral view shows you the outpouching. Treatment important. If I talk about the treatment, definitely, if it is less than 2 centimeters in size, I will just make incisions over this cricopharyngeus fibers. If I give incisions over this cricopharyngeus fibers, okay, what will happen? The pressure will be released, and then definitely what will not happen? The esophagus will not come out, because it is coming out because there is a lot of pressure from this constrictor muscle and it is trying to find a way out. So therefore, if you give multiple incisions over the cricopharyngeal muscle, then definitely the pressure will be released, and that is called as cricopharyngeal myotomy in the patient. Cricopharyngeal myotomy usually. Okay, so that is what is done if the Zenker's diverticulum is very small. And sometimes if you feel that the diverticulum should also be removed, you can even go for a diverticulectomy. If the diverticulum is between 2 to 4 centimeters, you can just pick up the diverticula and fix it above so that no collection of food should occur over here. That is called as fixation, is known as PEXI. And as you are fixing the diverticula, it is known as diverticulopexy. And if the diverticula is more than 4 centimeters, then what you are going to do? You are using a linear stapler, and with that linear stapler, you are combining the diverticula with the main esophagus, and that is what is called as Dohleman's procedure or diverticuloesophagostomy. Okay, Dohleman's procedure is nothing but diverticuloesophagostomy. That means connect the diverticula to the main esophagus with the help of a linear stapler that I've already told you. Okay, so that's important. That was all about your Zenker's diverticulum. Very important question of your exam. Next, if I talk about is this condition. What is seen? The chest X-ray of this neonate. Just a minute. The chest X-ray of this neonate is taken, and you can see on that, you can see on the left side of the thorax, you can see a lot of bowel loops or bowel shadows. Okay, intestinal loops are seen or intestinal shadows are seen. Whereas you can see the abdomen of this child. The abdomen appears as if a scoop has been taken from it. मतलब ice cream का scoop निकाला हो किसी ने जैसे. ठीक है? So this is a case of CDH. What is CDH? Congenital diaphragmatic hernia. So CDH is nothing else but congenital diaphragmatic hernia. Important is, normally there are 3 openings on the diaphragm, right? There are 3 openings on the diaphragm. One, it is at the level of T8 for the inferior vena cava. Next is it at the level of T10 for the esophagus. Okay. And next is at the level of the T12 and it is for the aorta. It is remembered by Voice of America, right? T8, T10, T12, very important. Now, apart from these 3 openings, iske alawa, apart from these 3 openings, there is also another opening in the esophagus, in the diaphragm. There is also another defect which is present in the diaphragm, or there is another opening in the diaphragm. If there is this opening in the diaphragm, what happens? The intestines will go into the thoracic cavity. Due to this defect in the diaphragm or due to this opening in the diaphragm, the intestines will herniate or the intestines will go into the thoracic cavity. As they go into the thoracic cavity, will the lung get enough space? No, the lung does not get enough space to expand. Okay, and what will happen to the heart? The heart will also be pushed towards the opposite side. The heart is also pushed towards the opposite side. Okay. So in cases of congenital diaphragmatic hernia, congenital why? Because it is present since birth. And what is the problem? A defect in the diaphragm. Important is, what is the classical triad in cases of congenital diaphragmatic hernia? So the classical triad which is there is remembered as RDS. Now as the lung is not able to expand, definitely the patient will have respiratory distress. So the neonate has respiratory distress. The heart is shift towards the opposite side or towards the right side commonly, and therefore the patient has dextrocardia or a right-sided heart. S stands for, as the abdominal organs or the intestines are going into the thoracic cavity, क्या हो रहा है? The thoracic cavity, the anteroposterior diameter of thorax is increasing. That is known as barrel chest. But the abdomen appears to be scooped. मतलब किसी ने एक scoop लिया हो जैसे abdomen से. And this scooped out abdomen is what is known as the scaphoid abdomen. That is what is known as the scaphoid abdomen. Okay? So that is the classical triad. Now important is, please remember in congenital diaphragmatic hernia, if the child is having respiratory distress, definitely we try to give what? We try to give ambu bag, that is bag and mask ventilation. But important is, if we give bag and mask ventilation in this child, the condition will be further worsened. बच्चे की condition और खराब हो जाएगी. Understand why? Now if a child is given oxygen with the help of a mask, this air is going into his nose, that's fine, but the air is also going into his mouth. From the mouth, the air will go into his esophagus, from esophagus to the stomach, from stomach to the intestine. And where are the intestines lying? The intestines are already lying in the thorax. Now what will happen to this intestine? As a lot of air is coming into the intestine, these intestines will distend or they will dilate and they will further compress the lung. So rather than improvement in the respiratory distress, there will be worsening of respiratory distress. Therefore, what is absolutely contraindicated is bag and mask ventilation. There is bag and mask ventilation is absolutely contraindicated in a case of CDH. That's the important thing. Now if they ask you which is the more common type, which is the most common type of CDH or congenital diaphragmatic hernia, you need to remember it is the Bosch-Dallek hernia. Okay, more common is the Bosch-Dallek hernia, and Bosch-Dallek hernia is commonly seen on the left side. Okay, and that too in the posterolateral wall. okay, in the posterolateral wall of the diaphragm. It is commonly seen. Okay, so therefore, if I take a chest X-ray of the child, as the child is having respiratory distress, I would like to see whether the child is having respiratory distress syndrome or is having congenital diaphragmatic hernia. So I'll get a chest X-ray done, and on chest X-ray, what is seen? You can see the bowel loops in the thorax. That is a characteristic picture. Okay, so there will be bowel loop shadows in the thorax. That is what is seen on a chest X-ray of the patient. That's important. Okay, sure. What is done for treatment? Treatment is nothing but, please remember, bag and mask ventilation is not given. Rather give intubation to the patient. Why? Because if you give intubation to the patient, you are inserting a tube directly into his trachea. So the air will not go into his esophagus and from there to the intestine. It will directly go into his trachea and then into his lungs. Okay, so that's done. Okay, so for improvement, definitely we'll go for intubation. And treatment is nothing but reduce the herniated organs and close the defect. Okay, reduce the herniated organs and close the defect. If the defect is too big, you can use a prosthetic patch or a mesh as well, that we commonly use in hernia. Next is very important topic, and that is foreign body ingestion. Sarkari question of your exam. If I talk about foreign body ingestion, more commonly, who ingests a foreign body? Kaun khata hai foreign body? Normally a child itself, right? So the most common age group is children. If they ask you which is the most common foreign body in children, so the most common foreign body in children is generally a coin. The most common foreign body in children is generally a coin. In an adult, if they ask you which is the most common foreign body, the most common foreign body in an adult is a fish bone. It is generally a fish bone. The most common foreign body in an elderly, if they ask you, it is usually the loose teeth which are there or the dentures. The loose teeth or the dentures. Important is, please remember, if a patient comes to you with foreign body, the foreign body can be either in the esophagus of the patient. The foreign body can either lie in the esophagus of the patient, when the patient will only have dysphagia, okay, or the patient can have choking sensation. Okay, the child will come to you like this. There will be a choking sensation, or the patient will be asymptomatic also at times. Yes, the child can be asymptomatic. But if the foreign body is in the trachea, or the foreign body is in the bronchus, okay, or the foreign body is in the larynx for that matter, all these conditions, the patient will be symptomatic, and here the patient will have what? The patient will have respiratory distress. The patient will have respiratory distress. Okay, so that is a common thing that you will see in the patient, or the patient will not be able to speak anything. That is aphonia, loss of voice. Okay, so now if I talk about the treatment, management of the patient, once a child has been brought to you with all these symptoms, or the child is asymptomatic, the mother tells you, okay, is bachche ne coin khaya. Okay, the child has ingested a foreign body. What is the first line investigation? Definitely the first line investigation is a X-ray. Please remember, the first line investigation is X-ray. We will take a X-ray neck as well as the X-ray chest. Please remember, we are not sure now, and even the X-ray abdomen is taken at times, because maybe the foreign body that the child has ingested has gone till the abdomen also. So complete X-ray has to be taken. Once we take the X-ray of the child, then this you can see over here. Okay, so important is, see, if now just understand, okay, trachea lies anteriorly, esophagus lies posteriorly. Okay, now if the foreign body goes into the trachea, which diameter of trachea is larger? The anteroposterior diameter of trachea is larger. Therefore, the foreign body goes like this in trachea, and it goes like this in trachea. So if I take a AP view of the X-ray, how you can see the foreign body of the coin? You can see a slit-like appearance. But when I take a lateral view, you will see a circular appearance of the coin. Okay? So that is the tracheal foreign body. Next, if the foreign body is in the esophagus, which diameter of the esophagus is larger? कौन सा diameter बड़ा होता है esophagus का? The esophageal horizontal or the transverse diameter of the esophagus is large. Therefore, the foreign body in the esophagus, or the coin in the esophagus, will go like this. And as it goes like this, the AP view will show which appearance? The AP view will show circular appearance. But if I talk about the lateral view will show slit-like appearance. So just remember that. Important is, we will take both the views. We will take a AP view of the X-ray, and we will also take a lateral view of the X-ray. If the AP views shows a slit-like appearance, if the AP views shows a slit-like appearance and the lateral view shows a circular appearance, then the foreign body is in the trachea. Or if the AP view shows us a circular appearance. AP view shows us a circular appearance. On the lateral view shows us a slit-like appearance. Then the site of foreign body is the esophagus. Apart from this, if you're not able to diagnose or remember this in the examination, the second thing that we generally use is this one. See, if the foreign body is in the esophagus, that means it lies behind the trachea. And trachea is what? Trachea is nothing but a windpipe. Okay, it contains air, and air appears black on X-ray. Therefore, if you can see a black shadow or a black air column in front of the foreign body, that means the foreign body is not in the trachea. The foreign body is behind the trachea. That means in the esophagus. Okay. So if you are able to see a black column of air in front of the foreign body, that means the site of foreign body is the esophagus. Okay. Chalo. Now if I talk about the treatment of the patient, so important is if the foreign body is in the trachea, in the bronchus or in the larynx, definitely we cannot leave a foreign body because from there it will go into the lungs. Okay, so definitely here we need to always go for an endoscopic removal. We will always go for an endoscopic removal. Now, wherever the endoscope is, the name of the endoscopy will be. Matlab, a lot of times now, this time they have mentioned esophagoscopy. That is nothing but endoscopy of esophagus. They will mention bronchoscopy. That is nothing but endoscopy of bronchus. Okay, so that's the important thing. Wherever the endoscope is, that will decide the name. Next is important is when the foreign body lies in the esophagus. Then this is very important. This remember please. If the foreign body is in the esophagus, definitely you need to see whether the foreign body lies above the cricopharyngeal sphincter or if it lies below the cricopharyngeal sphincter. What is the cricopharyngeal sphincter? It is nothing but the upper esophageal sphincter. And upper esophageal sphincter is at which level? We know the upper esophageal sphincter is at the level of C6, at the 6th cervical vertebra. On the X-ray, you need to see the 6th cervical vertebra. If the foreign body lies above the cricopharyngeal sphincter, definitely you need to go for an endoscopic removal. Here you need to go for an endoscopic removal. But if the foreign body lies below the cricopharyngeal sphincter, if the foreign body lies below 6th cervical vertebra or below the cricopharyngeal sphincter, then this was the recent FMGE 2023 question. Okay. So if the foreign body lies below cricopharyngeal sphincter, then definitely you need to go for observation and serial X-rays. You need to go for observation and serial X-rays. Serial matlab after every 24 to 48 hours we will take X-rays in the child. ठीक है? हर 24 से 48 घंटे बाद X-ray लो. You will say why sir? Very good. So please remember, as CPS or the cricopharyngeal sphincter is the narrowest portion of whole GIT. पूरे GIT में अगर सबसे narrow portion कोई है तो वो CPS है. If the foreign body can pass the cricopharyngeal sphincter, it can pass via any part of GIT easily. So if the foreign body has passed the cricopharyngeal sphincter, now it is lying below the CPS now, it can pass any part of the GIT. Okay, so that's the reason why we'll only go for observation and serial X-rays. That has to be done. But on observation and serial X-rays, you see that the patient is asymptomatic, no symptoms is there, and in every X-ray the foreign body is distally moving. Okay, it is moving further. Then just go for observation. Continue observation and ask the mother to give meshy foods to the child so that the foreign body can pass easily through the GIT, like banana, jellies, all of that. Okay, and observe the stools as well. So whenever the coin goes out, definitely it will be seen. And if the if the patient turns symptomatic, he starts having, for example, abdominal pain. Okay, so usually if the foreign body, if the patient turns symptomatic or if the foreign body is not moving distally, then in this condition, wherever the foreign body is, go for an endoscopic removal. Go for an endoscopic removal as well. Okay, that's important. If the foreign body is a disc battery, what is a disc battery or a button battery? Disc or a button battery is nothing but the small toy batteries which are used now. The small toy batteries which are there, these are disc or button batteries. Now they are very dangerous. Why? Because these batteries release alkali. And what is more dangerous, we know? It is the acids of alkali. Definitely alkali. Why? Because they cause liquefactive necrosis, and due to this necrosis there will be perforation as well. That's the reason why it is important. If the foreign body is a disc battery, go for immediate endoscopic removal. Whatever is the location, whether it is in the colon, esophagus, stomach, does not matter. Go for an immediate endoscopic removal. Okay, if the foreign body is a disc battery. Chalo. Then talking about next type of hernia, that is called as hiatal hernia. What is a hiatus? Hiatus is nothing but diaphragmatic opening for the esophagus, for the vena cava, or for the aorta that I have discussed. Okay, so the esophageal opening is also known as esophageal hiatus. It is located at the level of T10, from which the esophagus passes from the thoracic cavity into the abdominal cavity. Okay, and the junction at which the esophagus ends and the stomach will start, this junction is called as gastroesophageal junction. In a normal patient, as you can see over here, in a normal patient, where is the gastroesophageal junction? In a normal patient, the gastroesophageal junction lies in the abdominal cavity. It lies in the abdomen. Please remember that. Okay. Now, in some patients, what can happen? This opening which is there now, this opening can be too big. And if this opening is too big, what will happen? The abdominal organs can go into the thoracic cavity. Okay. But it will not be such a larger defect as congenital diaphragmatic hernia. Congenital diaphragmatic, what did I tell you? Apart from the normal openings, there is another opening, that is CDH. But here, there is not another opening. Here, the same opening which was there, the natural opening, it is just wide in size. It is larger in size. Okay. So, the first type of hiatal hernia that we need to discuss is a type 1 hiatal hernia. And that type 1 hiatal hernia is known as sliding hiatal hernia. What happens in the sliding hiatal hernia? Nothing, just the gastroesophageal junction which is there. As you can see, normally it was lying in the abdomen, but now it is lying in the thorax. So if the gastroesophageal junction comes upwards in the thoracic cavity, that is a sliding hiatal hernia. So the gastroesophageal junction slides into the thoracic cavity. Okay, this is not so severe, and this is also the most common type of hiatal hernia. This is also the most common type of hiatal hernia. It is not so severe. Here the patient will only have symptoms of GERD. Here the patient will only have symptoms of GERD, nothing else. Okay? Whereas the type 2 hiatal hernia which is there, the type 2 hiatal hernia which is there is known as a paraesophageal hernia, also known as a rolling hiatal hernia. It is also known as paraesophageal or a rolling hiatal hernia. Why? Because over here the opening is so big that not here the gastroesophageal junction is not sliding, rather some part of the stomach is going into the thoracic cavity. Okay, so some part of the stomach is actually going into the thoracic cavity. Okay, what will happen? This stomach can be compressed over here. Okay, and the blood supply to the stomach will also be decreased, and as the blood supply to the stomach will be decreased, what will happen? There can be necrosis of this part of the stomach as well, and therefore paraesophageal or rolling type of hiatal hernia is more severe, because there can be risk of necrosis of the stomach as well. Here you can see how you differentiate. The gastroesophageal junction is still in the abdomen. Yes. So gastroesophageal junction, if it is still in the abdomen, only the stomach is going, that is paraesophageal or type 2. But if the gastroesophageal junction is in the thorax and the stomach is normal, that is type 1. Okay. Chalo. So these are the two types of hiatal hernia. More severe, we know it is a type 2 hiatal hernia. What is the investigation of choice in this patient? The investigation of choice in the patient is usually a CT with contrast. Okay. If that is not an option, go for a barium swallow. Nowadays, Bailey recommends CT with contrast. If that is not an option, go for a barium swallow. What is the treatment in this patient? Please remember, the treatment in this patient is the same that we were doing for GERD, and that is nothing but Nissen's fundoplication. Nowadays, we don't tightly wrap the fundus of the stomach around the esophagus. Why? Because if we tightly wrap the fundus of the esophagus around the stomach, the gas will not be able to pass, and the patient suffers from gas bloat syndrome. Due to that, nowadays we just wrap the stomach loosely around the esophagus. That is called as a floppy Nissen's fundoplication. Okay, so usually nowadays we perform a floppy or a loose Nissen's fundoplication. So that is important. Moving further, talking about the motility disorders of the esophagus, and these are known as, the first one that I will like to discuss is the achalasia cardia. Now important is, we know that the lower esophageal sphincter which is there, it is having a high pressure. The lower esophageal sphincter zone which is there now, the lower esophageal sphincter, it has a high pressure. Okay, it has high pressure definitely. And how much is the pressure normally? So normal lower esophageal sphincter pressure is between 8 to 25 millimeters of mercury. The normal lower esophageal sphincter pressure is between 8 to 25 millimeters of mercury. But when the lower esophageal sphincter will increase too much, what will happen? Will the lower esophageal sphincter be able to open? No. So as the lower esophageal sphincter is not able to open, the pressure is too high. And that is what is called as achalasia cardia. If the lower esophageal sphincter is relaxing too frequently, that is GERD. But if the lower esophageal sphincter is not relaxing at all, okay, if the lower esophageal sphincter is not relaxing at all, relaxing your a constant spasm mein, that is what is achalasia cardia. So achalasia cardia is nothing but failure of relaxation. It's nothing but failure of relaxation of lower esophageal sphincter, due to which the pressure increases too much. If they ask you what is the most common cause of it, so please remember the most common cause of primary achalasia cardia, it is usually loss of ganglionic cells. Okay, so loss of ganglionic cells. As these ganglionic cells are absent, there is no stimulus to the muscles, and therefore the muscles are not able to relax. From which plexus? That has been important. Okay, that is important. So there is loss of ganglionic cells from the myenteric or the Orbach's plexus of the esophagus. Okay, that is important. From which plexus the ganglionic cells are absent? So they are absent from the myenteric or the Orbach's plexus. Another cause can be deficiency of the neurotransmitters, which helps in relaxation of the lower esophageal sphincter. And which are these neurotransmitters which help in relaxation? So these are usually nitric oxide or vasoactive intestinal peptide. So deficiency of nitric oxide or VIP is also an important cause of achalasia cardia. What will be the symptoms in the patient? So definitely, as the lower esophageal sphincter is not able to relax, will the food be able to pass? No, the food is not able to pass. There is a lot of difficulty in passing food, and that is what is called as dysphagia. Difficulty in swallowing is what is called as dysphagia. Now over here, please tell me, as the esophagus is in constant spasm, there will be more dysphagia to solids or liquids. So important is, here if we give liquids, liquids are lighter in weight, will they be able to exert a lot of pressure? No. So therefore liquids could not pass easily. In esophageal cancer, the liquids were able to pass easily. But now in this condition, if we give solids, okay, if we give solids to the patient, what will happen? Definitely the solids will be more in weight and they will exert a lot of pressure, and therefore the solids can pass. Okay, so here it is ulta. In esophageal cancer, the dysphagia was more to solids, but here the dysphagia is more to liquids. Okay, here the dysphagia is more to liquids as compared to solids. Yes, Chagas disease is also a cause, but that is a cause of secondary achalasia cardia. Okay, very good. So apart from this, what will happen in the patient? Definitely there will be dysphagia that will cause regurgitation. The food will keep on coming in the mouth of the patient, regurgitation. The patient will also have weight loss. Why? Because the patient is not able to swallow anything, na? So that can also lead to weight loss in the patient as well. Okay? And that can also cause halitosis, because खाना कहाँ जमा हो रहा है? Esophagus में. The food is collecting in the esophagus, that can get infected and that can cause bad odor or bad breath. Investigation of choice if they ask you. So please remember, investigation of choice. I need to measure the pressure at the level of lower esophageal sphincter. Pressure is called as mano and measuring is called as metry. So the investigation of choice is a esophageal manometry. And on a esophageal manometry, what will be the pressure? On esophageal manometry, the pressure will be more than equal to 26 millimeters of mercury. Okay, the pressure will be more than equal to 26 millimeters of mercury, and it can go up till 100 millimeters of mercury. Yes, the pressure can be between 26 to 100 millimeters of mercury. Okay, so that will be the pressure. If I perform a barium swallow in this patient, on a barium swallow, this is the classical sign which is seen. You can see over here there are sharp margins, right? In esophageal cancer, there were shaggy and irregular margins. You can see there are sharp regular margins over here. This is what is called as the bird beak appearance. Okay, this is what is called as the bird beak appearance, also known as which sign? The pencil tipped sign, also known as the pencil tip sign. Okay, so bird beak appearance or the pencil tip sign is commonly seen in cases of achalasia cardia. Please remember that. Okay, sarkari question of your exam. Now what is the treatment of choice? Now the lower esophageal sphincter which is there, it is not able to relax. What we will do? We will give multiple incisions over the lower esophageal sphincter. And if we are giving multiple incisions over the lower esophageal sphincter ki muscle, that is called as myotomy, and that was given by Heller's. Therefore, the treatment of choice is known as Heller's myotomy. We can also use drugs like calcium channel blockers, but they are not so effective. We can also go for endoscopic surgery like balloon dilatation, but that has high risk of rupture. Or we can also go for endoscopic surgery like POEMS. But the best one or the treatment of choice is always Heller's myotomy. Okay, so laparoscopic Heller's myotomy is done. But what is the problem? If you will give a lot of incisions over the lower esophageal sphincter, what will happen? Botulinum injection is also not used nowadays because of a high chance of recurrence. Heller's myotomy, if you do, you give multiple incisions over the lower esophageal sphincter. What will happen now? First, it was not relaxing. Now it will start relaxing too frequently. And if it starts relaxing too frequently, what will be the complication? Gastroesophageal reflux disease. Yes. So complication of Heller's myotomy if you give many incisions, it can land up the patient into GERD, gastroesophageal reflux disease. To prevent that, nowadays for prevention, along with Heller's myotomy, we also perform a floppy Nissen's fundoplication. To prevent that, nowadays we also perform a floppy Nissen's fundoplication in the patient. What is the complication of achalasia cardia? This is a complication of achalasia cardia, not surgery. If I talk about the complication of achalasia cardia, definitely the patient will have what? The patient will develop, definitely, as I've told you, squamous cell carcinoma of the esophagus. The patient can develop squamous cell carcinoma of esophagus, definitely. Okay? So that's important. Next, if I talk about, if the pressure, as I've told you, if the pressure is between 26 to 100, it is achalasia cardia. But when the pressure will be more than 180 millimeters of mercury, when the pressure will be between 180 to around 200 millimeters of mercury, then please remember that type of motility disorder. That type of motility disorder is known as a nutcracker esophagus. When the pressure is between 180 to 200 millimeters of mercury, that is known as a nutcracker esophagus. Yes, one another complication can be lung abscess, because definitely the food which was there collected over here, that can go into the lungs, that can cause aspiration for the pneumonia and finally lung abscess in the patient. So most common motility disorder is nutcracker esophagus, where the pressure is between 180 to 200. Whereas when the pressure increases to more than 300 millimeters of mercury, when the pressure is more than 300 millimeters of mercury, and not only in the lower esophageal sphincter, but in the body of the esophagus. But this excess pressure is in the body of esophagus. We can see this classical appearance. Again, a Sarkari question. This classical appearance on barium swallow is known as the corkscrew appearance of esophagus. So corkscrew appearance, also known as a rosary bead appearance of esophagus. That is the classical case of what? DES. Nowadays, please remember, a lot of people know it as diffuse esophageal spasm, no issues. But nowadays it is also called as distal esophageal spasm. So if you get distal in the question, don't get confused, okay? So it is one and the same thing. The new name in belly is distal esophageal spasm. Okay? Treatment is same over here itself. Heller's myotomy. Next question we have. Here we have a 30-year-old male, Kamlesh, who is a chronic alcoholic, and he presents to the emergency room with chest pain and retching episode. What is retching? The patient is trying to vomit, but the patient is not able to vomit usually. That is what is retching. Okay. He gives history of binge drinking. A lot of alcohol he has drank. Free में party मिली उसको दोस्त से, उसने बहुत दारू पी ली. On palpation now, if he tries to palpate the chest, there is a crepitus which is felt. What is the diagnosis in the patient? What is the diagnosis? So important is, now if I talk about this, this is a classical case of a esophageal rupture or a esophageal perforation. याद रखना, esophageal perforation can be of two types. One is iatrogenic, that means due to our fault. When we were performing endoscopy in the patient, the endoscope injured the esophagus, and that caused a iatrogenic esophageal perforation, and that is more common. Okay, and that usually causes perforation in the upper 1/3 of the esophagus. The second type of esophageal perforation which can occur is a spontaneous one due to excessive vomiting or retching episode in a patient, and that is this one which is given in the question. Very good. It is known as Boerhaave syndrome. So this spontaneous esophageal perforation that we have over here is what is called as the Boerhaave syndrome. Okay. So Boerhaave syndrome is nothing but spontaneous esophageal perforation which has occurred, or a rupture which has occurred. A lot of people are like, if I give you a history of chronic alcoholic and binge drinking and retching episode, a lot of people will mark it as malarious. No guys, please remember, not every case can be malarious. Nah? Yes, there is common history in both of them. Chronic alcoholic after a binge drinking episode and a lot of vomiting or retching episode. But in malarious tear, it is only a partial tear. It is only a partial tear. Therefore, the patient will only have upper GI hemorrhage or hematemesis, that is blood in the vomitus. But in cases of Boerhaave syndrome, the esophagus has been completely ruptured. And that is the reason why the patient will have more severe symptoms over here. Many other symptoms will be mentioned. So what is that symptoms? There's a classical triad which is seen in a case of Boerhaave syndrome. Again, a chronic alcoholic, history of binge drinking, and presenting to you with this classical clinical triad. What is this clinical triad called as? Macular triad. So the macular triad which is seen in a case of Boerhaave syndrome. What are the three important features over here? So please remember, it is remembered by the mnemonic CVS. Okay. So please remember the first one, definitely the patient will have chest pain. Why the patient will have chest pain? Because as the esophagus is ruptured, all the contents of the esophagus will go into the mediastinum. And just like peritoneum, mediastinum is also a sterile cavity. It does not handle any nuisance. That is the reason why जैसे ही खाना बाहर जाता है, it causes inflammation of the mediastinum leading to mediastinitis, and that causes chest pain in the patient. Next important feature, definitely the patient will have vomiting. V stands for vomiting, or sometimes only retching episodes will be there. And S stands for what? S stands for subcutaneous emphysema. As esophagus has what? Air inside. When it will rupture, there will be air which goes beneath the skin. That is called as subcutaneous emphysema. And when you will try to palpate, you will feel a cracking sound. That is what is nothing but crepitus, which is felt due to subcutaneous emphysema. Okay? Now air has gone into the mediastinum, and when air is present in the mediastinum, air in peritoneum I discussed with you, it is known as pneumoperitoneum. It was seen due to stomach or intestinal rupture or perforation, hollow viscous perforation that we discussed yesterday, and that was showing gas under diaphragm or Moustache sign. Just like that, in cases of pneumomediastinum, if I say, in cases of pneumomediastinum, when the air is in the thoracic cavity or the mediastinal cavity, auscultation, when I will auscultate this patient, I will get a characteristic sign. I will hear as if somebody is walking with leather boots on the snow. That is called as the Hammond crunch sign. I'll be able to hear a crunching sound known as the Hammond crunch sign. Whereas, a very important question. Whereas if I take a chest x-ray of this patient, on chest x-ray, I'll get a characteristic sign. I will get an air shadow. This black shadow you can see now. I'll get an air shadow or gas shadow below the heart. And this is what is known as continuous diaphragm sign. So pneumomediastinum on a chest x-ray will be seen as a continuous diaphragm sign. Okay. So that is what is seen. This continuous air shadow between two diaphragmatic domes is known as continuous diaphragm sign. Okay. Now, what is the investigation of choice in this condition? The investigation of choice for a Boerhaave syndrome is definitely a contrast study. Okay, it is definitely a contrast study. Okay, CTA with contrast should be done. CT contrast study should be done. And the contrast is again a water soluble contrast like gastrographin or iohexol. And what should be the treatment? As there is mediastinitis, we need to clean the mediastinum, we need to clean the thorax, and that is the reason why we need to open up the thorax. If we need to open up the thorax, that is what is called as thoracotomy. Plus, if we clean the mediastinum, we were cleaning peritoneum, that was called as peritoneal lavage. If we clean the mediastinum, that is called as mediastinal lavage. And then we will go for either repair of the perforation, we will immediately repair the perforation, or sometimes if there is a lot of infection, we will just leave a drain over there. We will wait for some days for the infection to resolve, and then we will go for a repair. ठीक है, थोड़े दिनों बाद करोगे अगर बहुत ज़्यादा infection है वहाँ पे तो, ठीक है. Next, if I talk about this condition, and what is this? These are two important barium swallows which are given to you. One barium swallow is showing that the esophagus which is there is compressed in some part. This esophagus which is compressed in some part, that is usually due to a subclavian vein which has arisen. Okay, a subclavian vein, okay, which is coming towards the right side and it is compressing the esophagus. Now this subclavian vein, this one which is arising from the left side but going towards the right side, it is arising from the left side but going towards the right side. It is not present in all the patients. It is only present in some of the patients. So it is not a normal finding, it is an abnormal finding. This condition, when there is dysphagia or difficulty in swallowing in the patient due to compression of the esophagus, and why the esophagus is compressed? Due to a abnormal subclavian artery. This condition is what is called as, very important, a previous year question it is, this condition is known as dysphagia lusoria. This condition is known as dysphagia lusoria. So dysphagia lusoria, just remember it is one thing. Here the patient will have difficulty in swallowing and it is due to compression of the esophagus due to aberrant. Aberrant is nothing but abnormal. It is due to aberrant or abnormal right subclavian artery. Okay, it is due to aberrant or abnormal right subclavian artery. Okay, so that's the important thing. Next one that you can see there is again a compression of the esophagus. Okay, this compression of esophagus is due to fibrosis in the esophagus. And this fibrosis is usually involving the mucosa and the submucosa. And this is due to constriction of the esophagus in the mucosa or submucosa due to a fibrotic ring. What is this ring called as? This ring is what is called as the Skadsky ring. Okay, so this is what is known as a Skadsky ring, which is nothing but a fibrotic ring in the mucosa or submucosa of the esophagus. Okay, that also causes dysphagia in the patient. Usually patients are asymptomatic, no treatment is required. But if treatment is required, definitely if the patient is symptomatic, we'll go for a balloon dilatation. Okay, so we'll go for a balloon dilatation. Moving further now, talking about hemorrhages in the patient. If I talk about upper GI hemorrhage and lower GI hemorrhage, what is the difference? So please remember, if there is any bleeding which occurs above the ligament of Treads, okay, if there is any bleeding which occur above the ligament of Treads, that is what is called as upper GI hemorrhage. And if there is any bleeding which occurs below the ligament of Treads, it is known as lower GI hemorrhage. And that has been asked, what is the landmark to differentiate upper GI and lower GI hemorrhage? It is ligament of Treads, which is usually found in the second part of diaphragm, second part of duodenum. Important is, now if there is a upper GI bleeding in a patient, how the patient is going to present to you? The patient will usually have what? Blood in the vomitus, and that is what is called as hematemesis. Okay, or the patient will have bleeding, but that will not come out in the vomitus, that will come out in the stool. So see, if there is an upper GI bleed in the patient and that is going throughout the GIT, so it will be acted upon by various enzymes, various juices. उसके ऊपर बहुत सारे reactions होंगे, and now the color of the blood will change. It will become black, and therefore the stools will become black and tarry. That is what is melena. So melena and hematemesis both are signs of upper GI hemorrhage. Whereas lower GI hemorrhage, if it is there will be appearance of fresh blood in stools, and that fresh blood in stools is known as hematochezia. Okay? Now if I ask you, what is the most common cause of upper GI hemorrhage? The most common cause of upper GI hemorrhage overall is PUD, that is peptic ulcer disease. And which ulcers bleed more commonly? Gastric or duodenal? We know more commonly it is the duodenal ulcers which bleeds, followed by the gastric ulcer. And the most common artery to bleed in duodenal ulcer, we know it is the gastroduodenal artery. All of these are one-liners. Followed by that, if they ask you the second most common cause, okay, it is gastritis. Okay, so in adults or children it is same, PUD usually followed by gastritis. But please remember, lower GI hemorrhage, definitely the cause in adults is different and cause in children is different. The most common cause of lower GI bleed overall or in adults is definitely bawasir. And what is that? Piles, that is hemorrhoids. Okay, whereas if I talk about children, the most common cause of lower GI hemorrhage is nothing else but rectal polyps. Okay, it is rectal polyps. Whereas if they ask you about elderly patient, okay, if they ask you about elderly patient for a lower GI hemorrhage, it is nothing else but diverticulitis. It is diverticulitis. Okay, that's important to be remembered. Now moving further, talking about various causes of upper GI hemorrhage. So here you can see a patient who is a chronic alcoholic, okay, had a lot of beer, okay, he got it in free, therefore a patient had a binge drinking. And after binge drinking, now the patient is complaining of hematemesis. What is hematemesis? Blood and vomitus. What is the likely diagnosis? Definitely my likely diagnosis. Here you can see there is no chest pain, there is no subcutaneous emphysema, there is no Hammond-Krantz sign on auscultation, there is no continuous diaphragm sign on chest x-ray. So this is not a case of Borjas, it should be a case of malarious. Now, okay, so that is how you need to differentiate. It is a case of malarious tear or a malarious syndrome. And here there is a complete tear or a partial tear. Here definitely it is a partial tear in the esophagus. Which part of the esophagus you can see? Mainly it is in the lower part of the esophagus. Mainly in the lower part of the esophagus it is. You can see there is a partial tear which causes bleeding. Which is the most common artery to bleed in malarious syndrome? So the lower 1/3 of the esophagus is supplied by the left gastric artery. So the most common vessel to bleed in cases of malarious syndrome is also the left gastric artery. It is the left gastric artery. Okay, so that's the important thing. Now please remember, that's important. Okay, so here also the patient will have binge drinking, after which they will give a lot of retching or vomiting episodes. Okay, so retching or vomiting episodes, but due to this retching or vomiting, the patient is not having perforation, the patient is only having hematemesis, a partial tear. Okay, what is the treatment? Malarious, please remember, it is usually a self-limiting condition. That means the patient does not require a treatment. But in case if you need to give a treatment, if self-limiting nahi hai, if the patient is still bleeding after a lot of time, then you will go for angioembolization. Okay, investigation of choice, if they ask you, answer is upper GI endoscopy. Okay. And if they ask you treatment, it is self-limiting usually, no treatment is required. But if it does not happen, if the patient is still bleeding, then angioembolization could be done. Okay, so that's important. Okay, next important thing that you need to remember, guys, is this one. And what is this? So please remember, this is what is called as your, here you can see the stomach is appearing as like a outer covering of a watermelon. So this endoscopy is showing you a characteristic appearance of the stomach known as watermelon stomach. And we know watermelon stomach is characteristically seen in which condition? So watermelon stomach is a feature of GAVE. What is GAVE? Gastric antral vascular ectasia. So it is nothing but ectasia. I've already told you what is ectasia. Dilatation. So dilatation of what? Vascular. So dilatation of vessels. So nothing else. It is nothing but dilatation of vessels in the stomach. Which part of the stomach? A stands for antrum. So in the antrum of the stomach. And these dilated vessels will bleed further. That will cause upper GI hemorrhage again in the patient. Okay? So that is what is a watermelon stomach. Important is it more commonly occurs in females. It is associated with some connective tissue disorders. And what is the treatment? Usually treatment can be argon photocoagulation. Okay? Investigation of choice, you know, it is upper GI endoscopy, which is evident here. Okay? No issues with this. Next one, a very important condition. Again, it is a upper GI endoscopy which is given. All of these are spot diagnosis. They give you images and they ask you to make a diagnosis. So this upper GI endoscopy which is seen, you can see here the appearance looks like brain, but it is a upper GI endoscopy. So usually here it is the stomach mucosa which is giving the appearance of brain. Okay. So if appearance of brain is seen, what is that appearance called as? That appearance will be called as cerebriform appearance. That cerebriform appearance, if it is seen in the stomach, it is suggestive of giant gastric rugae. What are rugae? Rugae are nothing but gastric folds. So if these gastric folds or these rugae, when they become huge, when they become giant, they will give an appearance like brain. That is known as cerebriform appearance. And this condition, very good, all of you, it is known as Menetries disease. That is what is called as Menetries disease. Okay. And we know Menetries disease is a condition in the stomach which secretes a lot of mucus, and therefore the patient will have protein losing enteropathy. There will be an excess loss of mucus, and mucus contains a lot of proteins. So therefore a patient will lose a lot of mucus or proteins from the body. Okay, so important is, why it is important? Because it has a high risk of malignancy. That means it is a pre-malignant condition. Yes, Menetries can further become a gastric cancer as well. Okay, so that's the important thing. Yes, bag of worm bhi dekh sakta hai. So pre-malignant condition. Therefore, the treatment is gastrectomy in this patient. Treatment is gastrectomy, removal of the stomach, because there is high chances of malignancy. Then what is this? You can see again, this is upper GI endoscopy which is done in the patient, and it is showing in the lower part of the esophagus. You are able to see these dilated vessels. What are these dilated vessels in the lower part of esophagus? So these are nothing but your esophageal varices. And in which patients do we see esophageal varices? We know that esophageal varices will also rupture and they will also bleed. What were varicose veins or what were varices? Varices का मतलब कुछ नहीं होता है. Varices just means dilatation of vessel and tortuosity of vessel. ठीक है? So varices or varicose just means dilatation and tortuosity of vessels. So here which vessels are dilated? So please remember, here it is not the artery. Okay, here it is the vein. So it is the left gastric vein which is dilated. The left gastric veins are usually dilated, which are present in the lower part of the esophagus. Why? Because it is commonly seen in a patient of cirrhosis, very good, CLD, chronic liver disease, which further develops portal hypertension, and due to portal hypertension, the patient develops esophageal varices. Now, in a case of portal hypertension, varices will form definitely. At what pressure? That is a very important question, okay? So, varices generally form at a pressure of around more than 10 mm of Hg. But when the varices will bleed, the varices will bleed usually when the pressure is more than 12 mm of Hg, more than equal to, okay? So when the pressure is more than equal to 10, varices form. But when the pressure is more than equal to 12, the varices or the vessels will start bleeding in the patient, okay? So that is called as a variceal bleeding. Now important is, if a patient is having esophageal varices, here also the patient will present to you with hematemesis. Here also the patient will present to you with hematemesis. Now a lot of people ask me, sir, how to differentiate it from Boerhaave and Malarivius? Just remember and listen. मैंने क्या बोला था? In Boerhaave syndrome or in Malarivius syndrome, in both the conditions the patient was alcoholic, fine. but they have given you a history of binge drinking, and second, they have given you a history of retching or vomiting episode. How to differentiate between Bohr have and malarious? I've told you. If there is only hematemesis, malarious. But if there is chest pain, subcutaneous emphysema and all those signs, Bohr have. Third important thing. Now, if the patient, they have given a case of chronic alcoholic patient who has developed chronic liver disease. What is chronic liver disease? Nothing but cirrhosis. And we know cirrhosis ka complication can be portal hypertension. And portal hypertension will cause formation of esophageal varices. So if a patient of chronic liver disease is coming to you with esophageal varices without any history of binge drinking, without any history of retching or vomiting, then that is a case of bleeding esophageal varices. Okay? No history of retching, no history of vomiting, no history of binge drinking. Only a chronic alcoholic and a known case of cirrhosis or CLD. That is the case of bleeding esophageal varices. Important is, what should be the investigation of choice? Investigation of choice is again a upper GI endoscopy itself. And what should be the treatment in this patient? So the treatment is usually, we initially try a drug. And what is the drug of choice for bleeding esophageal varices? So the drug of choice for bleeding esophageal varices, important. Please remember, we need to give what? We need to give IV octreotide. Yes, the best drug is terlipressin, but that is not available. So that's the reason why IV octreotide is the drug of choice. Best agent, if they ask you, it can be terlipressin. Important is, if IV octreotide fails, okay, if medical management fails, then definitely we can go for banding. Okay, then we can go for banding. We will put a band at the base of the esophageal varices. Okay, and if banding is not there in option, go for sclerotherapy. But banding is always better than sclerotherapy. Okay, banding is always better than sclerotherapy. Chalo. If they ask you how to prevent esophageal varices from bleeding, that means if there are bleeding esophageal varices, drug of choice is IV octreotide. But what should be done that the esophageal varices should not bleed? So what is the drug of choice for prevention? Okay, so what is the drug of choice for prevention? Then the drug of choice is the oral drug known as propranolol. Okay, so beta blocker known as propranolol is the drug of choice for prevention of bleeding. So the esophageal varices should not bleed. That is what is done by propranolol. Moving further. Okay, so shall we stop over here? Stomach we can continue tomorrow, if or I can continue as well. Please let me know. We are done with esophagus. So let me know once. And we can start early tomorrow around 4 or 5. Okay, I'll inform you the time. I'll discuss it with first, and then if I can start early, then definitely I'll start early so that we can finish. We can take 2 breaks definitely, and then we can finish it off. Let me know once. Hopefully I'm audible still. So please let me know. You wish to continue or we will conclude for today? Shall we conclude? I'll share the PDF, don't worry. Okay, tomorrow. No issues with that. Great. Sure. Thank you so much for attending the session. If you have liked the video, please hit the like button and share it with your friends for their benefit, definitely. Okay, and please comment. Okay, sure. Thank you so much, guys. It was great having a session with all of you.